I welcome our Director and Chief Executive Officer, Dr. Nitin M. Nagarkar, sir. Dr. Nitin M. Nagarkar, sir, is instrumental in the development of Chhattisgarh state, our AIMS rapport, this whole auditorium, this whole setup, this whole financial grant for this conference is all from Dr. Nitin M. Nagarkar, sir. He is always yes for an academic activity. That's myself, who has been chosen as the organizing chairman by Dr. Hemant Chatterjee, sir, and Dr. Prashant Dwivedi. I welcome Dr. Harshal Sakle here. I know that the sequence may be something up and down because of the slides not being in the proper manner, but still, he deserves a great applause because he is conducting this whole conference and working morning to evening. And that is how it changes. The youngers will be coming up, they are splendidly put into line, they get trained, and then they function as good as Dr. Ramesh Sen, Dr. Ramesh Chadda, Dr. Kamble, and others. With us, we have our guest of honor, Dr. Naveen Thakkar, sir. He is a very senior and famous orthopedic surgeon from Gujarat, and he is currently the Honorary Secretary of Indian Orthopaedic Association. He has several patents to his name, and he will be giving a lecture to us on 17th, how to get a patent. So that's great. I welcome you, sir. We have with us our young, our dynamic, our president, Chhattisgarh Orthopaedic Association, Dr. Hemant Chatterjee, sir. It is his vision that this conference is taking shape in this way. I welcome you, sir, to this conference, and I'm very happy of your full-time presence here in this conference. We have with us, with the younger, dynamic, Honorary Secretary, Dr. Prashant Dwivedi. And Dr. Prashant, the name is now, everybody knows in Chhattisgarh, because now it is his second term going as the IMA Chhattisgarh Secretary also. And the depth of knowledge that he has in institutional works as well as conferences and IMA like institutes is wonderful. The whole Chhattisgarh is getting every year 4 or 5 prizes at national level because of Dr. Hemant, Dr. Prashant Dwivedi. And online, we have with us Dr. Umesh Kapil. He's a very senior orthopedic surgeon who passed in 1971 from Raipur, Pandit Jawaharlal Nehru Medical College. He is the observer for today's National Symposium. I welcome you, sir. And then we have Dr. D.P. Bhushan, who is the president of the Central Zone of Indian Orthopaedic Association. And he has taken the responsibility of making all the states together in Central Zone to stand on a platform, and he's taken pains to reach here. You will not believe that he is looking so fresh, but he has come directly from the train after an overnight train journey. I welcome you, sir, here. And I've already told you about Dr. Vikas Agrawal. He is the president, Raipur branch of IMA. And this today's National Orthopedic Trauma Symposium is also under the aegis of Indian Medical Association, Raipur. Because I welcome you here to this. And I welcome my professor and head, Dr. K. Sudarshan, sir, sitting on the first row. Our faculty is Dr. Ram Chadha, who is the vice president and also the president-elect of IUA. He is very senior. When I started my senior residency at Coimbatore, he was the one who nurtured me. And he is here, so I'm feeling very happy. You all must not be knowing, but his father was a very famous physicist as well as film director and actor, Shri Manmohan Krishna. And after 40 years of his services, if you see any of the movies, you find that he is there as a character role. And he was one of my choices. So I feel very happy for your father also and for you also as my teacher and mentor. And I also welcome Dr. Daga, Dr. K.D. Tiwari, Dr. K.D. Agarwal, Dr. Pankaj Dhabalia, Dr. Anil Verma, and faculty sitting here from AIMS Raipur, Dr. N.K. Agrawal, sir, Dr. Arun Madharia, Madam Manisha Ruikar, Dr. Chinmay, Dr. Nitin Kashyap, and many more. If I have not taken the name, but you all are in my heart and I welcome you all. Thank you.
Thank you, sir. I request Dr. Hemant Chatterjee, sir, to kindly give us a precedent message regarding the conference.
Good morning, all of you. On behalf of Indian Orthopaedic Association Chhattisgarh chapter, I welcome you all for this very important Orthopedic State Conference of Chhattisgarh. On behalf of IUA Chhattisgarh State, I welcome our chief guest, the President, Indian Orthopedic Association, Dr. Ramesh Sen sir. I welcome Dr. Naveen Thakkar sir and all dignitaries of the dais. We know with the and the cooperation extended by Dr. Nagarkar, it wouldn't have been possible to arrange such a grand feast of academics in Raipur in a short duration. I really thank you, sir, for your all cooperation. I thank all my seniors and dear colleagues for their presence and guidance, and wish that you would all have a very grand duration of your knowledge and definitely will be benefited with all academics which we have arranged. Thank you all. Thanks for all your coming.
Thank you, sir. I now request our Director and CEO, Professor Dr. Nitin M. Nagarkar, sir, to kindly say a few words.
Thank you very much. First and foremost, welcome to everybody to this wonderful two-day conference. We are meeting after a long time physically as well as in the hybrid mode. So thank you very much for inviting me. Special thanks go to Professor Alok Chandra Agarwal, Dr. Harshal Sakale and the entire team. They have been pursuing for this particular workshop and conference for a long time, and they were waiting for the right time when we can meet. So I think thanks to God Almighty, it has been possible. We are really honored that we have the chief guest, Professor Ramesh Sen. He's been my senior at PGI Chandigarh. I know him since the 90s, early 90s. I remember Professor Gupta, Ashok Gupta, my colleague and senior at PGI Chandigarh. He first introduced me, sir. I had just come from Shimla that time. And he told me that inke naam pe Dr. Sen's angle hai. So I still remember the Sen's angle in orthopedics. And we had a great time after that. We keep meeting each other and discussing how to take the medical profession in general forward, including, of course, orthopedics. So thank you very much, sir. And he's been blessing us all through for the last so many years. Welcome to Dr. Naveen Thakkar from Gujarat. Again, my senior from Bihar as well as PGI Chandigarh, Dr. Dwivedi Pannak Bhushan ji. Dr. D.P. Bhushan has been my senior. I know him for, again, a long time. And he's now presently in Jharkhand. And happy that he's come for this particular conference and he's the president of the Central Zone. My friends, Dr. Hemant Chatterjee, Dr. Prashant Dwivedi, they have been the leading lights for this association here in the state of Chhattisgarh. Dr. Vikas Agarwal, IMA always supporting along with other stakeholders, conferences and workshops that we've been holding. Dr. Umesh Kapil also helps us from NAMS, and I'm happy that he's joined us online. I've seen so many senior people and colleagues here who have gathered today. So thank you very much to everybody. And it's your participation which really makes this conference really worthwhile. And a lot of juniors as well as our medical students, they are definitely going to gain a lot from today's workshop and conference. I was happy to see Dr. Ram Chadha. I don't know whether he'll remember. My school was in, King George in Hindu colony. And I remember his father in a Fiat car. And I would regularly cross him because my family was also, involved with the film industry. So it was time and again, I still remember that circle where his father would drive the Fiat and I would wish him that time. So I think I'm thinking of something 40, 45 years ago. So God bless. So thank you very much. Great time. I'm sure all of
Thank you, sir. Now I request Dr. Prashant Dwivedi, sir, to kindly say a few words.
Since we are already late, I'm not going to take much time. Good morning to all delegates, respected faculties, and all the members and all dignitaries on dais. On behalf of Chhattisgarh Orthopaedic Association, I welcome all of you for this conference, and my special thanks to Dr. Alok Agrawal sir, who has been very instrumental, and in very short time he had arranged such a nice conference, and our director sir Nitin Nagarkar sir, who has been very much supportive, and all the Raipur Orthopedic Society members who have been with Alok Agrawal sir for this conference. We assure that it will be a good academic feast, and it is going to set a landmark conference in Chhattisgarh chapter. Thank you.
Now I request our chief guest, Dr. Ramesh Sen sir, President Indian Orthopaedic Association, to kindly say a few words.
So good morning, friends, respected dignitaries on the dais, Dr. Nagarkar, as he has told, and I'm very happy the kind of a dynamism, the kind of a setup which we get here. And I'm lucky that I have been here also earlier in his directorship also. And incidentally, Raipur, I had visited many times in the last 15 years. I'm thankful to the surgeons here who had given me the opportunity to be here time and again, and incidentally going to all those places. So, and I'm also thankful to you to have given me the position in which I am here today. Respected other dignitaries, Dr. Naveen, Dr. Harshal, Dr. Hemant Chatterjee, Dr. Prashant Dwivedi, Dr. Bhushan, Dr. Vikas Agarwal. I mean, it has been a privilege to be coming to this place. And incidentally, when Dr. Alok asked me, I told him I had this thing, but I'll still definitely, as a responsibility, I'll be here. Maybe because that commitment is also there. So I said him, if you can make the inauguration little early, and I'm thankful to Dr. Alok to have given me this option. And so I know Dr. Alok also from very long time, and I know the organizational ability. I understand that there was an issue with some other city chapter to host it. And so he took the responsibility, and with the backup of our Raipur doctors, they have been able to manage a good show for Chhattisgarh, this annual meeting. I mean, that's a great thing. The great organizational ability and the great ability of the surgeons around that we see this function today. Congratulations for that part. As far as the Indian Orthopaedic Association is concerned, this year we do focus something on a perspective of education research. Yes, we aim every year, but this year we are primarily aiming for with the motto of success with surgical and soft skills. We all know about the skills as a part of our training as an orthopedic surgeon. As a surgeon, we are trying that in the last years, COVID, we have not been able to train our next surgeons also. So we have to fill up a gap at that level, and we need to do something for the continuing education in the technical skills also. We are right on Monday onwards, we are having a course specifically designed 4 days cadaveric course for the training of fresh orthopedic surgeons, those who have otherwise qualified in the skills only. And this, with the help of our other members in the central executive, we have been able to have this course as a starter. We hope that if we are able to provide a high quality course, which should stand as a IOA course, just like a AO course, we can make it as an IO course in which we give a reasonable amount of skills. Yes, we know the actual surgery is actual surgery, but on the way of skill learning between the studying bone models and cadaveric part, we are starting from this Monday. And I hope this makes a landmark statement in the day of today. Then we do hope that in this year, we will have more advanced courses in each of the subspecialty. And I'm happy that we have been able to license with all subspecialties in orthopedics to have contribution into the IOA as their responsible role to develop these surgical skills. And I'm very lucky this year that if you read the word soft skills, looking at the abilities, as important we have hard skills, equally important becomes our cognitive skills of perceptions, of our decision making, all our awareness, and our social skills of having the team leadership, having the teaming quality as such, and having a communication skill. So these are all part. As a surgeon, we tend to manage our hospital, our staff, our patients who have got their respective interactions, and we need to be best in them also when we are doing our surgical skills to the best. So it is a combination of surgical techniques, skills, along with our soft skills, which makes us successful in our venture. And that is what we have a aim for this year as a president's theme. With that kind of a situation and with the kind of a organizational ability which Dr. Alok has shown, we do hope that the backup of our orthopedic surgeons around this area will make up a success with a wonderful faculty. Dr. Alok has been able to get around it, and with the wonderful blessings of Dr. Nitin Nagarkar, I think it will be a great success. Thank you. Thank you all.
Thank you, sir. I now request our next session is for the presentation of President Appreciation Award and special invitees by Dr. Hemant Chatterjee, sir, who is the President of Chhattisgarh Chapter Indian Orthopaedic Association. And I like to specially invite Dr. Ram Chadda, sir, on dais, and Dr. K. Sudarshan, sir.
Welcome to Dr. Ram Chadda sir and K. Sudarshan sir, please. I request Hemant Chatterjee sir to present a special invitee memento to Ram Chadda sir. Thank you, sir. I request Director sir and Ramesh Sen sir to present a special invitee memento to Dr. K. Sudarshan sir. Now it's time for presentation of Special Appreciation Award by
Hemant Chatterjee, sir,
Dr. Hemant Chatterjee sir. I request Dr. Hemant Chatterjee sir to present a appreciation award to Professor Dr. Alok C. Agrawal sir, Professor and HOD, and our organizing chairman. Please. I request I invite Dr. Kedar Agrawal sir on the dais, and I request Hemant Chatterjee sir to present a special appreciation award to Dr. Kedar Agrawal sir. I request Hemant Chatterjee sir to present appreciation award to Dr. Prashant Dwivedi sir, our honorary secretary of Chhattisgarh chapter of Indian Orthopaedic Association. I request our president sir, Dr. Hemant Chatterjee sir, to present the appreciation award to Dr. Ankit Garg. I invite Dr. B.R. Patel sir on the dais, and I request Chatterjee sir to present a appreciation award to Dr. Bodhiram Patel sir.
The next appreciation award after Dr. B.R. Patel is for Dr. Harshal Sakle for conducting this conference. And the last President's Appreciation Award at this juncture is for Dr. Sunil Khemka. He is not here, so the award will be given in next function. Sir, please come on the stage.
Thank you. Look.
Sir. A very good morning to respected dignitaries on the dais and off the dais. Now it's time to felicitate our all dignitaries. I request Professor Dr. Alok Agrawal sir to felicitate our chief guest, Professor Dr. Ramesh Sen sir, President IOA, and our chief guest of honor. Please, sir. I request Professor Dr. Alok C. Agrawal sir to felicitate our director and CEO, sir, Professor Dr. Nitin M. Nagarkar sir. Please. I request Professor Dr. Alok C. Agrawal sir to felicitate Dr. Naveen Thakkar sir, Honorary Secretary, IOA, our guest of honor. Now I request Professor Agrawal sir to felicitate Dr. D.P. Bhushan sir, our President of Central Zone of Indian Orthopaedic Association. Now I request the dignitaries to felicitate our Secretary, Dr. Prashant Dwivedi sir, Honorary Secretary, Chhattisgarh Chapter of Indian Orthopaedic Association. I request dignitaries to felicitate Dr. Vikas Agarwal, President IMA, State Branch.
There is one correction. I am not the president of state branch. I am president of IMA Raipur.
I request all dignitaries to please felicitate our President, Dr. Hemant Chatterjee sir, Honorary President of Chhattisgarh Chapter of Indian Orthopaedic Association. I request dignitaries to felicitate Professor Dr. Alok C. Agrawal sir. I request all dignitaries to felicitate Dr. Prashant Dwivedi sir, Honorary Secretary of Chhattisgarh Chapter of Indian Orthopaedic Association. I request dignitaries to felicitate Professor Dr. Alok C. Agrawal, Organizing Chairman and Head of the Department, Vice Dean Academics, AIIMS Raipur.
And I request all dignitaries to felicitate Dr. Harshal Sakle sir, our Organizing Secretary for the conference.
And with this, our inauguration ends. And we start with our scientific sessions.
National anthem.
We'll have a national I'll request all of you to stand for the national anthem. जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे थैंक यू So dear friends, we'll be starting with our National Symposium on Orthopedic Trauma. The first session is on polytrauma. And the chairpersons are Dr. Nitin M. Nagarkar sir, Dr. Arun Madharia and Dr. K. Sudarshan. I want to inform you people, the director sir is busy with a national meeting and he has to leave. And he will join us fast, but we will start with our scientific function now. Dr. Arun Madharia, Dr. K. Sudarshan, Dr. Manish Raj, please come and chair this session.
So our first presentation of the day is by Professor Dr. Manisha M. Ruika ma'am, and the topic is Epidemiology of Trauma.
Hello all everybody, welcome to the first session. Now I will request Dr. Manish Ruikar to speak on epidemiology of trauma. चश्मा गाड़ी में छूट गया चलेगा
ये जो है ना Good morning, everybody. Respected chairpersons and distinguished delegates. At the outset, I would like to thank the organizers for giving me this opportunity to interact with you on epidemiology of trauma, which includes distribution, determinants, prevention of trauma, and safety promotion. Trauma is damage to the body caused by an exchange with environmental energy that is beyond the body's resilience. There are two types, unintentional and intentional. In unintentional, there are injuries caused by the natural forces and other causes of injury. WHO uses the term injuries and violence for the trauma. It's a major public health problem. All of you are aware. That's why we are here. It takes lives of 4.4 million people each year and constitute nearly 8% of all deaths. The age standardized death rate from injuries decreased from 2010 to 2019 by 19.4%. 90% of global trauma mortality occurs in low and middle income countries. It is responsible for an estimated 10% of all years lived with disability. This is the global burden of disease published in 2020. According to that, the intentional injuries globally are the ninth leading cause of deaths. And in India, it is on the 8th leading cause of death. The ranking remains the same when we come to the DALYs at global level also and in India also. The mortality in men due to injuries from all the causes was always higher in males as compared to females. If we look at the WHO regions, then the most affected region was Africa, subsequently followed by the Southeast Asia. Coming to the accidental deaths in India, based on the National Crime Records Bureau report, the rate of accidental deaths during the last decade in India, this trend shows decline in 2020. The Maharashtra contributed the most in the accidental deaths. When I say accidental deaths here, that includes injuries and violence both together in India. So Maharashtra reported the highest absolute number of the injuries, followed by Madhya Pradesh and Uttar Pradesh. But when we come to the rate of accidental deaths was reported highest in Chhattisgarh, followed by Puducherry, Andaman and Nicobar Islands, Haryana, Madhya Pradesh and Maharashtra, against the national average of 27.7 per lakh population. Traffic accidents was the predominant or major cause for the injury-related trauma. Natural forces were responsible for 2% of the injuries in 2020. Coming to the suicide data in 2020 in India, the suicides were reported highest in the Maharashtra, followed by Tamil Nadu, Madhya Pradesh, West Bengal, and Karnataka. And these 5 states are responsible for more than half of trauma mortality in India. Hanging and poisoning. These were the 2 predominant modes which were adopted by the victims to commit suicide in 2019 as well as in 2020. Coming to the road accidents in India, 2-wheelers accounted for the maximum road accident deaths in 2020, followed by car and truck. If we look into the causes of road accidents, the highest contribution is of overspeeding, followed by carelessness amongst drivers. When we look at the percentage of persons died out of total persons injured, it shows the increasing trend from 2016 to 2020. So this highlights the importance of the healthcare sector in the management of the trauma. This learned house is aware of the pyramid of the injury. So based on the learnings from India, the published articles, I would just like to highlight the trauma care in India. 90% of global trauma mortality causes, like we know that it is in the low and middle income countries. In India, it is described as disorganized, inadequate trauma care. Over 20% of the world's trauma deaths occur in India. Over half of the trauma deaths are preventable. The trend of in hospital trauma mortality in India has remained unchanged in the past decade. In addition to that, India's 30-day trauma mortality rate is twice than that of in the high-income countries. So the low-cost interventions such as airway management, fluid resuscitation, hemorrhage control, and surgical decision-making protocols were identified as opportunities for improvement based on our own studies.
Madam.
We are aware about the prevention and control, in which the determinants of the accidents or the injuries are important. So alcohol and substance abuse, inadequate adult supervision of children, economic and gender inequality, lack of safety in inbuilt environment, inadequate product safety standards and regulations, easy access to alcohol, drugs, firearms, knives, and pesticides, weak social safety nets, frail criminal justice systems in India, inadequate institutional policies to address injuries, and weak emergency trauma care services are the determinants. Subsequently, WHO has published these evidence-based measures to reduce risk. All of us are aware of all these measures which are evidence-based. Knowledge is not a problem. Application of the knowledge is the problem. So let us commit to the use of the brainstorming tool, that is Haddon's matrix, when dealing with the reduction of the injuries and the promotion of safety as far as injuries in India are concerned. Thank you so much.
Thank you, madam. It was a nice talk. Now I request Dr. Chinmay Kumar Panda to give his talk on polytrauma and need.
I request the chairpersons to kindly present a memento to Manisha ma'am.
We are getting to the definition of polytrauma. So to objectify the trauma, we have to go on some scoring system. And aim of this scoring system is to gauge the trauma severity and calculate the survival probability. And also it helps in the effective patient care, triaging, prognostication, clinical research, and reimbursement purposes by the insurance companies. And the expected outcome is improvement in the trauma care. It saves time as well as money, mortality benefit is there. So ideal scoring system, what we say, has to be validated, has to be calibrated properly, adequately calibrated. That is, the calculated mortalities should go near about the actual mortality. And there should be a good discrimination power in between the survivors and the non-survivors. And it should be reproducible. That is, it should have the ability of closeness to the agreement in different setup of measurements. So the different scoring systems broadly classified into anatomical, physiological, and combined. Under anatomical, we will be discussing about the abbreviated injury scorings, injury severity scorings, and the new injury severity scorings, anatomical profile, and international classification of diseases for the injury scoring. And physiological system, as we all know, that is Glasgow Coma score and revised trauma score, Apache scorings, and the others. And the combined scores is a combination of anatomical and physiological scoring, which comprises of TRIS as well as the Ashok system. So now let us come to the anatomical scorings. First is abbreviated injury scoring, which is developed by the Automotive Safety of American Medical Association in 1971. And it included the orthopedic trauma in 2004. And the current update has been done on 2015, which has got a 6-point ordinal scale, 1 being the minor and 6 being the lethal one. And this is how the scoring was going on with the ordinal scale. And the AIS dictionary contains 9 chapters in which all the body regions are divided into 9 chapters and has been assigned a number to it. For an example, if we are having a femoral shaft fracture, then it is provided a code, that is a 6-point pre-dot code and a 1-point post-dot code. The post-dot code is about the ordinal scale. If we go for the example, then the first 8 number is actually for the body region, that is the lower extremity, and the 5 for the type of anatomical structure, that is skeletal. The 1-8 goes for the specific anatomical structure, that is femur, and 14 goes to the level of injury, that is shaft of femur. And the 0.3 is the AIS severity scoring. And also the NFS is given in the dictionary in various articles, like which is not for the specified. That is, we didn't get any detailed information for the trauma. And the exceptions also are there in this AIS scoring, because in head chapter and spinal chapter, we will be going for the different type of lesions. So accordingly, the exceptions were there. And this abbreviated injury scoring doesn't calculate the preliminary diagnosis and the complications and the consequence or the outcome of the trauma. The advantage of being it sets for the basis for different type of scoring systems, and also it calculates the relative risk to the threat to the life. Also, it is not void of any limitation, like it has a lack of internal consistency and it cannot predict the mortality. The next scoring system is injury severity scoring, which is developed by the Becker et al. In 1974, which has divided the body region into 6 parts instead of 9. And AIS 6 in any body part is equivalent to ISS score of 75. Let me tell you about the ISS scoring is measured from 0 to 75. And the 6 6 body regions are shown over here. I'm not going into the details of this, but how to calculate this is the top 3 most severely injured body systems are taken into account, like A, B, C, and the squaring of this and adding of this will give you the ISS scoring. So how it helps us? It actually helped us in research purposes, and also it predicts the mortality and morbidity and the outcomes and the hospital stay outcome. And the limitations are like any error in calculating the abbreviated injury scoring will cause an error in the ISS, and it cannot be used for the triages because of the complications of calculating this. Age and comorbidity has not been considered, which is actually a measured contributor for the trauma morbidities. Next in line is the new injury severity score, where actually what they have done is they have, regardless of the body reason, they have just calculated the topmost 3 injuries in various organs and summed up this squares. And this gives us the new injury severity scoring. The advantage of this is over the ISS is if there is a single organ injury also, we can square it, the different injuries to the same compartment. We can square it up and add it up and give the result. And it also gives us the statistical beneficial over the ISS scoring. It also predicts the need for the intubation and mechanical ventilations, and generally it is consistent with the surgeon's criteria and instinct for the surgery purposes. Next, we'll come to the physiological scoring system. We all know about the Glasgow Coma scoring system. I will not go to the individual parts. We know it comprises of 3 parts: eye-opening response, best verbal response, best motor response. And the scores is calculated from 3 to 15, and it has been taken in various guidelines like ATLS, ACLS, BTF, that is British Trauma Foundation, Apache scoring, and SOFA scoring. And it is also widely adopted by more than 75 countries. The modification has been done after 40 years in 2014, in which they have just changes some commands so that it will be well appreciated by the nursing staffs. The eye opening in the second scoring, it has been changed to from pain to pressure. And in the verbal response, we can see the inappropriate words and incomprehensible words has been deleted, and it has just reduced down to sounds and words. This is the pediatric Glasgow Coma scoring, where there is. Please, is it?
Please sum up your.
Okay. Actually, we are just at the physiological scoring basis. Sorry, actually, we are running out of the time. So let us just summarize to the last part, where actually we are having why we are doing this scoring system is to calculate the survivability prediction. So escort scoring is the best scoring system, which is the combined scoring system, and which is better than the TRIS and the revised trauma scoring system, and NISS as well as the ISS. So this is all about my talk. If at all we have time, then we could have discussed about this. Thank you.
Thank you, Dr. Panda. Please collect your memento. Look. Dr. Panda, please collect your momentum, please. Okay. Next.
Thank you very much, Dr. Panda. Now I'll request Dr. Sanjay Rawat to speak on his subject. Thank you.
Good morning, everyone. Today I will be talking about triage and its relevance in orthopedics. So the history of triage originated in the military. In World War I, it was used first by French army for treating the injured soldiers. So the triage word is derived from the word trier, which means to sort or to choose. The goal of triaging is to assign treatment priorities with limited resources and to categorize the patient according to their need for medical care, irrespective of their order of arrival. During the World War time, the goal of triaging was to return as many soldiers to the battlefield as quickly as possible. So priority was given to treating wounded soldiers who were able to fight again on the battlefield. But at present, this is used for a different thing. Now, initially it was meant for the mass casualty or disaster situations only. But with increasing patient load in hospitals, now it's being accepted as a routine method in emergency department. So any patient presenting in emergency department could either be those who will die with no matter what, or those who will do well at present and no matter what we do, or those who will benefit from the acute intervention. So our aim is to identify this third category of patient who will benefit from the intervention. So the aim of triage is to treating the sickest patient first. Secondly, to evacuate them to the most appropriate care facility in priority order and timely. And then maximizing the use of our available resource for maximum patient benefit and aiming for minimum time to definitive treatment. The challenges associated with triage are placement in triaging category does not imply diagnosis, nor does it imply the lethality of the condition. And it's a dynamic process, so it's required to be repeated after some time, as the patient status can change rapidly. For example, a patient presenting with a shaft of femur who is like stable at this present, but could develop a fat embolism syndrome and deteriorate rapidly. Other challenges associated are infrastructural developments are needed for the emergency department for doing triage. Developing public trust in the system and awareness, as the patient in non-resident categories may need to wait long periods of time, while patient may who have presented later, but with condition perceived to be more urgent, are seen before them. So triage starts as soon as the patient enters the room. We follow the ABCD protocol only. So for airway, we look for abnormal airway sounds, stridor, wheezing, grunting, inability to speak. And if in a case we suspect cervical spine injury, then we stabilize the patient by manual inline traction. And if we need to intubate the patient or maintain the airway, then we will use jaw thrust in place of extension of cervical spine. Then coming to breathing, we look for cyanosis, dusky skin, use of accessory muscles, nasal flaring, respiratory, and saturation. But for orthopedic point of view, we also need to look for a patient like a shaft of femur who might develop ARDS at any point with fat embolism, or if any injury in upper limb extremity, should also screen for chest injuries which could be accompanied with it. Coming to circulation, altered skin signs like pinpoint rash or pedicle rash which are present in case of fat embolism on the chest, head and neck area. Pale flushing, pulses in 4 extremities, BP or uncontrolled bleeding. So if a patient presents with A and B stable, component okay and still in shock, then we should suspect any pelvic or abdominal injury for occult bleeding. So fractures with vascular injury, pelvic fracture with bleeding, or amputations or other mangled extremities are present. So for a patient who we suspect anything, so we should control the hemorrhage by tourniquet, using tourniquet or ligating the vessels. So in cases of pelvis where we can't stop the bleeding as such, we need to use sometimes digital subduction angiography for that. So for D, it comes to disability, which is for looking for neurogenic effects of this.
Please speak closer to the micro.
Coming to disability, we need to look for the neurogenic components of the injury. Like first, we'll see the neurological involvement distal to the fracture site or for an orthopedic patient. For a general patient, we will look for orientation. A patient is GCS level, and for the loss of consciousness present is there. As associated head injuries may cause decreased GCS, and cervical spine injury, especially upper cervical spine injuries, are associated with the brain damage. And bladder involvement should also be looked in these spinal injury patients. Coming to exposure and environmental control, we should completely expose the patient for looking for the other injuries which could be missed. So undress the patient completely, but prevent hypothermia. Log roll the patient and check for the spine injuries. To check for bruising, any laceration or lesions like Morelli lesions, which could be missed along with the sternum fracture. And to look and examine for compartment syndrome or any other dislocation present. So finally, patient is triaged into different categories, which is red for Red are the patient which requires immediate treatment. Yellow are the patient who requires observation but at stable at this point. Green are the patient who are with minor injuries and could be addressed later. Black are the patient who are already diseased or who have extensive injury and whose chances of survival are very bleak with the given level of care available. So across the world, different triage systems are available. But the universal goal of triage is to supply effective and prioritized care to patient while optimizing resource usage and timing. So different level triage system are available, which are 2, 3, 4, 5. For example, 2 level triage system is used in the CHC or district level where patients are categorized into emergent or non-emergent. But in a medical college system where we use 3 level system for like categorizing the red, yellow, green. 4 and 5 levels are most commonly used in the US and Europe systems. These are few examples of different triage system of using 5-level system, that is emergency severity index used in USA, Australian triage scale used in Australia, Manchester in England, and Canadian triage and acuity scale. This is the AIMS triage protocol developed by AIMS Delhi. They categorize the patient into red triage category according to the altered physiology or time-sensitive conditions like acute chest pain presenting within less than 24-hour duration, or limb weakness presenting within less than 24-hour duration, or any acute limb ischemia less than 48-hour duration. So they also classify in yellow after with a patient with normal ABCD but requires further observation, and green patient with normal ABCD but with minor injuries. These are few examples of the cases in which orthopedic condition would be categorized into red triage. For like bilateral femur fractures, major crush injuries, mangled extremities, vascular injuries, compartment syndrome, open long bone fractures, fracture pelvis, and traumatic amputations. This is the copy of the AIMS Raipur triage form that we use here. We follow that same ABCD, and according to the finding, we categorize the patient into red, yellow, and green. While examination, simultaneously interventions are done. So now there is upcoming outcome, which is reverse triaging. This is a method to rapidly increase inpatient capacity by identifying hospitalized patients who do not require major medical assistance. So it could be a response to overcrowding of emergency departments. So as it gives priority to emergency department patients with urgent need over inpatients who can be discharged with little to no health risks. And now during epidemic time, there is a new term is coming in line, that is OPD triaging. So OPD triage helps in better management of patient in heavily loaded government OPD setups for proper utilization of skill, expertise, and time of senior faculty. It also helps in proper data maintenance and increasing patient satisfaction. So like in COVID-like situation where you can't attend every patient and doesn't have resources to manage all patients, OPD triage is very useful. So the take-home message is like we should follow the ABCD approach for every patient. Time is the essence, and we should not like more than 3 to 5 minutes for completing a patient's triage. We should treat the condition which is greatest threat to life first. So, and in every hospital, emergency department must have their well-organized triage plan to tackle mass casualty, disaster scenario in the hospital. And pre-designated triage team should be there, so which are being trained of all the staff to be pursued in every hospital. Thank you.
Thank you, Doctor. Now, I request Dr. Vivek Thika to speak on his damage control in orthopedics.
Okay, good morning, everybody, and thank you, Dr. Alok, for inviting me here. My talk is on damage control orthopedics and where does it fit in. What is damage control? Technical term, tactical approaches which permits a damaged sea vessel in the naval battle to continue functioning. This was the USS Cole, and what they do is they just temporarily stabilize it so that they can take it somewhere and then repair it to the best. So what is damage control? It is the capacity to absorb damage and maintain mission integrity so that we can live another day to fight another battle. Started in abdominal surgeries. But in orthopedics, it has come from the naval centers to the surgical centers and then to the orthopedic trauma concepts. What does damage control mean for orthopedics? It is the delay of definitive fracture repair until a time when the overall condition of the patient and the physiology can be optimized. You use minimal surgical techniques till then. It cannot be an excuse for delaying emergency treatment. However, you do not do the definitive treatment till the patient is stabilized. So where do we focus it? It is in control of hemorrhage, management of soft tissues, provisional fracture stability, avoiding additional insults. There's a first and a second hit concepts, which first hit is the injury which stimulates the inflammatory markers, and the second hit is a surgical intervention. So we have to titrate the second hit, which is the surgery, in such a way that it does not cause hyperinflammatory syndromes. And that's why we do the second hit or the surgery at a time when the patient's condition is the best and will not deteriorate. What do we do in damage control? It's stabilizing the anatomy till the physiology can improve. If we just remember this, the thing can be very well written and understood. We stabilize the anatomy till the physiology improves and prevent the second hit. Where do we do it in orthopedics? We do it in polytrauma situations where the chest is bad, we have brain injuries and acidosis. And sometimes in casualty, mass casualties where the disasters are there. How do we decide which patient needs damage control? We need to look at shock, his lactate levels, and his INR, which is coagulopathy. We also need to look at whether he's hypothermic or not, and if he is resuscitation, he's responding to it or not. If he responds to the treatment which we are giving in the emergency, we can go ahead with doing an early total care, which is definitive fixation right in the first go. So these are the parameters which we look. ABG, oxygen, hypothermia, temperature, INR. These are the 2 or 3 main important things by which we look at whether the patient should be operated immediately or we wait till he improves. So what are the categories? We know these are the categories, the stable, borderlines, and the unstable and extremists. It's the borderline which is the one which can go into damage control or early total. The other ones have straight away defined, well-defined criteria for management. So again, I would repeat, look for hemodynamic stability, core temperature, lactate levels, coagulation profile, and then decide. How many of us have got a fracture shaft in a young adult? We operate, do an interlock nail, and he goes to ICU with his chest condition. What we have missed is his shock levels, his hemodynamic status, and his lactate levels, whether the acidosis is there or not. So these were the physiological and the concepts of damage control where we should be using them. But how and when we are using it in orthopedics. So here comes what we do. We stabilize it in borderline cases which are not responding to resuscitation or are just on the threshold. If we remove the resuscitation, they dip down. Those are the conditions and the persons where we do damage control. We just stabilize them with a fixator or even a simple traction, but we are not doing a major intervention and a full surgical procedure onto them. We optimize him, make sure that his acidosis is improved, he is not in shock, his temperature is okay, and his coagulation profile is okay. Nowhere I'm saying hemoglobin, sodium, potassium, or other things which anesthetists must ask. We are just looking at 3 things: lactate levels, temperature, and INR. If he's improved, you go ahead and do the surgery. And then you do the definitive management. He's a patient, our own patient, came referred after 1 day, bilateral femur with blunt trauma. A lot of shock situation, BP was less, had intubate, needs intubation with mechanical ventilation. ABG done, shows pH of -7 or 7.2, lactate of -5.8, 5.8, base excess of 6.8. So it's a clear cut. Above lactate levels, above 4 means it's acidotic. Hence, we had to do damage control measures for him. Why he was why was he in shock? was because he had some abdominal thing which was missed initially. We had to do his diversion colostomy by the surgeons, and at that time we did his damage control with a fixator. And once he improved after 7-8 days in ICU, then definitive fixations were done to him and he went back. Okay. So this is how we decide why to and when to do the surgeries. Again, what are the endpoints when we think that this person has to go for damage control or not are these. And this is again the same which I have told you. Pelvis fracture, we always do damage control, but we do not give it a term. We are putting in external fixators, that is damage control for the patient. And we then operate upon 4-5 days when his situation improves. Then why not we look for a fracture shaft femur with lung injury as well and do that? That's the main cause of medical legal cases in my hospital or in my area is young patient with shaft femur develops ARDS, goes to ICU and dies. And that creates havoc among patients. Preperitoneal packing, that's also damage control. You do the fixation first as an external fixator I have shown, and then subsequently after 4-5 days fix his acetabulum or the pelvis. We also do that not only in polytrauma, but also in the limbs, like vascular, compartments, proximal tibia. How many times you put in a fixator for the soft tissues to heal and then operate? Similarly for pilon fractures, we put in a fixator. Once it improves the soft tissues, then we operate. So damage control can be for the entire patient's physiology or for the physiology of the limb. And both the places orthopedics we can play a part. So the take home, it's a sensitive and a reliable way of treating patients at high risk to develop clinical complications, organ failure and death. We do not want to save the limb while making him die. Hence we do damage control, and it can be applied both to multi-trauma patients and to severely traumatized single extremity. But remember, it's not an excuse to delay the surgery which is required for the patient if his condition is right. Thank you.
Now I request Dr. Nand Kishore Agrawal to speak on the anesthesia management of polytrauma.
Hello. Good morning, everyone. Thank you, Dr. Alok Agrawal, for giving me opportunity to present management of shock in polytraumatism. Before I start with the presentation, I would like you to think how much body fluid your body have, how much blood volume your body have. If I will be able to answer this question, it will be very beneficial for managing trauma, particularly for orthopedicians. So let us begin with the presentation. No total body fluid, objective of the presentation, to manage hypovolemic shock, volume of the fluid to be given, and washer pressures of choice. Worldwide killer age is 18 to 40, third most commonest cause of death, economic and social loss, and very low budget by the governments. Definition is situation entailing severe blunt trauma with injuries to multiple organs. Two major systems are one major system or two major limb. Two major systems are one open grade skeletal injury or unstable pelvis you define as the polytrauma. Types of shock, there are around 8. Most important we want to discuss today is hemorrhagic, hypovolemic, or traumatic, or septic shock. How to diagnose? A low blood pressure, less than 90 millimeters of mercury, a low urine output, less than 30 ml per hour, and high lactate level, more than 2 millimole per liter. You can label the patient as in hemorrhagic shock. Aims, the aims of management are to save life, first, most important, to save life, second, and to restore the function to the normal previous injury. Steps of management: primary survey, resuscitation, secondary survey, definitive care. The team, always we should work in team in trauma, comprised of anesthesiologist, general surgeon, neurosurgeon, orthopedic surgeons. We should do it fast. We don't have time. Evaluate it fast, discuss, decide, perform. Basic philosophy of management is to manage airway, give CPR, have secure IV line, give splints, and do primary survey. Follow golden rule of golden hour time and platinum 10 minutes rule. Primary survey, ABCD should be followed judiciously. Airway, look, listen, and feel. Look for movement, foreign body, retraction, deformity. Listen for airway sound, stridor, gurgling sound. Feel for fracture, hematoma. As you work more and more in trauma, you are accustomed to get these things done within 60 seconds. Breathing, look for breathing, whether there is any cyanosis, tachypnea, paralysis. Listen for the sounds. See for the chest deviation or emphysema. Circulation, assess the circulation. You can assess it by skin color, temperature, moisture, by the level of consciousness, as other speaker said, Glasgow Coma scale, and assess the urine output. Causes of severe bleeding may be vascular injury, liver injury, spleen, thoracic, long bones. Most important, the blood loss with the different fracture rib 120 ml, fracture radius ulnar 250 to 500 ml, humerus 750 ml, tibia fibula 500 to 1000 ml, femur 1000 to 200 ml, pelvis, it may be massive loss. We should judge the blood loss as per the fracture. Even though there may be normal BP, but we should think the patient have this much blood loss if the patient have any fracture of the secure IV line with 16 to 18 gauze. And if you are not expert in securing IV line, you can go for other things like at our time we used to do venous section. That is not nowadays not common because all are accustomed with the putting PICC line. So anyhow, you have to secure the IV line first. To use isotonic isoosmolar fluid, preferably ringer lactate, plasma light, and many people use normal saline, but normal saline has very little role. Best fluid is ringer lactate. Initial fluid therapy, give 500 to 2000 ml of ringer lactate immediately, and if the patient is children, give 20 ml per kg as a bolus. The most important part of my presentation is the body fluid compartment. We have 60% of the body weight as body fluid. And if you calculate it for a 70 kg, you will be surprised to know that our body fluid blood volume will be 4.9 liter, interstitial fluid will be 10.5 liter, and intracellular fluid will be 28 liter. Total is 42 liters if you are a 70 kg person. The most why I have presented this, whenever there is a hemorrhagic shock occurs, blood leaves from the intravascular compartment. What happens? The intracellular fluid shifts to the interstitial shift to the intravascular. That's why body to try to compensate the BP. And if BP falls below 90, means you must think that already the fluid from the different compartment has shifted to the intravascular. So you have to give a large volume of fluid. Circulating blood volume for male is 76 ml, female is 67 ml, and children is 85 ml. So this is the most important. 70% of the body weight is your blood volume. So always whenever you have the patient, as per the body weight, calculate the circulating blood volume. Fluid should be given as per the three part of the fluid for one part of blood. These are the vasopressor, dobutamine, norepinephrine, dopamine, epinephrine, phenylephrine can be used. Most commonly used nowadays is norepinephrine. Atropine, if the patient has bradycardia, heart rate below 50, irrespective of anything, you can go for giving 0.6 to 1.2 milligram of atropine. Colloids, it should be used cautiously because the function of the colloid, when they are given, they shift the fluid from the intracellular and interstitial compartment to the intravascular. So unless you give 1 liter of the fluid, you should not use colloid. Personally, I like to use colloid for any patient with hemorrhagic shock. ECG, urinary catheterization, and X-ray can be done. And this is the end of the primary survey. Hemodynamic, patient is stable, normal SP2, lactate is less than 2 millimeters per liter, urinary output is coming normal, and normal body temperature will be the end of our survey. Summary: to secure IV line first, give fluid, Follow ABC, give vasopressor non-adrenaline 0.2 to 30 microgram per minute, and give blood if available. And please to wear helmet and seat belt for your safety. Thank you.
Nice.
Thank you, Doctor. Now I request Dr. Nitin Kashyap to speak on management of chest trauma.
Thank you, Chairperson. Senior faculties. My topic for today's presentation is management of chest trauma. I am Dr. Nitin Kumar Kashyap, Associate Professor in Department of CTVS. Motor vehicle accident is the most common cause of thoracic trauma in the emergency department. It accounts for 10% of all trauma admissions. Of all death caused in relation to chest injury, accounts for 25% of mortality. There is a role of surgery in 10 to 15% of cases. It's one of the important factors, total mortality and morbidity in traumatized emergency patients. Anatomy, mediastinum is anatomic division. It extends inferiorly from diaphragm to up to superiorly to thoracic inlets. Its border include sternum anteriorly, vertebral column posteriorly, and bilateral pleura laterally. It contains heart, lung, esophagus, trachea, aorta. Any injury to such vital structures can be life-threatening. Thoracic trauma can be blunt, penetrating. It can be life-threatening or stable. Severity of injury depends upon the strength and duration of impact, acceleration and deceleration injury, and compression damages. Types of thoracic trauma, it can be skeletal, rib fractures, sternal fractures, scapular fractures, pulmonary injuries, pneumothorax, hemothorax, pulmonary contusions, tracheobronchial injuries, cardiac and great vessels, aortic injuries, cardiac contusions, diaphragmatic injuries, which includes herniations. Assessment in thoracic trauma, initial assessment and resuscitation follows the basic principle of ATLS. Primary survey is used for identification of life-threatening injury. Secondary surveys include detailed history, physical examination, and targeted diagnostic studies. The ABC method, airway, breathing, circulation, disability, exposure. There is one caveat in this principle. In patient with respiratory distress following chest trauma, breathing takes priority over airway in cases of tension pneumothorax, where ICD insertion should be done prior to endotracheal intubation. Fast examination, including thoracic evaluation, EFAST is mandatory during initial evaluation. Remember this lethal 6 during initial assessment and resuscitation, tension pneumothorax, massive pneumothorax, open pneumothorax, flail chest, cardiac tamponade, and airway obstruction. There are some hidden 6 like aortic rupture, blood cardiac injuries, tracheobronchial injuries, lung contusion, diaphragmatic herniations, and esophageal perforations. I would like to highlight some important common problems like rib fracture. Common rib fractures usually from 3rd to 8th rib. First and second rib are well protected from clavicles. They require high velocity injuries. Any level of rib fractures, the risk of pneumothorax and pulmonary contusion exists. More than 2 rib fractures at significant risk of complication like pneumothorax or pneumonia. The cornerstone of rib fracture management is pain control. Flail chest, fracture of more than 2 adjacent ribs at 2 different locations produces thoracic instability with paradoxical motion, underlying pulmonary parenchymal injury. Elevated respiratory efforts, dyspnea, hypoxemia can be life-threatening. Initial treatment is obvious, oxygen supplementation, good analgesia, and close monitoring of flail chest for early stage of respiratory compromise. Most of time, non-invasive positive pressure ventilation by mask may obviate the need of endotracheal intubation. One should consider rib fixation for more than 5 rib flail requiring mechanical ventilation or in symptomatic non-union or severe displacement found during a thoracotomy. Pneumothorax, injuries of lung or thoracic wall can create a pleural injury, collection of air in the pleural space, which is associated with collapse of lung. The closed form or a small pneumothorax is mostly inconspicuous. Thoracic drainage should be performed except in asymptomatic patient with occult pneumothorax where close observation can be done. Tension pneumothorax, amount of air in pleural space increases, the loss of air is impaired or impossible due to a wall mechanism. Tension pneumothorax is purely a clinical diagnosis. It reduces the cardiac output by displacement of mediastinal structure and the lungs and reduce the venous flow to the heart. Treated with immediate decompression of pleural space, needle decompression should be done in hemodynamically unstable patient. Formal tube thoracostomy can be done once patient reaches an appropriate setting. Needle thoracotensis, technique of last resort during hospital and trauma reception. It has a significant failure rate, delay in providing formal pleural decompression caused due to incorrect needle placement or kinking. Use large bore cannula, 14 gauge, 16 gauge needle or angiocatheter. Skin is punctured just above the third rib inserted intercostal mid-clavicle line. Now, ATLS recommends the insertion of needle in mid-axillary line, fifth intercostal space, 4 to 5th intercostal space here, with a very good success rate. Open pneumothorax occurs when air accumulates between chest wall and lung as a result of open chest wound. The larger the opening, the greater the degree of lung collapse and the difficulty of breathing. Simple treatment is sterile waterproof dressing secured on 3 sides to act as a filter wall. Tube thoracotomy should be placed away from the open wound. Hemothorax or hemopneumothorax, there is always a source of massive bleeding, aortic rupture, like myocardial rupture, injury to hilar structure. Other source can be memory bleed or intercostal vessels bleed. Thoracic drainage is the therapy of choice. Drainage and quantification of blood is necessary. Removal of possible coexisting pneumothorax and tamponade of bleeding source. Lung contusion is most frequent intrathoracic injury resulting from blunt trauma. Isolated lung contusion are benign. In early phase of injury, impairment of oxygen seems to correlate with involved lung tissue. Clinically, gas exchange impairment is obvious. In one third of time, initial X-ray doesn't show any signs of lung contusion. Thoracic CT scan or blood gases are better indicators for grade of lung contusions. Management, sufficient pain management in form of analgesic, regional anesthesia, intercostal blockade, pleural catheter, thoracic epidural catheter, paraventricular importance, physiotherapy and pulmonary is always helpful. Positive pressure ventilation again also helpful. Impaired gas exchange, hypoxemia, respiratory distress needs intubation and mechanical ventilation. Subcutaneous emphysema, usually benign and self-limiting, with result from air injury and lung injury. It does not require treatment. The underlying injury must be addressed. If positive pressure ventilation is required, the tube thoracostomy should be considered on the side of subcutaneous emphysema in anticipation of pneumothorax, specifically Triage pneumothorax. Chest tube insertion, the optimal size depends upon the leakage rate. Tube 28 to 32 inches is normally sufficient for adult patient. Insertion should be done on the triangle of safety, 4th and 5th intercostal space. Rule of surgery, either doing a resuscitative thoracotomy or formal standard thoracotomy. Indications, massive hemothorax, more than 1500 ml blood return on insertion of chest tube, ongoing blood loss, more than 200 ml for 4 hours, evidence of cardiac tamponade, penetrating transmediastinal chest wound with unstable hemodynamics, chest wall disruption, impalement of wounds of chest, massive air leak, pedestrian hematoma, radiography of blood vessels with unstable hemodynamics. Take-home messages: avoid underestimating blood. Pulmonary injury severity can present as a wide spectrum of clinical sign, often not correlated with chest X-ray finding. Aggressive pain control without respiratory depression is the key management principle. Careful monitoring of ventilation, oxygenation, and fluid that is required. A simple pneumothorax should not be ignored or overlooked. It can progress to tension pneumothorax. A simple hemothorax not fully infected can result in a retained clotted hemothorax with lung entrapment, or if infected, can develop into empyema. Thank you. Thank you.
Thank you, Dr. Kashyap. Now I request Dr. Debajyoti Mohanty to speak on abdominal visceral trauma.
मंच पे बैठे हुए डिग्निटरीज, सारे डेलीगेट्स को मेरा सादर प्रणाम. डिपार्टमेंट ऑफ जनरल सर्जरी और एम्स रायपुर की तरफ से आप सबको अभिवादन। ये कॉन्फ्रेंस बेसिकली हमारे ऑर्थोपेडिशियन कोलीग्स के लिए है और हमें थोड़ा सा साइड रोल के लिए बुलाया हुआ है। तो मेरा ये कहना है, पहले बहुत दिन पहले राज कपूर जी की एक मूवी आई थी हिना करके, जिसका एक टैगलाइन था गॉड मेड लैंड एंड मैन मेड बाउंड्रीज। तो उसी हिसाब से हमने मेडिकल साइंस में बाउंड्रीज बना दी, सर्जरी ऑर्थोपेडिक्स। बट जब कोई पेशेंट को ट्रॉमा होता है, वो एक्सीडेंट में हो या फॉल पे हो, तो वो बाउंड्रीज नहीं जानता, वो अस्पताल में आ जाता है। तो हम सारे लोग जो भी हैं, हमारे वेरियस डिपार्टमेंट्स के हैं, सबको मिलके काम करना है और थोड़ा बहुत ऑर्थोपेडिक्स को छोड़ के भी बाकी चीजों के बारे में थोड़ा सा नॉलेज होना चाहिए हमें। तो उस बारे में कहाँ रे उसके लिए तो थोड़ा सा हमें जो अब्डोमिनल ट्रॉमा जो है, विसरल इंजुरीज, वो हमें थोड़ा सा उसके बारे में थोड़ा नॉलेज होना चाहिए। मैं कोई डिटेल में नहीं जाऊंगा, बेसिकली एक ऑर्थोपेडिशियन के हिसाब से कुछ चीजें जानना है और बेसिकली हमारा यही रहता है हमेशा एम, हमारे पोस्ट ग्रेजुएट स्टूडेंट्स और हमारे रेसिडेंट्स वो अच्छे से पेशेंट इवेलुएट करें। तो कैसे अप्रोच करना है इन पेशेंट को, इनके बारे में थोड़ा बहुत मैं बताऊंगा। जैसे ही हम इमरजेंसी में काम करते हैं, तो एक ऐसे ही एक पेशेंट सिनेरियो, कई बार एक ऑफ दिस पेशेंट ऐसे आ सकता है कि एक पेशेंट को बाइक एक्सीडेंट के बाद इज रिपोर्टेड टू द कैजुअलिटी अराउंड 30-40 आवर्स लेटर एंड उसको चेस्ट, abdomen, pelvis सब जगह पेन है। When we see the pulse rate, it is around 120, blood pressure, respiration rate apparently normal and GCS is also normal. तो जब हम पेशेंट देखते हैं, we get a somewhat picture like this, a pelvic trauma हमारा पेशेंट थीम है, तो इस पर एक फोटो लगाया हुआ है, तो एक पेशेंट है। तो जब ये पेशेंट देखते हैं तो हमारे पास दो इश्यूज हैं। What are the injuries that we need to suspect? And once we suspect, how will you manage this patient? These are the two basic questions that comes to our mind when we see such a patient. To achieve these two or answer these two questions, we need certain objectives. We need to have certain background knowledge. वो क्या है? कि what are the key anatomic regions of the abdomen and the pelvis? We have to recognize the risk of associated abdominal visceral injury based on the mechanism of injury. We have to choose any appropriate imaging technique if it required. And most important, we have to identify these patients who will require surgical intervention. So coming to the first objective, so when we evaluate or see a patient, these are the three areas of the abdomen called the anterior abdomen, flank, and back. So how will you differentiate? The upper part of the anterior abdomen starts from the transnipple line. The lateral boundaries are the anterior axillary line. And at the lower part, we have the inguinal ligament and the pubic symphysis. In contrast, the posterior abdominal wall starts from the tip of the scapulae, lined bilaterally by the posterior axillary line and the iliac crest below. And the area in between the anterior and posterior axillary line is called the flank. But when we think from the internal aspect, we have the basic three cavities: peritoneal cavity, the retroperitoneum, which lies posterior to the peritoneal cavity, and the pelvic cavity, which contains both the pelvic peritoneal as well as the retroperitoneal space. And this is where how we teach our residents the 9 areas of the abdomen divided by the 2 vertical and the 2 horizontal lines, and think of abdominal organs which corresponds to each of these areas. So when we see a patient, we have to think of these areas and think of organs which may be affected by such a trauma. Now, how do we recognize the abdominal visceral injuries? First, just like an approach, we have a relevant history and a detailed clinical examination. In the history, it has 2 aspects. what is the mechanism of injury, and what does it produce. That means what are the symptoms by which the patients report to us. Injury mechanism depends on the type of injury, which may be blunt, penetrating, and explosive and blast injuries. Blunt injuries, it depends on the speed. More is the speed, more the risk of fatality, more is the risk of serious injuries. Site of impact, whether it is a head-on collision or a side-on collision, whether there is intrusion of the part of the vehicle into the patient, what is the seat position, whether it is like sitting on the front seat or in the back seat, whether any restraint devices are used, whether the patient has used any seat belts, and whether he, in case of bikes, whether he has used any helmet. These things are important to suspect the extent and the severity of the injuries. And what is the status of the co-passenger? Death of the co-passenger suggests a high degree of high impact trauma, and you can expect serious injuries. In case of penetrating injuries, particularly you depend on the type of weapon, be it a gunshot, which may be rifle or a shotgun injury, or it may be a patient who is suffering from a incisional traumatic injury from a knife. The distance from which the firearm is fired and what is the position of the assailant, right-handed, left-handed, to see what is the expected course of this penetrating injury. The number and site of the penetrating wounds, be it an entry and exit wounds, what are their site, that helps us to think about the course of the trajectory. And the problem with this incisional or the penetrating wounds are these multiple. One single wound results in multiple perforations inside the abdominal wall, abdominal cavity. Explosion is a combination of both blunt and penetrating injuries, and apart from this is a blast web which injures organisms that have both fluid and solid component. Now, relevant history, all these features they present with the patients may present with, in case of abdominal trauma, signs of peritonism or absence of peritonism. Patient may present with shock, or patient may be hemodynamically normal. When we look at the examination, we inspect all areas, undress the patients, evaluate from the transnipal line to the perineal area, and do not forget to look at the back of the patient. Auscultation is not that much of a role apart from the peristaltic sounds. Palpation, we look for signs of peritonism in the form of tenderness and rebound tenderness. Examination of the pelvis is very important, will be dealt later on, and perineum, particularly a digital rectal examination to assess the sphincter tone, presence of blood, and a high riding prostate in case of a urethral injury. When we examine the patient, we have two helpers with us. One is a nasogastric tube and second one is a Foley catheter. Nasogastric tube decompresses the stomach. In case of upper GI injury, it can show presence of bleeding. Foley catheter, same, we decompress the urinary bladder and monitor the hemodynamic status of the patient, as well as in case of bladder injuries, it can drain blood. Caution, particularly in case of a Ryle's tube, we have to aware of fascial injuries where putting a nasogastric tube can lead it to inside the brain through a fracture in the cribriform bed. And in case of urethral injury, where is suspected by the form of blood at the urethral meatus, butterfly hematoma, and urinary retention, do not put a Foley catheter unless you get a retrograde ureterogram in place. Blood and routine test, not that much useful unless the patient is stable. Maximum you can do a grouping and cross-matching of the blood. Now, imaging techniques, these are the imaging techniques. We have particularly X-ray, FAST, DPL, CECT, and contrast studies. Of us for important, particularly in patient to get a chest X-ray, just like Dr. Kashyap has evaluated, and pelvic X-ray to exclude a pelvic bone injury. FAST, EFAST are very important in case of a abdominal injury. FAST stands for 4P. It is the pericardial, perihepatic, perisplenic, and pelvic space, while EFAST, in addition, we examine the pleural space. DPL is not done usually CCT of abdomen done in hemodynamically stable patients. So most important, what is the indication of laparotomy? If the patient is hemodynamically abnormal, patient have signs of peritonitis, free AR and X-ray, and a positive FAST, the patient will require laparotomy. In case of penetrating trauma, if there is evisceration, peritonitis, free AR, positive FAST, this patient will require laparotomy. And who will not require a laparotomy if the patient is hemodynamically normal? You can, following a blunt trauma, you can do a CT scan of abdomen. Asymptomatic patients with flank or backstab wounds, which have a thick musculature with no obvious signs of peritonism, may require serial contrast and on CCT for evaluation. And conclusion, the mechanism of injury is very important in the decision of management of abdominal visceral injuries. Appropriate diagnostic procedure are based on assessment of patient's preparation. Basically, what the patient is hemodynamically normal, we have time to evaluate the patient is hemodynamically abnormal or shrinking, losing blood. We have to think of immediate laparotomy or surgical intervention. And the early surgical consultation is warranted whenever we suspect a possible intra-abdominal injury for an optimum outcome. Thank you so much for your patience here.
Thank you very much to all the speakers. Before I open for panel discussion, I would like to add few words. Number one, this emergency has really become an emergency. And secondly, the damage control. The damage control has become more important for two reasons. The recent inclusion of the doctors in the consumer forum and the recent suicide by doctors following a complication of no fault of theirs has become made us so aware of all the problems of surgical management that nowadays we are a bit hesitant to give frank opinion. Thank you very much. Now I will request the faculty members to join me to open the panel discussion. Thank you.
Thank you, sir. Since we are short of time, we'll be proceeding with the next session. I thank the chairpersons for their time and valuable suggestions. For the next session is on pelvic trauma. I'd like to request Professor Dr. Ramesh Sen, Dr. Sanjay Pandey sir, Dr. Anil Verma sir to kindly be on the stage and chair the session. The first presentation is by Dr. Anup Inamdar, Acute Management of Pelvic Trauma.
Good morning for this session. So we will have to talk about the subject on pelvic trauma. And
Dr. N.C. Kothari, sir.
Yeah. So first of all, I'll request Professor Vivek Rekha to talk about classification and decision making in pelvic fracture. Yeah. So probably it has to be changed. Okay.
A very good morning to all the faculty and delegates. And I thank you and I thank my mentors at AIIMS to provide me with this opportunity. Today my talk is on acute management of pelvic fractures.
Yes.
So pelvic fractures constitute 2 to 8% of all skeletal injuries and near about 25% of all polytrauma patients. Mortality rates in pelvic injury is 8% for isolated pelvic injuries and 50% associated with polytrauma. And the reason for mortality is the exsanguination due to recalcitrant hemorrhage, which is why decision-making, resuscitation, and stabilization must go hand in hand in these injuries. So the most common classification that is used is the Young and Burgess classification, since it takes into account the mechanism of injury and the forces acting on the pelvis which is causing the injury. So it comprises of the lateral compression, the anteroposterior compression, the vertical shear, and the combined mechanisms of injury. And the most notorious for hemodynamic instability are the lateral compression 3, anteroposterior compression 3, vertical shear, and the combined injury mechanisms. So care at the trauma site and pre-hospital phase is extremely important, especially the first 60 minutes following the trauma, which is the golden hour of trauma care, in which the patient has to reach a designated hospital or a level 1 trauma care center. Especially the first 10 minutes of this golden hour are the platinum 10 minutes in which the patient should be attended, stabilized, and loaded into the vehicle Unfortunately, the emergency medical services in India are still in the stage of infancy. The most important device at the site of trauma care is the T-pod or the pelvic binder, which has to be applied to control the bleeding. So it should be applied at the level of the greater trochanter. It should encompass the entire pelvis with internal rotation of both legs. Care should be taken that there is adequate cushioning in the gluteal folds. And when properly applied, it is as efficacious as the pelvic C-clamp. So there should be a continuum of care between the pre-hospital phase and the care in the emergency department, which consists of management in the form of ATLS principles, that is the primary, survey, resuscitation, and prevention of hypothermia should be done at all costs, and log rolling of the hemodynamically unstable patient should be done extremely carefully because it may dislodge the blood clots. So persistent hypotension is defined as systolic blood pressure less than 90 millimeters of mercury despite resuscitation. It induces dilutional coagulopathy and stimulates the lethal triad of acidosis, coagulopathy, and hypothermia. But the treatment is permissive hypotension. We should always remember that it is the restrictive fluid administration which is important, and the systolic blood pressure should be maintained between 80 to 90 millimeters of mercury to prevent the pop the clot phenomenon, that is dislodgement of the already formed blood clots. So according to the modified ATLS protocol, 1 liter of crystalloids is enough to resuscitate the patient, following which early transfusion of the blood component should be done. Tranexamic acid also plays an important role. It should be given in the first 3 hours of polytrauma. It reduces the mortality rate significantly. And the endpoints for resuscitation are a base excess of more than 5.5 millimoles per liter, pH of more than 7, normalization of serum lactate levels, systolic blood pressure between 80 to 90, a good urinary output, and a palpable peripheral pulse pressure. So as discussed previously, damage control orthopedic principles should be followed. Permissive hypotension is the best way to resuscitate the patient, and this reduces the incidence of ARDS and multi-organ dysfunction, and the term aggressive resuscitation has been eliminated from the ATLS guidelines. The most important thing in pelvic trauma is to early identify the site of hemorrhage. The hemorrhage usually occurs from the bone surfaces, vascular structures, solid organs. It can be concealed hemorrhage in the form of in the vagina or the peritoneum, the perineum, and we should inspect for blood at the urethral meatus, total contusions, and butterfly hematomas like these in the perineum suggest that there is injury to the perineal membrane and the patient may require a colostomy due to a rectal tear. Digital rectal examination for a rectal tear and high riding prostate signifies a urethral injury. The surgeon should be aware of the chimney effect, that is a vent in the parapelvic fascia, causes the pelvic hemorrhage to drain into the retroperitoneal space, and which may not be addressed by external stabilization measures. We should take care that vigorous examination should be avoided because the first clot is the best clot and it should not be dislodged. And the other adjunctive treatments such as the gastric tube placements and urinary catheter is important, as the gastric tube decompresses the gastric dilation and prevents aspiration. Urinary catheterization should be done very carefully. If there is urethral injury, it should not be done, and a retrograde urethrogram should be done, and suprapubic catheterization should be done. Urinary catheterization should be done following the FAST, that is the evaluation for the abdominal injury. So the FAST is an excellent method to evaluate for the abdominal injuries. It has a specificity of 95%, and more importantly, it has a false negativity of only 2%, which means it is reliable to diagnose the life-threatening bleeding. And the extended FAST to the E-FAST additionally screens the thoracic cavity. If there is hemothorax in the chest X-rays, an intercostal drainage should be done, and radiographs of the pelvis, such as the AP view, inlet view, outlet view, should be done to get an idea of the mechanism of injury and the plan of management. Selected tomography of the pelvis is important to identify the fracture morphology. However, whole body CT scan has been found to be superior to the selected tomography of the pelvis because it tends to detect occult injuries better, such as the cervical injury, lung contusion, the pneumothorax, and the brain contusion, but it should not be done in women of childbearing age and in children. So according to the principles of damage control surgery, first, the resuscitation should be done and early stabilization by external fixator should be done. And when the patient is resuscitated, the definitive fixation can be done. So the external compressive devices such as the anterior external fixator and the pelvic C-clamp are used for initial management. So the various types of pin placements in anterior external fixator, the pins can be either iliac pins or supraacetabular pins. Iliac pins require 2 pins to be inserted into the iliac crest. It can be done quickly. However, it has the disadvantage that the pin may become loose because of a thin iliac braid and it interferes with the abdominal procedures. Hence, the supraacetabular pins are superior to the iliac crest pins. The Shyam pins in this case, they stop just short of the corridor of the SI screws, and the pubic ramus screws can also be placed. And the interconnecting rod also does not come in the way of the abdomen so that the abdominal procedures can be done. However, the anterior stabilization methods do not take care of the posterior pelvic ring injury. which is why the pelvic C clamp is an essential device. It has to be inserted near the SI joints by threaded bolts into the ilium, and there is a free sliding side arm which is applied. It does not come in the way of abdominal procedures, and it provides good compression of the posterior injury. But the disadvantage of the C clamp is that it cannot be applied in the iliac wing fractures, and it cannot be applied in the transforaminal sacral fractures. So recalcitrant hemodynamic instability occurs whenever an unknown source of bleeding causes the blood loss. It can be an arterial source or a venous source, arterial source being rare. Arterial source needs a pelvic angiography and embolization, whereas a venous source, which is the presacral venous plexus bleeding, needs retroperitoneal pelvic packing. This 3-in-1 protocol in a multicentric study in Hong Kong shows the efficacy of external fixation, peritoneal packing and angiography done in the same sitting to reduce the mortality rates. Reboa or resuscitative endovascular bundle occlusion of the aorta is a good treatment for those who do not respond to all hemostatic measures. So as discussed before, delayed definitive fixation of pelvic ring fractures after good resuscitation is a safe with predictable outcome. However, few surgeons have attempted early definitive internal fixation by minimally invasive methods. Although it is controversial, it is a part of the early total care. So the various modalities in which the early fixation of these fractures can be done is the infix, which is the anterior subcutaneous internal fixation. It consists of the supraacetabular pedicle screws, which is applied in the supraacetabular region, and then a subcutaneous tunnel is made between the two hemipelvises, and the pedicle screws are connected. It stabilizes the anterior pelvic ring. So this is how it is done. And a new modality is the intramedullary interlocking nail fixation of the pubic rami fractures, or the PU lock, in which the entry point is made in the pubic symphysis, and a nail is passed along the pubic ramus fracture. The perforation of the outer cortical wall is done. And this is how the nail is inserted. And the incision is very small, and the posterior injuries can be taken care of. So to summarize, early resuscitation by means of damage control principles, IV fluid and early blood transfusion followed by a delayed internal fixation should be done. Thank you.
Thank you, Dr. Anupam. So now I'll request Dr. Vivek to talk about a little change in the classification and decision making about the pelvic injuries. No, he just wants.
Okay, so we'll start by the acute management, which was told. Until unless you save the patient of pelvis fracture in the emergency department, you are not going to classify the pelvis fractures. So remember that what he said is the most important thing in pelvic injuries. Pelvic stability, the majority of it is on posterior side, and the anterior stability is less 30% to 40%. And what do we mean by stability? The ability of the ring to withstand physiological forces without deformations. That means you can do the normal activities and the pelvis is not going to go haywire. A lot of ligaments are there in the pelvis, and the major stability is given by the ligaments for this. How do we approach a patient of pelvis injury? Define the injury and classify it. Save the life in emergency department. That's the most critical thing. We cannot do anything for the patient except fixators if we do not save the patient in the emergency. Then only it comes to our wards and we are able to do glamorous surgeries which look very fashionable. Then we decide conservative or operative, assessing it by various approaches and the fixation techniques. There are various classification systems. First was by lateral anatomical, just where the fracture was there, that's what they used to say. But what we understood was there are two patterns of major displacements. One is that there is an opening of the pelvis like a ring. And the second thing is it goes up and down in a cephalad displacement. So either it's a rotational instability or a vertical stability or instability as well. Tiles is based on this. The classification, it's A are stable fractures, the B are rotationally unstable, and C are rotationally and vertically unstable fractures. So that's what we need to understand. If it is rotationally, we can fix it and by closing it. If it is vertically, we need to push it down and then fix it. And that's what entire management is dependent upon. Muller's classification is a neo classification. It's also based on the tile in the same fashion. But what is the young Burgess, as was just briefly described in the first talk, it's on the mechanism of injury and where the direction of the forces is leading the displacements to be. The APCs, the lateral compression, and the vertical shear, and the combined mechanism. So let's go one by one. When we are hit from the front, we are crossing and some person comes and hits onto the front, the pelvis starts opening up in this fashion. And that's what anterior-posterior compression is all about. So what happens in APC1? The anterior ligaments break, symphyseal ligaments break. In APC2, the anterior SI ligaments break. And in APC3, the entire SI joint also opens up. So it's a complete opening up of the ring. Based on this, if we can evaluate it and classify it, we can operate whether we want to go anteriorly or posteriorly as well. Then comes the lateral compression, the most common injury. What happens in this? We are crossing the road and we are hit from the side in the road. We try to cross it, some vehicle hits us from the side. Where the injury happens? In the greater region, the pelvis moves inside, it caves in. And that's what happens. Again, we have got various gradations of it depending upon the mechanism and the forces. The first one, just pubic rami will be broken and will collapse. So there are no ligamentous avulsions here in lateral compression. It's just collapse. In LC2, we just have posterior elements also which are involved. And in LC3, it's a windswept sort of a thing. One hemipelvis collapses, and because of the internal pressure, the opposite pelvis opens up. Hook, counterhook mechanisms which were happening in the skull as well in the injuries. And that's what happens in LC3. Vertical shear is when we fall from height and we fall on one pelvis on the one leg and the other one goes up. That's a vertical shear displacement, which is both vertically and rotationally unstable. As you see, the posterior elements are definitely involved in a vertical shear. And where the posterior elements are involved, that's the place where your common iliac is dividing into the posterior and the anterior branches and into the external and internal iliac arteries. So the maximum vascular damage happens when the posterior elements are involved along with neurological damage. So always look for fractures or injuries which are going to have posterior injuries, because they can have hemorrhagic disturbances as well as neurological problems. Combined is the one because it cannot be defined that I am going to hit only in anterior-posterior or lateral. So both the things combine together. When you fall from height, then you fall also on the ground. And that will combine the lateral compression with the vertical shear. And that's how it happens. So a combined mechanism, the most common injuries which we have to have lateral compression. Because whenever we fall onto the ground, we are falling on the sides, and the impact, even in the car, is compression. It may be associated with a front injury or a vertical shear. And what we operate, depending upon the mechanism, we try to understand the mechanism. And then if the anterior fragments are involved, we fix the anterior. Along with that, we fix the posterior whenever it is involved. So just to recapitulate what we have done, the lateral compression is an implosion. It comes inside. The anterior posterior is an opening up of the ring, like a bangle opening up like this, like a flower from a bud. The vertical shear is the vertical displacements or the cephalad displacements. And the combined mechanism, which is usually having a vector force, which is combination of the forces which is acting on it. Sacrum is also divided and having a classification, which is zone 1, which is lateral to the foramen, zone 2, which is involving the foramen, and zone 3, which is medial to the foramen. So the zone 2 and the 3 ones have got neurological damages, which we need to look for, especially the zone 3 ones, because it's involving the canal and the place where it is there. Definitive fixation is only done once you have stabilized the patient and made sure that his life is secured. What decides treatment is the stability. If you understand that the stability is there, you might treat conservatively, or if it is opening up, you treat operatively. See the soft tissues. It's not only the bone, it's the soft tissues which is going to decide what treatment you are going to give to the patient, along with other organs injury. Remember, pelvic injuries are associated with abdominal injuries. An SPC or an open or a colostomy might not allow you to operate on this patient. So in conclusions, I would say it's a high energy trauma. Save the patient's life first. ED is most important. Then do the quality of life. More than just a team on a bone injury, it is also a team approach which we do. We classify it, understand the mechanism, and based on that, we try to give him the best stability so that the patient can be mobilized as early as possible and he comes back to the social circle. Thank you.
Next speaker, Dr. Mantu Jain. He may speak on posterior approach to pelvis, including SI joint and acetabulum.
So I thank the organizing committee for giving me an opportunity, and greetings from AIIMS Bhubaneswar. So I'll be speaking on the posterior approaches to the acetabulum and the pelvis. So the outline of my talk will be indications and approaches to the acetabulum and indications and approaches to the pelvis. And I will be discussing only the posterior approaches. So before we jump into the approaches, there are some golden rules of fixation. So a pelvic patient could bleed to death, where an acetabular patient could limp to death. Therefore, Latoral left the golden rule that the posterior stability must be restored first. So if there is a rotational unstable, then the anterior fixation would suffice. But if there is a global instability, then posterior fixation is required. As far as acetabular fractures are concerned, they follow the principles of intra-articular fixation. That is, any malreduction will lead to osteoarthrosis. So a right approach for a right fracture done by a right person will give optimal functional outcome. Now, most of the surgeons are exposed to the posterior approach during their training in arthroplasty. So with minimal meticulous dissection, there is minimal blood loss, and there is adequate exposure to the posterior wall and the column. So when there is a posterior wall or a posterior column or both, or there is an associated fracture with a posterior wall, then the posterior approach becomes absolutely essential. But if there is a transverse or a T-shaped fracture with predominantly posterior displacement, then the posterior approach will become very handy. Now, the posterior approach basically is of two types. One is a Cocken-Langenbeck approach and one is a Gibson's approach. So the prone position, the position of the patient in the approach will depend on the surgeon's choice. Either you can have a lateral or a prone position. A lateral position would definitely simplify the intraoperative management by the anesthetic team. And if you are planning to do a safe surgical dislocation, it will allow you. But the weight of the leg could hinder a reduction, particularly if there is a transverse fracture. So the advantage of a prone position is that in transverse fracture, it is easier. And the femoral head also acts as a scaffold over which the posterior walls can be placed. It also improves the access to the quadrilateral surface, but a safe surgical dislocation of hip cannot be done. Now, the steps of the Cocken-Langenbeck approach are: a 15 to 20 centimeter incision is made 5 centimeter distal to the PSIS along the greater trochanter and the femoral line. And then the gluteus maximus is split between the anterior 1/3 and the posterior 2/3. The gluteal can also be released from the femoral side. And the external rotators are cut 1.5 centimeter from the femoral attachment. And preserving the capsules carefully, one can see the posterior wall and the posterior column. So what actually we see is the dotted line, but the anterior part of the roof of the acetabulum is not visualized in the scale approach. So here comes in the Gibson's approach. So the Gibson's approach actually is a vertical incision, and it lies anterior to the gluteus maximus. So it lies actually in between the gluteus maximus and the gluteus medius, and therefore is a true internervous plane. And the deeper dissections are similar to that of a KL approach. So the part which we could not visualize can now be seen, that is the anterior part of the roof of the acetabulum. There are some complications associated with this approach. sciatic nerve neuropraxia, superior gluteal artery or inferior gluteal artery injury, and heterotrophic ossifications. Now, what extra can be done is a flip trochanteric osteotomy, which is actually a digastric osteotomy. It is continuity between the gluteus medius and the vastus lateralis. So doing this will allow you to see even more anterior part of the roof of the acetabulum. And if you do combine a safe surgical dislocation with it, you can actually see an intraoperative reduction of your fracture fragment through the joint. So this is a case one where there is a comminuted posterior wall fracture and it has been fixed by using a recon plate and a spring plate. So this here is another fracture where the fracture fragment is on the anterior part of the roof and a flip trochanteric osteotomy was done and the fracture was fixed. So what more can be done with the posterior approach? So if you want to palpate the quadrilateral surface, then you can do an osteotomy of the ischial spine. And if the fracture fragment is little lower, then you can actually release the quadratus femoris from the ischial side and not on the femoral side. Now coming to the second part of my talk, that is the surgical fixation of the posterior ring. We have various modalities of fixation, which includes a percutaneous iliosacral screw fixation, a posterior and anterior plate fixation, a lumbopelvic fixation, or a combination of all of these. But again, the golden rule is that the posterior implant merely acts as a tension band and stabilization of the anterior pelvic ring is must after a posterior fixation. Now, the posterior approach will require a prone position. So the advantages are it will give you a direct visualization of the fracture or a dislocation. It will help you in reduction. Also avoid the iatrogenic injury to the L5 nerve root. But it would require another position for fixation of the anterior part once the posterior part is finished. And there are certain contraindications for a prone position, particularly if the patient has got a lot of chest injury. So the indications for posterior pelvic fixation would be a displaced iliac ring fracture, that is a crescent fracture extending into the SI joint, a sacroiliac disruption, a comminuted sacral fracture, a vertical displacement, or a spinopelvic dissociation. Now the approaches are, there can be a unilateral approach when an incision is made just lateral to the iliac PSIS, and it will give you access to the posterior ilium sacroiliac joint and the posterior part of the sacrum. Or you can go for a midline approach, which will give you a bilateral access. Even if you want, we can release the erector muscles from the base and we can see the whole of the sacrum. This will allow you to do a central canal decompression as well. So after the reduction has been done by using clamps, actually one can insinuate one of the finger to the greater sciatic notch and feel for the reduction of the fracture. When we are putting screws, particularly in this area, one has to be very wary because of the presence of the neural foramina and the central sacral canal. Now the spinopelvic fixation is a bypass mechanism for the sacral fracture where the line of force passes from the lumbar spine to the iliac and to the hip joint, bypassing the sacral fractures. So it is mostly indicated whenever there is a spinopelvic dissociation or there is a failed primary fixation, and this is an illustration of how it is done. So pedicle screws are placed at the L4, L5 and the iliac screws are placed. So here is a case where there is a crescent fracture along with a comminuted alar fracture, and there is also anterior ring fracture which was fixed with the iliosacral screws, and also percutaneous Ramai fixation was done after the procedure. So the take-home message is that in case of pelvic acetabular injury, appropriate sequence and positioning is very important. The posterior stability must be re-established first, and it has to be followed with the anterior pelvic ring stability. Acetabular fractures follow the principles of intra-articular fractures. That is a right approach for a right fracture done by a right person is very paramount for an optimal functional outcome. Thank you.
Again, Dr. Sir for anterior report. It's just 8 minutes, so I'll be concentrating more on the Stoppa approach for everyone. Okay. Okay, so the modified Stoppa or the interior approaches, and it also incorporates the symphysial fixation. So if we know how to do the intrapelvic approach, we can also fix the pelvises from the front in the symphysis. Stoppa, it's a very near approach and a very recent approach. It started from hernial repairs when you have the hernias and they have been recurrent. So that came as a salvage procedure from Stoppa, and he started doing this. And then Hirvensalo from Scandinavian and Kolbofner started using it for our own procedures of acetabular fractures. Previously, it was known as extended fan and steel. Then it came as modified Stoppa, and now it is known as intrapelvic approaches or anterior intrapelvic approach. For the approach, if you need to do this, you need some special instruments. For all anterior pelvis injuries or the surgeries, you need some special, which is a Harrington or a Devers, which you can always borrow from your surgical friends. Then there is a malleable retractor also, which is many a times required when you are going anterior. Remember, most of the other instruments that we use are the Homans, but in anterior one, where we are dealing with the soft visceral organs and the bladder, the Homans is not going to be the ideal instrument and the technique to retract. So we require some blunt ones like Harrington and Devers. Without this, you cannot do anterior pelvic fixations or approaches. When you do an intrapelvic approach, you are looking at the quadrilateral plate or the inner side of pelvis. So if I am operating from the right side, I cannot look at the right side of the quadrilateral plate. I can look at the left side. Hence, I will be standing on the opposite side, and then from the internally, I'm going to be operating from the inner side of the acetabulum, as well as the pubic rami, as well as going right up to the SI joint. Fan and steel incision is the one which we use. It's just extended fan and steel, as it was said. That's the standard approach. We just extend our incision by fan and steel. We do not cut anything else, and we just go more laterally from the central position and try to approach the acetabulum from the midline position. So either you can use a transverse incision or you can use a longitudinal one also. And rectus in between is vertically cut. You retract the bladder and you start doing your symphysial fixations. So this is how you take the fan and steel and the initial ones. Can I forward it? Oops. It will take its own time. So once you do that, it's 5 minutes. So it's around 6.5 minutes video. So you cut the rectus vertically. You see the decussation from both the sides of rectus coming abdominis and forming the linea alba like a cross. So you cut it there. And then once you do it, you bluntly dissect out your finger. From your finger, the bladder can be retracted and the rectus can be pulled up. And then you go ahead and do the things. Then comes the placement of retractor, which is the most important. Right now we are using the Homans. So the first retractor is put at the pubic tubercle region. The second one, can somebody help me out here? If we can fast forward this. The second one is put roughly at the pubic, at the iliopectineal eminence, once we lift it up. And okay, and then ये slide show को हटाकर presenter mode हटा सकते हो तो फिर उसमें I can maybe fast forward this. Okay, and the second one is put, let me just tell you where exactly I'm going to put. The second one is going to be at the pubic, at the iliopectineal eminence region. And the third one is where the name and the things are written. So that's the iliac fossa region where I'll put the third retractor. And the fourth retractor is going to be put removing and pushing down the soft tissues, the bladder, and the other things which are there in the viscera. So, यही वीडियो है, इसी में सर मुझे फास्ट फॉरवर्ड करना है अगर हो सकता है। right. तो फिर उसी में जाते कोई ना again. So that is done, and once you do that, then you have to do a most important thing, which is the ligation of the corona mortis, and then you place the retractors like this. If you see the retractor, that's our number 1 retractor. That's near the iliopectineal eminence is the second retractor. The third one is in the iliac fossa region, shifting the muscles there, and the fourth one is pushing down the soft tissues. And that's how we see the entire inner side of the pelvis and the acetabular region. Comes the corona mortis, and this is the most important thing. The one critical step is there in all approaches, and we all know that that is the critical step and decision-making step. So in this, it is the ligation of corona mortis, which is an anastomosis between the external iliac and the obturator. So if you think like a capital H, 2 vertical lines lying down and 1 transverse connector to it. Spine people know 2 pedicular rods with a transverse connector. Just tilt it down and think like that. So until unless you cut the corona, you are not going to lift up the external iliac and push down the obturator. And once you do that, then you will be able to focus in the quadrilateral plate region. And that's what, then you go here and do that. So if you can just see, otherwise I'll just skip this in paucity of time. And then we do the quadrilateral plate exposure after this. And then we go down the infrapectineal region. And in the infrapectineal into the true pelvis, we try to dissect out the acetabular region and the quadrilateral plate. So if I can just show it diagrammatically, I cut the corona mortis, and once I cut, I lift up the external iliac, push down the obturator, and I see the inner side of my acetabulum and the pubic rami standing in front of me, and I can fix them wherever they are getting displaced. That's how we do that. This is the infrapectineal plate inside the true pelvis. And there we put in the suprapectineal plate over the pubic rami, where we get our normal fixations. Just few contraindications. Remember, old fractures, caesarean sections, you will be difficult to see them and do the things and find out where the bladder is, and you can have problems with that. So in conclusions, I would say that Stoppa or the intrapelvic approach is the newer approach, which you should be looking at. 8 minutes or 7 minutes is too less a time to understand it. But I think I have been able to give you the basic principles of this intrapelvic approach, and we can discuss this further sometime over a cup of tea. Thank you.
Thank you, Dr. Vivek. I think we have all the talks done. No time for discussion. Is that all? Any time for any questions? No. Thank you. So thanks a lot to the participants, and thanks to my chairpersons. Thanks a lot for this session.
Thank you, sir. Our next session is on spinal trauma. I request Dr. Subir Mukherjee sir, Dr. Anil Sharma sir, Dr. Surendra Shukla sir to kindly chair the session. Yes.
Before the session starts, it is just to inform you that breakfast will be finishing with this lecture. And the jackets which are being distributed, the owner of the jackets is here with us by up to 2, then he will be going. So if you want to have it of proper size, he can guide you in taking the jackets. Ankit, who are the other chairpersons? So may I request Dr. D.P. Bhushan sir to chair this session. Dr. K.D. Tiwari sir to please come and chair this session.
Good morning, everybody. We are into the third session of this conference, and this is the session on spine. And we have about 8 papers to be read within this short period. And we are lucky to have the galaxy of spine surgeons of the state, national, and international repute in this session. And may I invite upon Manindra Bhushan for his first talk on cervical spine injury, case-based discussions. Manindra Bhushan, please.
Good morning, respected chairperson and my dear colleagues. I'll be talking about a few salient points about how to manage a case of subaxial cervical fracture dislocation. Coming to our index case, she is a 30-year-old housewife who sustained road traffic accident and she is complaining of neck pain. There was history of loss of consciousness. There was no weakness of upper or lower limb and no bowel bladder involvement. On examination, I would like to emphasize the point, beside checking for motor or sensory deficit, we should always check 2 more things, that is whether spinal shock is present or not by checking for bulbocavernous reflex, and last, myotomal and dermatomal segment, that is S3, S4, and that we check by doing perianal sensation and anal contraction. And always we plot the neurological status on ASIA scoring. That will give a objective view of later on how much patient is improving or patient is deteriorating. Coming to after history and examination, how to evaluate further. So in any trauma case, first and foremost, utility is X-rays. We get X-ray cervical spine, AP, and lateral view. So what all things to look for in X-rays? So always we have to do methodical evaluation. We have to look for adequacy, alignment, bone, cartilage, disc, and soft tissues. So adequate X-rays are must, otherwise we'll miss the lower cervical spine injuries. Next thing is look for the alignment. Here we can see there is all 4 lines are broken: anterior vertebral line, posterior vertebral line, spinolaminar line, and posterior spinous line. All 4 lines are broken. Here we can see there is a subluxation of C4 vertebra over C5. Coming to AP view, again we'll look for alignment, symmetry of pedicles, contour of bodies, and height of disc space. Coming to our X-ray in AP view, we can see that there is a spinous process line is broken. This vertebra looks laterally subluxated and disc space is not uniform. So what next? Next comes role of CT and MRI in any case of cervical spine injury. So how does CT scan helps? It defines our osseous anatomy better. It helps in identifying the junctional levels, that is occipitocervical and cervicothoracic level, which can be easily missed on X-rays. And CT scan has been found to have a sensitivity of 99% and specificity of 100%. Coming to our index case, we should always look CT scan from one facet to other facet so that we should not miss any minor facetal fractures or subluxation. So here we can see that there is C5 facet fracture is there. Along with that, subluxation of C5 over C6 is there, and there is lateral subluxation of C5 over C6 is there. Along with that, here we can see in axial section, there is a fracture of right facet. This is stuck. This is stuck. If it was now coming to what is the role of MRI? Can we just do CT scan and get away with it? No, there is definite role of MRI in any patient with neurological deficit. It can detect injuries to disc and PLC. It can identify the severity of the spinal cord injury, and it can screen whole of the spine in order to rule out injuries at other level. Coming to whether we can see in this case, these are two different cases with same level of injury, but in one case there is a disc prolapse, but in other case there is no disc prolapse, which can be easily missed on CT scan. Coming to our index case, there is disruption of PLL, along with that posterior ligamentous complex injury. So how to manage such cases? First and foremost is immobilization, medical stabilization. Then we have to get the anatomical alignment of the spine, surgical decompression, if there is proved cord compression, and spinal stabilization. Immobilization by means of Philadelphia collar or Miami J collar. Then we have to maintain the blood pressure because cord loses its ability to auto-regulate blood flow after injury. There is a controversial role of steroid. Within 8 hours we can use it. Spinal alignment we can get by means of tongs. Close reduction can be achieved by gradually increasing the weight on Gardner-Well tongs in flexion position, followed by we extend the reduced spine. What are the different radiographic markers of cervical spine instability? If we see there is loss of vertebral height of more than 25%, angular displacement of more than 11 degree, or translation of more than 3.5. So we just classify the injuries based on Eslick subaxial injury classification scale, and if it comes equal to or more than 5, we should operate such cases. We can do anterior or posterior surgery. In this case, we did anterior surgery. We went ahead with the C5, C6 reduction and ACDF along with anterior cervical plating. Thank you.
Salute, time is up.
Yes.
Dr. Vishal Kundani.
Thank you, Chairperson, and thank you, the organizing team here. I must commend Dr. Alok's credential here. He's been really on it since morning and actually yesterday night to get us all. And thank you for the hospitality extended to all of us. So, cervical trauma, we are just changing gears, going one gear up to the cranio-vertebral junction. Might seem like one of the complex features in cervical trauma, but it actually is not. Cranio-vertebral junction trauma जितना कॉम्प्लेक्स दिखता है उससे भी कॉम्प्लेक्स उसके बारे में सोचने वाले लोग होते हैं. Why I'm saying so is because most of us tend to not think about it and not visualize it and often miss it. And that's that one message that I would like to percolate among all of us here is that if one thing you want to do in cranio-vertebral junction trauma, please don't miss it when it has to be diagnosed on day one, because that is the best time when you can diagnose it, manage it. And if I have to give you 8 messages in the coming 8 minutes about cranio-vertebral junction trauma and odontoid fractures is that it is commonly missed rather than diagnosed. In acute setting, most of these patients have other associated injuries, be it chest, abdomen, pelvis, or musculoskeletal injuries, that this injury, because it is not in the mind, it doesn't come to the eyes, it doesn't reach to the heart, and you are often tending to miss these injuries. And this is the time when you should actually diagnose them, because earlier the diagnosed they are, the better they are managed. Remember, not all odontoid fractures are surgical in nature. Most of them are actually stable, provided they are diagnosed on day one. If you can diagnose them on day one, stabilize them only by a rigid halo collar or something, they will not get displaced and they will not turn into a surgical one. Classification systems are there, we will go into them, but they are not so complex. You can actually just remember in the simple means, stable and unstable. Not all unstable ones, remember my words here, that not all unstable fractures also require surgery, because fibrous non-union, which often can be achieved by non-rigid stabilization, is also acceptable standard now. And whenever surgery is required, anterior osteosynthesis should be the first thing, which is anterior odontoid screw should be tried upon. Unfortunately, there is a big list of contraindications of anterior surgery, and that's why posterior surgery sometimes can be the mainstay of treatment in most of these cases. And based on these 8 messages that you have to carry home, we'll be discussing upon the coming slides across. To emphasize my first point, let me bring you my case of polytrauma, a blunt injury abdomen with a patient who's conscious and oriented but has got blunt injury to abdomen, complains of mild neck pain, and X-ray, which was done in this manner, tends to look normal and also has been reported normal. I am very, very sure that most of us, despite being the best of orthopedicians in our field, would actually just shove this X-ray under the blanket saying that it looks seemingly normal X-ray. Unfortunately, 2 weeks after the injury, when the patient persistently complained of neck pain, a CT scan was advised, and this is what it was seen, a mildly displaced odontoid fracture, which could actually have been diagnosed on day one, unfortunately got missed on day one, and for 2 weeks, the patient had an unstable odontoid fracture, which was present on day one axis and then was neglected. And this becomes even more common when we see kids of less than 10 years, where they have a mild fall at school, they complain of mild neck pain. But believe me, odontoid fractures never or rarely come to you with myelopathic symptoms or neurological features. They often tend to come to you with mechanical symptoms of mild neck pain after a trivial injury, and often gets misplaced or misdiagnosed. And you should have a very high index of suspicion, because even a normal looking X-ray in a persistent symptomatic patient can have something trivial lying there. It can be as simple as either a subluxation of C1, C2 or odontoid fracture underlying there, which could easily get missed unless your eyes and heart and mind is working on it. So my message number 1, cranio-vertebral junction injury is very common. It is not an uncommon feature, and most of them present with only trivial symptoms of neck pain. Keep an extremely high index of suspicion, particularly in elderly patients, particularly in kids, and always follow the trauma protocol of radiological evaluation in all these patients, particularly when a patient walks into an emergency room who's unconscious or often dated or under the influence of drugs or alcohol. Please don't forget you have to screen every single organ in musculoskeletal, including abdomen, pelvis, and cervical spine, including the CV junction area. And in a conscious patient, don't shove away mild symptoms of neck pain or back pain. They may be having a subtle injury which could actually be managed better conservatively if they are diagnosed on day one. So have a very high index of suspicion. Now, you have had a high index of suspicion, you have done an X-ray and you have found a odontoid fracture. The question comes, what next? Abhi maine diagnose to kar liya odontoid fracture, abhi karu kya? Then the answers to these come in the form of classifications. You first thing that got to know about what kind of fracture this is. Is it a stable or an unstable one, which purely depends on the displacement angles and the displacement, the translation of the fracture, and whether I can manage it conservatively or surgically. And all this can be answered. Most of these questions can simply be answered if we follow this classification, which only says the location of the fracture line, whether it is in zone 1, zone 2, or zone 3, which is in the tip of odontoid, in the tip versus body of odontoid, and actually in the body of odontoid. This tells you that whether the fracture will actually go into non-union or will unite. A type 1 fracture, which is in the tip of odontoid, often is very, very stable. A type 3 fracture, because it is in the body, often heals very well. It is the type 2 where the watershed vascularity of this leads to non-union. And these are the fractures you should actually look forward and follow them up for a long time, whether they are healing or non-healing. And a displaced type 2 fracture is something that is surely going to go into non-union, where you would want to actually start thinking about managing them a little aggressively. So classification systems help you to evaluate the stability and give you the natural prognosis, whether they are going to go into union or non-union. Now, there are inter-observer variations. When it comes to classification, there is always a debate whether this is the best classification or that is the best classification, and inter-observer variations can actually happen. And there are disadvantages to it, which actually this is not the right forum to discuss about. But let me bring forward, it is not the only factor. Classification is not the only factor which decides whether a particular kind of fracture needs surgery or not. Age, displacement, and morphology also decides. Again, I repeat, it is the age, the displacement of the fracture, and the fracture line placement. All these three factors should be taken into consideration whether a particular kind of fracture is going to unite by itself or it is not going to unite by itself. So management planning should not be based purely on the classification systems mentioned in literature. It also takes a lot of consideration of patient's age and medical comorbidities, short neck, long neck, and comminution of the fracture, and various other morphological features of the fracture per se to decide upon what kind of treatment is required. Now, there is a notion that undisplaced fractures actually go into union and you really don't have to worry about surgical fixation. And also a patient who's 70 plus, which is where the odontoid fractures are very common. Again, surgery may not be the best option. Sometimes fibrous union, which can actually be achieved only by rigid immobilization by a hard cervical collar or halo vest, where fibrous union happens in almost 80% of cases, actually is the acceptable standard, and you don't really have to rush upon these patients. Undisplaced odontoid fractures or fractures in elderly patients, just conservative care can really help. However, same fracture in a younger patient or a displaced fracture type 2, actually surgery is the better option, because these patients will often go into non-union and the fibrous union may not be acceptable standard in these patients. So non-surgical treatment options are acceptable, where you can immobilize the neck in patients where there is an undisplaced fracture, or in an elderly patient where you can use a hard cervical collar, a rigid immobilization by a halo vest is the acceptable standard. So surgery is not always the best option. And there are certain kind of patients, certain type of patients where even a type 2 displaced fracture can be managed conservatively. Vice versa, in a younger patient, even a stable fracture sometimes may want to be fixed because of the patient's high demand neck there. Now, you're decided upon the type of surgery. Again, the dilemma, the best confusion happens whenever you're planning to do a surgery is whether you do an anterior surgery or a posterior surgery. It's not as complex as we think. The answer to all this is that anterior osteosynthesis is the gold standard, because it spares the C1, C2 joint and the rotation at the neck can be spared. And that is why whenever possible, always plan to do an anterior odontoid screw, which can be done by using anterior posterior lateral views or two C-arms together, putting in a screw from the C2 body going all the way to the peg of the C1. And the technique is very well described in literature. These are just some case examples where a young guy with a type 2 simple looking odontoid fracture managed with a odontoid screw and anterior osteosynthesis being the gold standard. We have been using navigation these days to do the same kind of screws, and we have been having wonderful results out there. And this is still the gold standard. Whenever possible, please do an anterior surgery, because it not only gives you a good fixation, osteosynthesis preserves the joint as well. However, anterior osteosynthesis may sometimes fail. Actually, it fails often. And it doesn't fail because the technique has failed or the surgery has failed. It is purely because the surgeon has failed and has missed certain features which are called contraindications of anterior osteosynthesis, which means there was an associated injury apart from odontoid fracture, which was not recognized by the primary surgeon. And that led to the failure of this wonderful procedure of anterior odontoid screw. And this was not meant for the patient. And there is a big list: transverse alar ligament fracture, C1, C2 dislocation, fracture going into the joint, pars fractures, or comminuted fractures. You do an anterior osteosynthesis with a screw, it is bound to fail. So in all these patients, the morphology of the fracture decides whether anterior is possible or not. And there is a big list of contraindications in patients with small fragment of proximal comminution, associated steer fracture, or hyperextension injuries. Please don't do anterior fixation. You are bound to have a failure. And again, this has been taken forward in various classification systems to tell you that anterior screw fixation is only present when the fracture is either transverse or a plain oblique. Whereas in all other patients, wherever there is a displaced fracture, comminution is present, the fragment is too small to hold the threads of the screw, or there is a pediatric population or a neglected non-union, please don't do anterior fusion, because that's the way the anterior screws will fail, and posterior is the mainstay. Some of the case examples: reverse oblique fracture, you do a lag screw anteriorly, it is bound to fail. Transverse ligament injury, anterior screws will fail, so we do a posterior transarticular screw in these patients. Small proximal fragment, again anterior screw will not hold the proximal fragment. Unfavorable anatomy with comminution, like in elderly patients or osteoporotic patients, it may not work. And atypical variants, again, it may not work. So to summarize, odontoid fractures classification does helps to get you natural prognosis of these patients. There are factors more than classification which are important in deciding the fracture management. Halo vest immobilization in elderly patients and stable patients still remains the acceptable standard, even if it means achieving fibrous non-union. But the most important message that I would want to drive home is keep a very high index of suspicion in patients of polytrauma or cervical trauma, because you can actually diagnose a fracture which is underlying because of only a subtle neck pain there. Thank you, Chairman.
Thank you, Dr. Vishal. And our next speaker is our own Dr. Harshit Goenka. He'll be speaking on the thoracolumbar injury. Dr. Harshit, welcome.
Good morning, everyone. I'll be speaking on TLICS classification for thoracolumbar injuries. Before we start, every time whenever we talk about the thoracolumbar injuries, we always insist to take an AP and a lateral X-ray and always start looking towards the X-ray from lateral, and that too from posterior to anterior. So why it's so? We'll be discussing more on this topic now. So there were many classifications which has come. Sometimes it's been a 3-column injury, sometimes the TLICS. And many times we just take an X-ray of a patient, says it's a conservative approach. We send the patient home. We send the patient home, and later on the patient comes with subtle neurological involvement, subtle back pain. And when we try to know the reason why it has failed, we comes to actual reason that there has to be a certain fundamental principle which has to be strictly followed. So what are they? So we'll be taking about 3 X-rays right now. We are on the screen. We have one MRI of a pediatric old age pediatric group, one osteoporotic group, and one young guy. So what are we trying to look in this MRI is basically the posterior ligaments which are playing a key role here, apart from the bony involvement anteriorly. So what exactly is the posterior ligamentum complex? So it consists of 4 ligaments: ligamentum flavum, interspinous ligament, facet capsule, and supraspinous ligaments. So these all things are easily missed by an average population because we never bother to take an MRI. These things can be easily picked up either by an X-ray in form of a increase in the interspinous space, or in form of an MRI where we can see there is an edema seen. Going to the first slide again, the first guy who is a pediatric old age, we can see that there's an edema between the interspinous ligament. So the PLC over here is not intact. And the last MRI, the third one, again there is an edema between the interspinous ligament. So that indicates that there is some break there. So this is what the classification says. There are 3 independent factors which we have to look after. The first is the morphology, which normally everyone looks after. The second one is the integrity of the PLC, which we tend to miss. And third is the neurological status. So how do we come across it? The morphology factor comes by an X-ray or a CT scan. And we normally come across a couple of ways, like a compression, burst, flexion, distraction, fracture, dislocation. So there are subtypes into it. We give numbers to it, like compression comes with a number 1, burst comes with number 2, translation or rotation comes with number 3, and distraction comes with a 4. So when we see an X-ray or a CT scan, this is how we number it. So the classification comes with a numbering system where the total score has to be calculated, and according to the total score, we see whether it's an operative or a non-operative. The second one is the posterior ligamentum complex. So when we have an intact posterior longitudinal complex, we number it as 0. When we have a suspected part of it, we put it number 2. And when it is injured, it's always 3. So by and large, when we have a ligament PLC injured, most of the time the patient lands up with surgical intervention. So how do we see the third part, neurological status, that comes with the examination by the clinician? It can be from intact neurology to nerve root injury to complete cord or incomplete cord or even chorda equina. Accordingly, we number them as 0, 2, 2, 3, 3. So this is again an important factor where we have to look after the physical examination of a patient. Just radiographic or MRI doesn't help with.
So this is how we predict. When the total score comes to 0 to 3, it's most of the time non-surgical. If it's 4, it's surgeon's choice whether we want to operate or we don't want to operate. And if it's more than 4, it's always a surgical intervention. Certain examples we can do, like how to calculate it. If a flexion compression injury comes here, with the flexion compression morphology is 1, intact neurology is 0, and PLC is 0. So total points comes to be here 1. So that goes in favor of non-operative. The second, with a compression burst fracture, where the morphology comes with number 2, intact neurology 0, PLC 0. So total points comes to be 2 again. So again a non-comparative. Non-operative. And the third one is an axial compression burst with distraction, which comes with 0.4, complete neurology involvement, number 2, PLC injury, number 3. Total points comes to 9. So again, it goes in favor of surgery. So thank you.
Thank you, Dr. Harshi. Our next speaker is Dr. Ashish Jaiswal. We'll be talking on the burst fracture.
Thank you, sir. Good morning, everyone. So I'll be talking on burst fracture. So we know that this is the commonest fracture, and almost 20 to 25% of young patients with traumatic fracture, they will be having burst fracture, thoracolumbar. So the treatment goal, as in any kind of spinal fracture, is still same. You have to prevent further neurological deterioration, and whenever possible, promote neurological recovery, stabilize the spine if it is unstable, restore the alignment, facilitate early and active mobilization, minimize pain and deformity. The issues which I'm going to deal in my talk is regarding burst fracture, classification, which has been already elaborated in last lectures, whether we need to operate or not. If we need to operate, then whether we should go posterior, anterior, or combined. And if we are instrumenting, whether it should be long or short. And if it is short, then whether it should be including or bridging. And when you are instrumenting, whether you really need to fuse or not. So these are the questions which usually strikes our mind and needs to be addressed. So this is a case one. You can see 45-year-old male. He had a fall from height, severe back pain, unable to stand and walk. Neurology was Asia C, and in X-ray you can make out there is a burst fracture D12. So this is the MRI of the same patient. We'll go into detail at end of the talk. And this is the MRI. This is the MRI. So the management, again, you have to address all 6 issues. This is the case 2, 25-year-old male had an accident. He came with back pain and paraplegia, Asia A. So this is the MRI of the same patient. So the same issues. So the classification, I will not go into detail, but the purpose, what is the purpose of classification? To direct the treatment and assess the outcome. So we have plethora of classification in TL fractures, but there is a lack of universal agreement. So the most acceptable one is the which Harshit has already described, the scoring system, thoracolumbar injury classification and severity scale. The advantage is because once you assign point, then you can decide which patients to conserve and which to operate. So this point system has been already elaborated. I will not go into detail. So there's a further, there is a next step in this classification system, which I think needs to be addressed. AO classification has been combined with scoring system. So this is the most kind of descriptive classification, but yet easy, and it includes each and everything. So here A, B, C, I will not go into detail, you can find in literature. So same modifiers and this thing. But after going through all the classifications, ultimately it boils down to practice. So in practice, what do you see? You see only 7 things. Whether it is a compression fracture, a stable burst, whether it's stable or not, and distraction injury is there, or flexion dislocations are there. PLC is how, whether it is integral or not. Is there any neurological deficit? So ultimately, whatever comes in box, you decide for surgery. So this is the easiest, and most of the time we use this approach only. The importance of PLC cannot be overlaid. It is definitely very, very important and most crucial part in most of our cases. You can assess the integrity of a PLC clinically, X-ray, CT, MRI as and when needed. But most of the times MRI is your confirmatory investigation. So coming to surgery, there are many ways, but still the most common practice is posterior transpedicular fixation. So I will go into that only because time is not that much. So there are some issues with posterior fixation, whether you should do long or you should do short. The advantages of short segment fixation is you spare a lot of motion sparing. It is a motion segments, which is very, very important, especially in your lumbar spine. You don't want to sacrifice that. And there has been studies which have shown that it can be safely used, but there are some limitations, like short is preferable for AO type A and B fractures, and long segment would be preferred for type C fractures, osteoporotic or severely comminuted fractures. Then when you have selected a short segment fixation, whether it should be including or bridging one. Including means where you include the fractured vertebra into fixation. So there were in this study, they showed that actually the outcome is far better in including one. The implant outcome is almost similar, but implant failure rates are very high in bridging one. And so the inclusion has advantage, better kyphosis correction and maintenance, fewer failures, no additional complications, and outcomes are comparable to bridging construct. But there are limitations of short segment fixation. You know that more instability or deformity or poor bone quality, it equates to more failure of short segment fixations. So in such conditions, you should be very, very careful, and you need more points of fixation. And sometimes you need to add up anterior stabilization in form of cage. And also you should be careful in patients with ankylosing spondylitis, DISH, RA, osteoporosis, and malnourished patients because the bone quality is poor. So we come to the last issue, whether we need to fuse or not. So this was described first in 1999, where they showed that there's no need to fusion. Most outcome is same, whether you fuse or not. And this is another recent meta-analysis where they have analyzed various studies, and they showed that there is a similar outcome, whether you fuse or not. In fact, increased surgical times and higher intraoperative bleeding in fusion cases. So these results really raise the question whether you need to fuse in thoracolumbar burst fracture or not. So coming to my case, here you can see it was a burst fracture, unstable, disrupted PLC. Short segment fusion was done, results were good. And this is with associated fracture dislocation. Hence, a slightly longer construct was used and results were acceptable. So we can conclude that short segment fusion is effective in treating most of the burst fractures where we need to operate. Placing screw in fractured vertebra is biomechanically superior. Fusion is often unnecessary and better avoided, but SSF must be avoided in highly unstable dislocations, poor quality bones and ankylosing spines. Thank you.
It's very unfortunate that such a session, we are not interacting with the speaker and the audience because of great paucity of time, but this needs to be corrected in future. I now invite Dr. Ram Chadda, spinal surgeon from Mumbai, for his talk on fracture dislocation, thoracolumbar spine.
Good morning, everybody. Respected chairpersons, dear friends. Fracture dislocation of the thoracolumbar spine. I'm indeed most privileged to be here sharing what I have learned over the last 3 decades in managing these very complex injuries. Let's look at a 30-year-old gentleman with traumatic paraplegia, burst fracture of L1 with more than 50% canal compromise. The plain images were shown to you. This is what the MRI looks like. What's the way forward? The way forward is reduce the deformity, clear the spinal canal, stabilize with minimal levels of fusion, and have early rehabilitation. Neurological recovery, mind you, is a bonus and is not promised. Evaluation of the injury. All burst fractures are 3-column injuries, anterior, middle, and a posterior sympathetic breach or break in the column. Traditional treatment 30 years back was posterior instrumentation, and I followed the same. We used the Harrington rod. We used Sir Arthur Steffy's VSP, variable screw placement. We then used the screw rod constructs made overseas and then in our country. And we found, as mentioned by the previous speaker, large incidence of implant breakages and give way. What are the drawbacks of a posterior instrumentation in such injuries? You need a minimum of 2 levels, Kefalard and Cordard, is what literature said at that time. There is a posterior indirect ligamentotaxis, which may or may not adequately decompress the canal, and you may need to open the area, or you may need from the posterior side an eggshell procedure or a posterolateral decompression, which means handling the theca and subjecting it to a second insult or a second injury. What were the other things? Well, if you used short constructs, as mentioned, there was a large incidence of implant failure, screw breakage, and kyphosis. And this is because there is a posterior cantilever which works and the anterior middle column is not really supported. Hence, we swung towards additional anterior instrumentation. We did direct anterior decompression. We believed that it caused better neurological recovery, and so did people like Bradford Sado. McAfee also said that we should do an anterior strut, and we swung from posterior to anterior to a situation where we started doing all anterior. We combined what we found there, the local bone which is fractured and the rib which came as an axis of the surgery, and put all that morselized within a cage or a large strut if you went with the iliac crest in the less affording patients. Having said that, a lot of these surgeries showed better fusion, showed better neurological recovery at times. Hence, we started believing that this is actually a less morbid procedure, although most people said a thoracotomy going transpleural causes more damage than good. We surgeons found that anterior or anterior plus posterior as a global stabilization gave greater neurological recovery and lesser residual canal compromise on CT. Uninstrumented fusions were not done anymore, and we combined back and front, and we did it in various ways, more than one. We also started putting this mesh cage from the rear to the front and did not necessarily do a separate back and front incision, did both the surgeries from the rear. Coming to what has been spoken of, the middle column is the most critical. It is the one responsible for both the mechanical and the neurological damage, and our aim should be to set that right mechanically and hope that the neurology recovers. Please remember, surgical decompression and stabilization should reconstruct the middle column, and that's most important. Neurological recovery is usually determined at the time of primary damage. Timing of surgery at times in irreversible situations does not matter, but in reversible situations is critical. That's the AO classification. We've all spoken about it. The TLEX has also been spoken of. Now let's move to the more complex injuries of the C2, C3, where on the APV also there is a lateral subluxation. That means it's a true fracture dislocation. In these, we need back and front because we have to correct the frontal defect or the lateral subluxation. It's more like a fracture dislocation. Hence, look at that. That's an almost concertina collapse, and it's a young patient. It's not an old patient. That's how much it gets corrected if you go in within the first few days. And hence, leaving it alone, such an unstable situation, so easily getting corrected by positioning and implant placement is unstable.
You can't leave it there. So you have to do an anterior reconstruction, and that's what we started doing. This may be an overkill for A2A3 as spoken by my previous speakers. Hence, whatever you do, it's a tension band from the rear, which supports the anterior axial loading, which is 80% by an anterior middle column reconstruction. Hence, global stabilization is a key. Approach choice is yours. This is what I did in the late 80s to early 90s, moved on to the early 2000s, and that's the way we moved forward. We swung from back to front to only back again. We use autograft from the rib and the bone graft, as I said. In between, we got further carried away. We said minimally invasive for everything. So we did. We even slipped in these implants, minimally invasive, but not at the compromise of doing a good decompression and an instrumented fusion. A lot of my friends who said anterior surgery is overkill, not warranted, said all these things. You need an access surgeon. It's a more morbid approach. It can cause vascular injury. There's more blood loss. There's more time taken. Associated pneumothorax, hardware prominence. All this for the anterior. This is exactly what happens if you do a poor posterior and not a poor anterior. Look at this patient. I think this needs an access surgeon. This is a far more morbid thing that you've done. Not one screw is in there in the right place. This must have been huge blood loss. Time must have been humongous. There was surely pneumothorax, and hardware here becomes prominent, never from the front. So balance it. Systems don't fail. It's the way you do it, the technique which fails. And mind you, ladies and gentlemen, there's huge radiation that's there in the posterior surgery vis-a-vis anterior. You're doing a young patient or yourself or your nursing staff, you don't like radiation. So where am I today? And these are the last 4 to 5 of my slides. 1, if I'm dealing with a situation which is intrathoracic, D11 or above, where there's a rib cage in addition protecting what I do, well, I prefer to go only anterior. To a mini thoracotomy, do a decompression, put in a nice cage, get my bicortical screws, which may be a single screw rod, but getting bicortical with a staple or a washer there. All this is after you're doing a good decompression. When I'm doing thoracolumbar junction, but without a PLC, my dear friend spoke about the PLC injury in the TLX classification. In that situation, I go from behind, a small minimal access, and then a mini anterior and a decompression, small here, small from the front. I prefer a back and front separately because I take lesser time doing that rather than struggling to put my implant from the rear and actually retracting the theca in an incomplete deficit. However, if the PLC, posterior ligament complex, is injured, I do a good back surgery with a decompression and a good anterior surgery with a decompression. Minimal access, that's all that we've done, but stabilize it more rock solid, both front and the rear. Coming to upper lumbar now, which is you've gone to L1, L2, L2, L3 now. In these, again, I swing back to anterior because I want to preserve my motion segments in the lumbar spine as far as possible. And I go in, this is retroperitoneal, maybe a little bit transthoracic if necessary, depending on where your diaphragm is, and do an anterior, but a dual rod construct here. There have to be 2 screws and a dual rod because lumbar spine is far more mobile and unstable than an intrathoracic D11 and above. However, if it's a complex thing like in this, the patient was actually decompressed, unfortunately, at the rear and then sent to me 48 hours later. And I had to do a both reconstruction at the rear and at the front, where I've done again short segment. Why have I done short segment? And a good job is because I'm trying to preserve as much of lumbar motion as possible. So it's a back and front in situations like this. Finally, I'm pretty certain that you are confused with all that I've said. There's one way that you do it. There's another way that I do it. There are no correct answers. It's a perception. At the end of it, what works well in your hands for your patient. So that's your way, my way, and the correct way is somewhere in between. What did I learn in these 30 years? Well, I learned good results come from experience. Experience, unfortunately, only comes from bad results. Think about all I've said. Look back at your patients, and if you feel that you can preserve motion, you can get solid fusion, use less implants, and hone skills to do back and front surgeries, think of it as a good option. Thank you all for a patient hearing.
Thank you, Ram, for completing your talk well within time. I think I still have more than a couple of minutes. left for your talk. Any questions from the house? The very, very important topic of dorsal-lumbar fracture. I have a short question both for Ram and Vishal. The management of thoracolumbar fracture in an ankylosed spine. Very controversial. Your comments, please.
So ankylosing spondylosis can present with a true traumatic fracture and with an Anderson type of a lesion. These are the two situations where they come. If it's a true traumatic fracture, well, treat it like you would treat a fracture this way, but understand you're dealing with a long bone with a single mobile segment. So you got to have a much larger construct above and below, and you're actually not sparing any movement because there's no movement there to spare. So use a longer construct, treat it like a long bone fracture. That's one. And mind you, if it's presenting early, there's no real need to add additional bone graft. It's just immobilization, and that's all that is needed. However, if they present as Anderson lesions, which have been growing over a period of time with incomplete neurology, first and foremost in our country, you need to get that thing out, clear off that place, send it for a biopsy. A lot of people with ankylosing also have tuberculosis of the spine, and we need to biopsy that and rule out that there is a tubercle overlying, and probably, if necessary, shorten or add a little bit of bone graft there. That's what I do in those which are Anderson type of lesions. But acute Anderson is going to be treated like an acute fracture. Vishal.
I think Anderson lesion or fractures in ankylosing spine is a completely complex and a different problem. Like Harshit very validly mentioned that there are stable and unstable fractures in normal thoracolumbar fractures. But in ankylosing spondylitis, a fracture is always unstable. There is nothing like a stable fracture in ankylosing spondylitis. That is rule number one. So they are all most of the times unstable because it's a chance kind. It is like a chalk. May look like a strong bone, but it is grossly osteoporotic. So the chances of your implant loosening is very, very high. And the third part is that you have to use long constructs. There is nothing called short fixation in ankylosing spondylitis because like Dr. Ramchandra rightly mentioned, a long bone fracture, you cannot use 2 screws above and below on a plate. You always use either 4 screws or 3.5 screws above, 3.5 screws below the fracture line. Similarly, in ankylosing spondylitis, treat them like a long bone fracture, have multiple anchor points. These are the 3 basic biomechanical rules for ank spine. Yeah. That's how I would take it.
Okay. Thank you. Thank you very much. So we now move over to the next.
Vishal is the speaker.
Pardon?
Yes, Vishal is the speaker.
Yeah, thank you. Thank you so much, sir.
Sorry.
Yeah, please proceed with your talk.
My fault.
So we are changing gears from normal thoracolumbar fractures in a young individual to fractures in osteoporotic spine. And believe me, when I change this transition from young patients to elderly, the whole world of management of fractures changes. You cannot treat these fractures like you treat it in young patients. The biomechanics are different. We are not here to discuss about the biomechanics of fracture management in osteoporotic spine. I am here to talk about a completely versatile and dynamic physiology of osteoporotic spine. And why are we actually sitting here discussing about osteoporosis? Is it because there is a company guy who's sitting there sponsoring one of the sessions in this conference on teriparatide or denosumab? No, answer is no. Because the impact of osteoporosis is not only humongous, but it is also growing. Many of us would grow to 80 years, 90 years. We have some very, very senior guys with us, Dr. Dheer, respected sir here, Dr. Tanna sir, Dr. Subhu Mukherjee sir, and many of us would grow to that age where we will surely become osteoporotic at one day or another. And mind you, the overall impact of osteoporosis is bigger in today's world, and that is the impact or the morbidity of osteoporosis in today's society. And you will really be happy to know, but with despise I mentioned that by the time CG IACON ends, we will have already had 1,000 new osteoporotic fractures to treat when we are going from here to home. And these would be in various forms, and all of them would be osteoporotic fractures. And the impact is such that by the time we reach home tomorrow night after CG IACON is over, 18% of implanted prosthesis and implants managing these fractures would have already failed. And we would have probably not realized only that they have failed. And today, like Dr. Trikha this morning was talking about damage control, in osteoporosis, the damage control today is try not operating them till it is not absolutely an emergency, because you are probably creating more morbidity for such patients, and treat them medically optimally before you plan any kind of surgery in these patients with osteoporosis if you don't want to see such failures coming to your practice. So the question arises, can I not treat them optimally? Have I not been treating them optimally already? Have I not been giving them alendronates? I have been giving them calcium. I have been giving them vitamin D. Isn't that enough? The answer to this is a strict no. That is not enough. Optimal treatment of osteoporosis is a completely separate chapter. And I really wish and hope that at the end of this talk, we are able to carry on some messages from here. And these are rules. These are not only rules. This is the verdict that optimal management of osteoporosis has to follow these rules. And these questions, when they come to your mind, that what is optimal medical management? These questions should be answered optimally. When do I start treatment for osteoporosis? What do I start? Bisphosphonates, denosumab, or why don't I just give teriparatide in every single patient? How do these work? I'm sure that this is already known. When to use combination and when to use solo therapy? How long can I treat? Like Dr. Didi Tanna sir is watching on the phone there, Dr. Dhi sir is watching me. Will they not develop osteoporosis now? And after 5 years, even if I treat them with bisphosphonates, what will I give them after 5 years? How long can I give them? So when do I change my treatment is another question. And if I am putting them on some kind of osteoporotic medication, how do I monitor this treatment, whether this treatment is working in them or not? So just to bring the problem of medical management of osteoporosis is all about problem of plenty. We have so many options and none of them is written in black and white. Probably we'll come to some black and white rules from here. So the rule number one for medical management of osteoporotic is start early and prevent fractures. And that happens only by general care. In a research study by Cochrane, 1 lakh individuals were given this general care, and it was seen that 90% of those individuals didn't develop fracture, which is such a huge thing. You have prevented osteoporotic fractures by just giving this general care, which means prevention of fall modalities. If you see an elderly gentleman or a lady into your clinic, please tell them to get some of these measures at their home, that their bathroom should be lit, because 90% of these falls resulting into osteoporotic fractures happen at night when they are getting up from their beds, they're looking for their lights, walk into a washroom which is wet, they slip, they have a fracture. So if you can have adequate lighting at home, no mats, dry bathrooms, a light always there, bed switches around their bed, a glass of water kept there, they don't have to get up and have a fall in there. And this is something that is absolutely important. So every individual 60 plus, please try to give this general care. You'll be able to prevent 90% of these fractures. Walk into a clinic later date. When to start? Start at the earliest. You do not have to wait for a fracture to happen to start anti-osteoporotic medication. A 50 plus lady, already post-menopausal 5-year plus, WHO has recommendations. FRAX score mentions that 5-year plus menopausal is an indication to start anti-osteoporotic medication. And it can be as simple as start with high protein diet, calcium, vitamin D supplements, and then put them on bisphosphonates. 5-year plus post-menopausal, don't wait for a fracture, start anti-osteoporotic medication. Of course, there are rules to start. How to start, we will go to there. Now remember, when you plan to start bisphosphonates, you cannot start them just empirically. Yeah, आया है तो ले bisphosphonates खा. ऐसा नहीं चलता. Bisphosphonate is a serious medicine, and you cannot just start them just like that, because bisphosphonates can have their own problems. We have all seen jaw getting avascular necrosis, hip bones getting into non-union, and that is why there is a check called feasibility check, whether these patients will really benefit from bisphosphonates or not. And that is why a baseline check in the form of check calcium, check PTH level, check alkaline phosphatase level, check creatinine level, check whether they have any asthma, gastric issues, or blood thinners, because all these patients having any of these, you're going to have a major problem starting them on bisphosphonates. And these are the candidates where you would want to rather go on denosumab. So always do a feasibility check. And if any of this is positive, please don't start them on bisphosphonates. Also remember, though anti-resorptive bisphosphonates are first line of treatment, they do not form new bone. So please don't start them in acute fractures. A patient with spine fracture coming acutely to your clinic, or a patient with hip fracture walking recently, or wrist fracture, please don't start a bisphosphonates for first 3 weeks. That's the phase of bone resorption, which will be increased by starting a bisphosphonates in them. So after a feasibility check whether the patient is really fit enough to undergo this kind of treatment or not. Remember, it only prevents bone resorption. It should not be used in acute fractures. Please don't use it in young patients. Always do a feasibility check and always follow them up in 12 months' time, asking them about these problems. So this is the basic rule when you start any kind of alendronate, whether it's a yearly, daily, or a weekly regimen or a monthly regimen. Please follow these basic rules whenever you're planning a bisphosphonate therapy. So if these are so effective and there are rules, when do we start denosumab? I think denosumab is a wonderful drug, but it is to be used for maintenance therapy or in patients where there is a contraindication for starting any kind of alendronate. So this is that medicine which also doesn't form new bone. It only prevents bone resorption. It is as good as any bisphosphonate, but it's to be given in an injection form once in 6 months. So it should be used only in patients where there are bisphosphonates contraindicated, or you have burnt out bisphosphonates where 2 saal ka bisphosphonate is done. What to give? Denosumab at 6 monthly interval. You can give it for 5 years, 7 years. The data is already available there. It can so far be used 5 years effectively. And it reduces risk reduction significantly. I am not here to debate about the efficacy, only how is what we are talking about. The wonder drug is teriparatide, but should we use it in every single patient? The answer to this is no. This is a drug which is reserved for patients who have very severe osteoporosis. Please don't burn out this option today in your fracture patients or in young patients. This is a wonderful tool. Keep it saved for the day to come. It's only when the war zone happens you would want to use this nuclear weapon in your hands. Don't burn out the benefits of teriparatide. Once used, it cannot be used again after 2 years of therapy is over. Now again, you cannot use it in every single patient. It leads to formation of new bone. The physiology is wonderful. It results into good bone union. It results into prevention of fractures, but you should not use it more than 24 months. And also, please don't use it in patients with hyperparathyroidism, low calcium levels, high alkaline phosphatase levels, and high creatinine levels. So again, there are certain contraindications where you should not use, and that's why a baseline check before starting teriparatide is absolutely important, whether the calcium levels are adequate or not, because patients who have infection, metastasis, hypocalcemia, alkaline phosphatase high bone turnover, or for that matter, a borderline high serum parathyroid hormone will develop major problems with this drug, and you will have failure of this drug. You would have lost the nuclear weapon which can treat osteoporosis very, very effectively. So do a feasibility check for this drug also before you start them. And again, it has wonderful benefits to it. And now the question is, which one to start when? The answer is start as early as possible. In asymptomatic individuals, start with bisphosphonates after feasibility check. When you have burnt out bisphosphonate, use denosumab as maintenance therapy, and teriparatide only when the DEXA shows minus 3.5 T-score or below, or when a patient has obviously had a fracture of osteoporosis defined. How long? Osteoporosis is not going to be treated. It's a lifelong measure and you have to treat them lifelong. Unfortunately, the drugs can only be used for a certain period of time. However, general care, these osteoporotic patients are not only low in bone mass, they are also low in muscle mass. So developing their muscle mass, sarcopenia is a term that should always be associated with osteopenia. And that is why developing muscle mass using high protein care and also other measures is very, very important in the form of exercise and other things. But the duration for drugs, unfortunately, so far is limited. How to monitor therapy? Alkaline phosphatase is the simplest way. Serum calcium is the simplest way. Monitor serum parathyroid hormone whenever you're giving teriparatide. Any fluctuation, please stop them, because this is something you can actually be looking at a disaster in making. Solo or combined? Always combined in patients who already have a fracture, but solo always in a patient who's asymptomatic and you're starting for prophylaxis. And when to change therapy? When you know that the serum calcium and bone markers are not showing any benefit, patient is not having any clinical benefit or has developed a fracture on treatment, you would want to change the therapy in such patients, or BMD is worsening despite treatment. So the answer is treat early, treat optimally, and manage these patients medically so as to prevent any such fracture or your implants failing in future. Thank you so much, Chairman.
Sure, sir, sure. Take it easy.
Mic, please, mic.
So Tanasar is 85 and he's still not on any bisphosphonates. The answer to this is because men like him don't develop andropause ever.
The newer thoughts, Vishal, as you start with bisphosphonates. The empty walls you are trying to preserve. So the newer thoughts is first build up the walls, collect the money, and then try to save it. So there are quite a few people who have started thinking, if you are treating osteoporosis, start with teriparatide, build up the bone. Because all the bisphosphonate does is try to reduce the loss. Same thing is about the other drugs. So that is the reason why the newer thoughts are coming, that when you start with 2 years of teriparatide, build up the bone, and now use everything else to preserve that bone.
True that, sir. So if you have an empty bank, put some money in the bank, and reduce your expenses is what sir is saying. And what I am saying is also the same. When you have a fuller bank, stop losses when your bank is still full. Start early. So if you start early, your bank is still full. And if your bank is still full, unfortunately, teriparatide cannot add further money to your bank. So what sir is saying that if your bank, bone bank, is already vacant, fill and prevent losses. Prevention of losses is with bisphosphonates. Filling of money is with teriparatide. And I am probably a little aggressive because I tend to catch my patients a little early now. We have learned from the failures of sir and sirs. So I know that if you catch them early, you will have a fuller bank and you only have to cut the losses there. So bisphosphonates for 2 years, prevent further bone loss with general measures. And actually teriparatide comes into picture. It's the nuclear weapon. It actually comes into picture when it's really needed there.
Thank you. Thank you very much, Vishal. Thank you, Vishal. May I now invite Dr. Kar from AIMS Raipur for his talk on osteoporotic fracture, vertebroplasty tips and tricks, when, why, and how.
Respected chairpersons, esteemed delegates, good afternoon to all of you. Before talking about vertebroplasty, we should talk about the osteoporosis. The aging population in the worldwide is a big problem now. If you estimate in 2021, there is 1.4 billion people are more than 60 years. Though now the aging, old age is defined as more than 75, but more than 60 years is 1.4 billion people. So what it is a micro-architectural deterioration of the vertebra, and also in making them vulnerable to the stress fracture, that's known as fragility fractures. So besides that, we can have other problems like metastasis, multiple myeloma, and other space-occupying lesion, where we can go for that procedure. The spine is the major site for fragility fractures, and vertebra, the most common site for metastatic bone fractures. And it leads to chronic bone pain, midline, axial pain, non-radicular pain, and the risk of further vertebral compression fracture increases around 20 times after a single vertebral compression fracture. So it leads to height loss of making the patient more lordotic, kyphotic. Then the 12-3 will come down to the iliac crest. There will be decrease of the pulmonary functions. One single vertebral compression fracture leads to 9% loss of pulmonary function capacity. So what to do? Either you do a conservative treatment or surgical treatment. That has been discussed already. So coming to the vertebroplasty is a vertebral augmentation by cement, bone cement. It is usually done by a percutaneous method. Now it has been modified by cement augmented screw. It is some sort of accessory method of vertebral augmentation, but the principle is the vertebral architectural augmentation by bone cements. So except fragility fractures or osteoporotic fractures, it can be used in multiple myeloma and others, osteogenic imperfecta and Gorham's disease, that is your vanishing bone disease. So indication is mostly if there is a fracture, fragility fracture of the vertebra, and it is more than the pain persists for more than 4 weeks at least. We usually do it in 2 to 3 months post-trauma, and severe pain, incapacitating pain, patient is unable to sit and walk, and these patients are axial pain and your midline pain, non-radicular pain. These are the ideal patients to pick up for vertebroplasty. So besides that, lytic bone lesion, hemangioma, and other metastatic bone disease can be also treated by vertebroplasty. So these are the cases we can be selected for a case of vertebroplasty. And contraindication if there is a bleeding disorder and pain with radicular pain, neurological deficit, and there is pole general condition so that patient cannot be prone for a pretty long period. So in that case, we can avoid this type of procedure. And the lesion, when if it is more than T6 level, above the T6 level, these are high incidence of other diseases like metastasis secondary. We should avoid these type of procedures. So disruption of the posterior vertebral wall, when the axial cut in CT, the posterior border of the vertebral body, if it is disrupted, that is a contraindication for vertebroplasty. So patient selection is very important. What to do, when to do, which patient is to be done, and patient should be able to lie prone for 1 hour at least. It should be done under a local anesthesia. Complete blood profile so that bleeding, there should not be any bleeding disorder. Informed consent about the complication of the surgery must be mentioned to the patient. And the CT imaging is essential to know the axial section of the vertebra should be taken so that we can know the posterior vertebral body should be intact. O-arm or plain C-arm can also be helpful, and it can be done under local anesthesia, minimally invasive procedure. We should monitor the blood pressure and heart rate, pulse oximetry. And orthogonal X-ray is very important, because if it is in osteoporotic, there is some sort of scoliotic changes is also there in old ages. So we need to have an orthogonal C-arm images. So the pedicle should be clearly visible, and there should be true AP and lateral images should be there. So the pedicle should be clearly visible, the end plate should be clearly visible, and the spine should be symmetrical at the center, and this pedicle should touch to the upper part of the end plate, upper end plate. Then only we should proceed for this surgery. So 3 things are most important. So what is the entry point, then is your trajectory, then your advancement. 3 things are important. If you want to see the diameter of the pedicle, you can take an end-face view, tilting the C-arm a little bit. And the entry point is very important. Why? Because if we are going directly end-on view, then we may perforate the vertebral body anteriorly, and the anterior, the vital structures out, and vena cava is there. So we should start from little laterally so that it will go right into the center of the vertebral body. That is the thing. And it should be obliquely placed towards the inferior border of the body so that we should not hit the spinal canal. So if you are doing in a thoracic spine, you may do a parapedicular approach also. It is same shape, similar to the transpedicular approach in what we do preferably in thoracolumbar and lumbar area. Parapedicular approach is also equally safe. So cement should be prepared after the needle placement, the trocar placement. Trocar advancement is very important because 3 things are important: the entry point, then your trajectory, then your advancement. Why advancement? Advancement is when you are touching the medial wall of the pedicle in an AP view, when you are touching the medial wall of the pedicle in an AP view, you must touch the posterior wall of the body in lateral view. Before crossing the posterior wall of the body in lateral view, we must not violate the medial wall of the pedicle in AP view. That is the most important step for advancement of the.
Dr. Kerr, kindly try to finish it short. You are overdue.
So complications What there may be a transient increase in pain. There may be infection, which is very rare. Leakage of the cement is the dreadest complication. It may leak into the spinal canal, or it may go for embolism also. So that's the only two complications. Otherwise, it is a safe surgery. Like other spinal surgery, it is also associated with some sort of controversy. The US Preventive Surgery Task Force also do not recommend this type of vertebral augmentation. But now the world literature has said it is a very beautiful method for prevention and pain management for fragility fractures. So kyphoplasty only we do the inflation of the vertebra because it is already a kyphotic fracture. Otherwise, it is the principle is same as vertebroplasty and kyphoplasty. Thank you. Thank you for your question here.
Thank you, Dr. Vikram. And now I would invite Dr. Ram Chadda for the last lecture of this session of the spine. You would be talking on the osteoporotic fracture with the neurological deficit. Dr. Ram Chadda, please come. And everybody is requested to remain in the hall. After this session, we would be having very important session that would be the delivering of the oration. So please remain inside the hall.
Good afternoon, everybody. Respected chairpersons, dear friends. Osteoporotic fracture with neurological deficit. It's extremely uncommon to have a neurological deficit with every osteoporotic fracture. In fact, you have to be very, very vigilant and have a low threshold to pick up one. Why do we talk of osteoporosis? It's no more a silent disease. It's a thunderstorm. As we saw between these two very valiant warriors, Dr. Tanna and Dr. Kundani some time back, that it is something that we can argue and keep arguing for the rest of our lives. However, if we have to be like these three senior stalwarts that we spoke of, have graceful aging and add life to years, we have to prevent, and if not possible, treat a trivial fall. It's not uncommon to see at the end of 3 weeks of a trivial fall, an elderly patient being brought by an attender or a family to a patient's general physician and an X-ray shot, not very clear, and then finally reaching an orthopedic or a spine specialist at 4 to 6 weeks with excruciating thoracolumbar junctional pain, some referred pain to the SI joints, and at times a radicular pain in the subcostal region. We've spoken about minimum rest to these patients, suitable medication, whether it is bisphosphonates, denosumab, teriparatide, one or all, pain relief with the help of splinting, bracing, painkillers, and if necessary, physiatric therapy or pain blocks. But we very often forget that a lot of these patients are painful and have mild deficits which are creeping in, which happen when they sit or stand and walk. You can have a patient lying down in the anti-gravity position, has an active SLR, can move her toes, and I say her because it's more common among women. But the moment you make them sit, they get paresthesia, weakness, and may have even early sphincter, bladder bowel abnormalities. Hence, whenever you see such a patient, subject them to a sitting and supine film lateral shoot through supervised. Do your entire gamut of all investigations, including a serum protein electrophoresis, get an M-band done, get a kappa, lambda, light chain ratio done, rule out multiple myeloma. It's more common than you think it is. And if necessary, with neurology, plan an MRI, and if you have an attached suite there, get a local CT of the area done as well. Medicines, as I've said, has been spoken of at length, and they will still be the basic line of treatment. Please remember, just like AKT is important in TB spine, medical management is equally important in osteoporotic vertebral compression fractures with or without neurology. At 6 weeks, if they have that incomplete neurology, pain,
and you do an X-ray or an MRI and shows this fluid cleft or a cleavage sign, also known as a Kamal sign, that means this is now becoming a pseudarthrosis. At this time, you as a team need to put your minds together, physician, surgeon, anesthesiologist, all together. Why are we now going to do something that we want to do? And only then you decide whether it's local anesthesia, whether it's cement, whether it's screw, whether it's screw with cement, all that comes in later. But does this patient need intervention? What's the purpose of treating such a patient? It's pain, instability, neurology which has crept in, a deformity either impending as you see in that image or present, and severe osteoporosis which may be treatment naive patient, T-score -5 and you're in big trouble. What are the challenges? These patients are unfit for anesthesia. They have residual pain despite whatever you may do, and there's huge early and late morbidity. You may lose them within a year of any surgical procedure like you lose most of your fracture neck femurs. Hence, what do we do? As mentioned by my previous speaker, percutaneous cement augmentation is the best, but with an intact posterior cortex. Do we still do it with incomplete neurology? Yes, you could, because there are times when the intact posterior cortex is actually causing a mild dynamic internal gibbous imposition, and you may actually foreshorten it by putting a little bit of cement, 2 to 3 ml in the front, and yet get an indirect decompression with a posterior dynamic stabilization. We can do a combination of any one of these procedures, and I shall go through them one by one. Cement augmentation mentioned by my friend, cement augmentation percute with percute screws, open surgery with a posterior decompression, open dynamic steady stabilization, a conventional surgery but with cement augmentation, long construct as mentioned, ankylosing spondylitis and osteoporosis, and finally a salvage when nothing else works, stainless steel ring, hard shield ring with sublaminar wires. When do I do my vertebroplasty? Well, it has to be 6 weeks minimum. I don't wait for just 4 weeks, more than that. Local anesthesia, I use 2 image intensifiers. Give it a thought. If you have 2 machines lying there, use them. How much cement do I put in? Well, whatever I aspirate from that fluid, if it's 3 to 5 ml, I should have a threshold of 2 to 3 ml going in. Remember that. What you aspirate, which is usually clear, sent for cytology, that's the amount of cement that will go in. Semi-solid cement is the best, and I use 2 ml syringes with Luer locks. I do it this way. This is how my C-arms are placed. And I'm standing next to the patient. Patient is under local anesthesia, not general. And you can do it. This is to avoid that C-arm going up and down. You position it once and for all, and you can do your surgery extremely well. Put in the local, decide. Like in this CT scan, I'm going to put in my needle from one side. And if one side fills it up all, I'm not going to put in from the other side. The side where there is a large vacuum, that's the area that I'm going in. You can do biportal if there are sort of necessity for larger vacuums, or if there are 2 separate voids to be filled. Always have 2 images at the same time, and I use this sort of a position in all my patients. And I fill it mainly through the front and a little bit to the middle column. I don't go beyond the second or the posterior half of the vertebral body. I also go very, very slow. I inject weight. If there's any extravasation, I ablate. I abandon the procedure. Next, where there is neurology established, indirect decompression, posterior long construct, at least 1 to 3 levels above and below. Maximum length of the screw. You can even go up and in. You can go percute. You can do staggered screws. You need not put them parallel. Do outside, in, out, the way you want. Do it the way you want so that you get maximum diameter and get your screws in various planes. Use a little bit of cement in front, and I have a threshold for shortening the vertebrae. Intraoperatively, if you have a contrast like iohexol available, you can put it and check whether you've actually done a decompression indirectly or not by seeing a free flow of the contrast from below upwards. If, however, you need more than that, like in this particular patient, I had done this lady's low back surgery 20 years back, and she came back with this very unstable, painful situation. She was just getting pain, no neurology, but I had to go in and segment it, put it in there. I did a little bit of cementing in the front and put in percute screws from behind and called it a day. She actually had moved to a non-walker phase more because of pain, but we were not too sure. She had some urinary dysfunction, which again, we were not too sure. So it's best to bite the bullet and help them get up and move around. This is what we did. There are times when you may want to do a posterior short segment or a long segment in situ. Whenever I do this, and if I'm doing it open, then I add transverse connectors. If I'm doing it percute, I don't put transverse connectors. Let's look at this situation. Again, done about 18, 20 years back, which collapsed over a period of time. A doctor's mother developed a pseudoarthrosis, came to me late with neurology, more like a pseudoarthrosis presenting at 6 to 10 months post-injury. She was trying to gum up, but she had neurology. So I had to go in and do a stabilization from the rear with a posterior decompression, standard surgery. However, do I do anterior reconstructions? No more with my cages, but I do a posterior shortening. That's how I reconstruct the anterior void or cleft. I go in, this is what the patient looks like, gets almost corrected. That's the one that I showed you in the traumatic. That's not what we do anymore. What we do now is we go in, do a posterior shortening. We've not been wanting or not needing to put anything anterior, and it works. The other way is the one there where we've gone in, put in a little bit of cement in the front, but accepted a foreshortened concertina collapse, done a good decompression so that you can actually get your columns, the one above and below, aligned without causing a secondary posterior compression with the overhanging lamina above and below. So this is to do a shortening procedure. This does not work in osteoporosis. These two situations will work. Shortening with or without a little bit of cement in the front. Finally, if you have those really severe -5 osteoporosis, how do you go in? Well, you have to do standard sublaminar wires with a heart shield, but here are certain points. Don't bite into the edges of the laminae. Whenever you're doing your interlaminar approach to put in your sublaminar wire, for those who do it, we tend to at times weaken. That's the only thing that is left strong, which is the edge of the lamina. So get in only by removing the ligamentum flavum, keep the intact cortices of the edges of the laminae intact, and then pass your wire from below and put a long construct. This is what works if you're doing sublaminar wires with heart shield. However, if you're doing cement augmented screws, go ahead. That's what I've done. I've used it. This is still very expensive in our country. If you're going to use these true percute screws with cement augmentation and fenestration, hence in our country, you still have a situation like this, go long. It's usually thoracolumbar. It does not matter if you've got to stabilize them for a very, very long segment. Go in, put in your large heart shield with sublaminar wires. They do well. They do very, very well. Believe me, you don't have to actually try and save motion in these elderly ladies. Accept this and they will do extremely well. My final message, subacute 6 weeks, vertebroplasty, dynamic instability with postural instability and neurology, as I told you. That means when they stand or sit, they get neurology, but lying down, they are good. Do a posterior indirect decompression. Instability with an obvious mechanical compromise. My orthopedic friend's mother, where she had a compression, I had to do a standard surgery from behind, but used long construct. Where there is instability, neurology with a deformity, yes, you have to correct the deformity. And what I use today is a shortening to correct the deformity rather than do an anterior reconstruction. Finally, suboptimal bone, poor T-score, not yet started on teriparatide. Patient had not visited Dr. Tanna earlier. So we go ahead and do a heart shield with sublaminar wires. Finally, you do that. You can celebrate your 100th birthday as my mother would next year on the 3rd of March. Thank you all for a very patient hearing.
Thank you very much. And unfortunately, as I told earlier, because of paucity of time, there is no time for interaction. So I would declare the session finished and invite others for the next session on orations. Thank you very much.
Our next session is for the orations. Please be remain inside the hall. Only 2 orations are there. One is Dr. Mahurkar oration and another is Dr. Dao oration. Please be seated.
I'd like to request Dr. Hemant Chatterjee sir and Dr. Prashant Dwivedi sir to kindly chair the oration.
पहली शॉल और मोमेंटो फिर लास्ट में सर्टिफिकेट.
Good afternoon, all of you. As you all know, this is a very important scientific part of our state conference. There are two orations. One is in the memory of Dr. Mahurkar sir, and another in the memory of Dr. A.S. Dao. These are the orations where we definitely remember and honor our very active members of Chhattisgarh. These orations are very important in the sense that this is they definitely serve the most important scientific part of the conference, and it has been awarded this year. Dr. Mahurkar oration is awarded to Professor Dr. Alok Chandra Agarwal. As you all know, Dr. Alok Agarwal is a very active academician of Chhattisgarh. He has been doing a lot of activity, not only in the state of Chhattisgarh, but in national and international level. He has delivered many lectures in the many scientific programs in and around. He is a past honorary secretary of CGOA and MPIOA, past editor JOTR CGIOA, CGIOA. IOA MP chapter fellow to Sayan Hospital, Mumbai in 1999. He is a J&J fellow of IOA 2002, WOC and CCOT fellow for Hong Kong 2008, IOA IOSUK fellow to London in 2008, Sri Ram fellow to TMH Mumbai in 2005, OOA fellow to Jagannath Puri, CGOA fellow to IOCON Bhubaneswar, IOA MP fellow to IOCON Cuttack. He has attended many international and national conferences, to name few. So we are very proud to honor this oration to Professor Dr. Alok Chandra Agarwal. Operation. Now I invite Dr. Alok Agarwal for his deliberations, solving the mystery of the unsolved fracture and Indian experience.
Dear friends, my seniors, chairperson, and colleagues, you all know what is the unsolved fracture. You all have been operating on fractured neck of femur. You all have been saying that it is full of complications and the results will be inferior. But that is the mystery which we have to solve. Just before I proceed, my teachers are sitting here. Professor Dr. Sudarshan is here, who is my teacher and guide in the thesis. And Dr. Subir Mukherjee sir is here, who was one of my teachers. And I bow to them before I start the oration. The oration is on the name of Dr. Vinayak Mahurkar. When I was doing a PG, suddenly a doctor shifted from Sector 9 hospital to Chhattisgarh. And everywhere the name was only Dr. Vinayak Mahurkar. Roaring practice. He was the first MCH coming with an MS degree from Riva Medical College. Very meticulous, very humble, very soft-spoken. I just visited his clinic to see what is there that he is having such a big name. And I found that you have to be into the subject right up to the depth. Each and every case you should be knowing the detail. Every case was X-rayed AP and lateral views, and he did not accept defeat. So obviously his results will be good. And that is what we tried, that we will also be following. And nowadays there is less of radiation. There is image intensifiers. There are more than one image intensifiers. There are O image intensifiers. So we can be more accurate. And if we are accurate, that is the secret to get the fracture neck femur having good results. I'll be telling you about the Indian experience. So as we all know, intracapsular fracture neck of femur is one of the most difficult problems to the orthopedic surgeon all over the world. Even today, it remains as the unsolved fracture in many ways, as far as the treatment and results are concerned. The quotation from Watson-Jones' textbook on fracture says that we come to the world under the brim of the pelvis and go out through the neck of the femur, which reflects a defeatist attitude that has long been held by medical and lay personals towards this fracture. The incidence of these fractures are increasing because of increased incidence of high velocity injuries. In the past, there was a search for an ideal treatment for these fractures. Femoral fractures occur in all the ages, more in elderly, and the solution is what we'll be discussing. In the paper on fractures presented before the American College of Surgeons in 1913-4, Kellogg Speed used the title, The Unsolved Fracture, for discussion of the intracapsular fracture neck of femur. He stated, this fracture was chosen for discussion because for more than a century, its treatment the results have been a matter of controversy and inquiry among surgeons. And because although the results obtained today show improvement, they are not at all comparable to those of other fractures. And the thing is true now also if we compromise. You all know that the problems in a case of intracapsular fracture of femur is non-union and avascular necrosis of the head of femur. And this goes along with restricted range of movement, limb length discrepancies, limb pain, and deformity. The problems arise due to a vertical placed fracture line, increasing the shear stress. Intrasynovial fracture line, external callus is washed away by synovial fluid. Posterior comminution, which brings about instability. A displacement of the fracture, which cuts away the blood supply. A small proximal fragment on which you cannot have a hold. And obviously, the age of the patient, the osteopenic bone itself. So the factors which we have been taking into consideration are related to the patient, related to the fracture, and related to the surgeon facilities. This part now has gone quite far off. And so we should not err on our decisions. So it is the age of the patient. We know elderly people, the bones is osteoporotic, and implant will not have a grip. They'll be having medical conditions. Some will be having diabetes, renal failure, hypertension, CCF. We have to operate all on them. You operate and discharge the patient, and there is no post-operative care. The patient lies on the bed, moves, goes to the bathroom on a weak implant. It comes out. So these are their economic status of the patient, cannot afford good quality things, social factors, and then associated injuries all bring an inferior result. We all know that fracture neck femur is a medical emergency. Ideally operate within 6 hours, nobody can. Within a day, 2 days, 3 days, that is acceptable. After 3 weeks, we take it as neglected. So the results will be dependent on the duration, depending on the fractional functionality. We'll be discussing the classifications, the quality of the bone, the status of head and neck. Previously in India, there has been a lot of discussion on the trabecular structure of the bone and where to get a good purchase. It is the reduction following the purchase which is important. And you all have seen this diagram. And you know the Singh's index, which is now gradually going out because it is not dependent on osteoporosis. But it is giving you a concept that there are trabeculae. If a screw goes in between, it will be having a grip. And the arcuate alignment in the transverse sections is the place where the screw head should be lying, which has been gradually replaced now with the tip apex distance. So this diagram was from my boss, Professor Dr. HKT Raza, who I remember during this oration, who has done a tremendous work on trabecular structures of the whole body. And you can see the areas of poor purchase on the top part, acceptable purchase in the lower part, and the strongest area of purchase. And if it is in the area of purchase, the screw will not walk out. It will not go inside and penetrate. So these are non-union with implant failure. It is on the table failure and avascular necrosis and absorption of the head. We all see these complications, and that gives us strength that there are always complications. You tell the patient, complications to hoga hi hoga, isme vascularity nahi hai. But no, there is a way out. The way is out is a meticulousness. Otherwise, you will have to go for a McMurray's osteotomy or excision arthroplasty. Discussing non-unions. Well, if you were giving traction and cast, still in 50% of the patients, the bone was uniting. If you went for internal fixation, the complications were only in 33% of the patients. And so now we have decided that we will be going for fixation. Blood supply has been taught to us coming from distal to proximal, and it gets cut off. What should I click here? If it gets cut off, the head will become avascular necrosis, but that is not exactly how it happens. You look at this diagram, you will see the heft is uniting, the screws are gradually coming out. They are three, they are sufficient. But actually the reduction, if it is not there, which is the secret, it is bound to happen. You will put multiple implants, try to prevent the rotation, but then you can see it is getting cut off. The neck femur diameter with the DHS never matches. Indian neck femurs are thinner. And so you get a loss of fixation. So the cause of non-union, avascular necrosis, shearing forces at the fracture site, absence of the cambium layer, giving no osteoblastic potential to unite, dilution of the fracture exuded synovial fluid, elderly people, and osteoporosis. So what are the solutions in India? And I will show you some of our work. And the solution is that people have been searching for a better implant. And before that, people were going for reconstructions. What were the reconstructions? Well, these are muscle pedicle bone grafting. I had a chance to learn muscle pedicle grafting and assist Dr. D.P. Bakshi, whose work is there in JBJS on this topic. I had a chance to work on muscle pedicle grafting with Professor Dr. S.C. Goel, whom I assisted and learned how to do it with the Sartorius-based muscle pedicle graft. I had a chance to work with Professor Raza, and we did a lot of cases, the standard Mayer's procedure. And we can see the difference in all of them. And there is a long series. Professor Nagy is known in the literature for a fibular grafter with a screw. And then Muller propagated the term going for an osteotomy, making the fracture line from shearing to a compression force. And if a late case comes with us with a Powell's grade 3, we all are doing this routinely. Novel had come with multiple pins so that there is less injury to the vascularity. And we all have used these pins, 2, 3, 4, several. Now we don't use them, but they still had some good results. And nowadays we use multiple cannulated cortical cancellous screws, and we know that it is meant
given us very nice tips to all our delegates, and I hope they will be benefited. Thank you so much. Our next oration is Dr. A.S. Dao oration. To deliver this lecture, I now invite Dr. Sunil Khemka, Senior Orthopedic Surgeon and past President CGIUA.
He is also director of Narayana Hospital. And he has developed some his special techniques in trauma, and we are going to benefit it, I believe. Welcome, sir.
Now we request Dr. Sunil Khemka to deliver his lecture on management of open tibial fracture by railroad fixators, undernail and plastic covers.
Respected Chairman, sir, and dear friends, I am thankful to Dr. Alok, Dr. Sakle and team of AIMS for giving me this opportunity to speak about Dr. Arjun Singh Dao. Arjun Singh Dao was our friend. He was HOD of Orthopedics in Medical College Hospital, Raipur. Arjun Singh Dao, a man who worked hard, worked like a machine with humanly touch to his patients in orthopedics. A man who is not among us, and I am privileged to speak about him. Arjun Singh Dao, my close friend of life, closest colleague, and philosophical guide and buddy who taught me more about life apart from orthopedics. He was my batchmate during MS when I got to know him closely since 1986. He has been an ardent academician and a very much disciplined contributor to orthopedics. He has been available for help to all the colleagues whenever needed, always smiling and giving humanly touch to his patients. Sadly, we lost him a couple of years ago, and he lost the battle to a medical illness. I am thankful again to AIMS team for providing me this opportunity to say something about Mr. Dao. Dear friends, I am talking about a new innovative technique of managing compound comminuted tibial fracture. These fractures usually occurs because of the high velocity road traffic accident, requires multiple surgery, multiple debridement, flap, bone grafting. And we all have seen in our practice that most of the time it end up with deformity, limb length discrepancy, joint stiffness, and disuse atrophy. To avoid all these complications, we have innovated a new technique of fixation with Andersnell and LRS system. Aim of management is to achieve anatomical reduction, provide stability, minimize infection with a stable construct, allow subsequent plastic surgery procedure and bone grafting comfortably, and permit early mobilization and achieve early union. The options so far with us are external fixator, but the disadvantages are anatomical reductions are not possible always, not able to bear weight many times, and it is not a definite mode of fixation always. Interlocking nail is a procedure of choice, you can say, in such fracture, but it requires adequate length proximally and distally for locking, and infection rate is also high in such severe comminution and compound fracture. Plate is out of question because soft tissue status is not like that to apply plate, and infection is very high, and plate will remain exposed in many cases. Alizaro has too much disadvantage in such a comminuted fractures, long segmental comminuted fracture, and it doesn't permit flap rotation, and it is very cumbersome also. Dear friends, in my talk, I am talking like this type of injury where there is a severe comminution, fracture is open like a book. What you will do? You just think for 5 seconds, what you will do in this case? Almost all of we will go for external fixator. Then the things will come in mind, what to do with this split fragments. Should we remove it? Then later we should do bone transport, or we should keep it there. There is a great chance of infection. These were our first case when we innovated this technique. We preserved all this fragment. We did debridement, passed retrograde Andersnell, assemble all the fragments with cerclage wire around Andersnell, and further construct has been forced with LRS system. Alignment and length had been maintained with Andersnell and LRS, and cerclage wire applied. After 3 months, we observed that there was no infection. Meanwhile, gastrocnemius flap had been done and wound became absolutely all right. After 3 months,
request all our members to please go ahead with all you, whatever you are doing, document it properly and present it before us, so we can learn from your experience and the new techniques. Thank you so much once again.
Thank you, sir. And thank you, the chairpersons, for chairing the session. For the next session, we have on fractures around the shoulder. And I would like to request Dr. K.M. Kamble, sir, Dr. Deepak, sir, and Dr. Bodhiram Patel, sir, to please chair the session. The first talk is by Dr. Klein Dentist, sir, on sternoclavicular injuries. Sir is an assistant professor here at Department of Cardiothoracic Vascular Surgery at AIIMS Raipur.
Very good afternoon to all of you. So this session is around for the fractures around the shoulder, and the first speaker is Dr. Klein Dentist. He is assistant professor in the Department of CTVS AIIMS Raipur, and he'll be delivering talk in sternoclavicular injuries. Dr. Klein.
Yes. Good afternoon. So I'll be speaking on a sternoclavicular injury, which is a rare injury where we come across mainly when we operate on when we see the patients, especially in trauma unit, coming with hemothorax, pneumothorax, and rib fractures. So just a basic anatomy. You have saddle joint here, which is a sternoclavicular joint, and you have the articulation with the clavicle as well as manubrium sterni and the first superior surface of the first rib. And the joint stability is maintained by sternoclavicular ligament as well as costoclavicular ligament and your articular disc, which surrounds the ligaments. The introduction for here, the topic is that it's very uncommon and very rarely seen. You see only in the 3 to 5% of the injuries to the shoulder girdle. And the most common presentation etiology is traumatic and dislocation. Usual presentation is in the form of sprain, and dislocation is usually anterior. Very rarely you find it on the posterior aspect. If present posterior, you find with a catastrophe or a very vascular injuries or a nerve injuries. The most common mechanism of injury is road traffic accident, which we see here, as well as sports injury, very less uncommon here, we can say, and fall from height, as well as a blow to the shoulder, which is seen on the lateral aspect. And how do you grade this injury, sternoclavicular injuries? The most, you grade it as mild, moderate, and severe. In the mild form, the joint is stable and ligament integrity is maintained, and this is the most common presentation we see. And the moderate, you have a joint subluxation with a ligament disruption partially, and the severe form, you have a joint instability with complete ligament disruption. The most common clinical presentation we find it is the pain, swelling, and tenderness. We see, and the trauma unit we find usually with the presentation with the pneumothorax or hemothorax, what is the most common presentation we see. And the clinical assessment, you can find the crepitus at the site and a range of limb movements, especially in the supine position. You have examination of the pain as well as a neurological examination if you are suspecting a brachial plexus injury. What is the diagnostic test? The most in the X-ray view, usual X-ray view, what we can see the fracture is in the like tilt view, that is a 40 degree serendipity view, as well as anic view. Anic view, where you can see the tangential dislocation of the fracture buried, and the investigation of choice is CT imaging. If you have to look for a mediastinal structure, if you have to look for any lung window or any pneumothorax, hemothorax associated injury, CT is the investigation of the choice. And the treatment, usual treatment is depend on the grade. If it is a mild, you usually give ice therapy as well as a sling immobilization. And in moderate, you have a figure of 8 brace, clavicle splint, as well as the immobilization for a certain period of time, like 4 to 6 weeks. And in the severe form, you have usually it is classified into anterior dislocation and posterior dislocation. In the anterior dislocation, close reduction, as the orthopedicians do in the perform the procedure under a GA or under a short GA, and followed by a brace. The most you perform it in this way, as we have performed very. And the operative procedures. What are the operative? This is from the thoracic point of view. What the operative procedures we perform? We can perform a suture anchor. Suture anchor is that you make a drills, especially on the manubrium as well as on the clavicle, and you just anchor with the non-absorbable suture ethibond, or a bolster plate, where you join the manubrium with the clavicle. And you have a surgical lockdown technique. In a surgical lockdown technique, you reconstruct a costoclavicular ligament with the polyester mesh. And most commonly, where we use, as it is in a rib fractures, is the titanium plate, similar to that titanium plates with screw for reconstruction. And rarely you perform medial clavicle osteotomy or a capsular repair with tendon graft, or resection of a medial end of clavicle is rarely required, or a claviculectomy, which is very present, very rarely done. So thank you.
Thank you very much. Our next speaker is one of the senior orthopedic surgeon, Dr. D.D. Tanna, and he's going to deliver his precious talk on the fracture clavicle.
This was the standard treatment for fresh fracture clavicle for a long time. We used to give this figure of 8 bandage. Till new evidence came that figure of 8 is not needed. And now this is a standard treatment for patient unfortunate to refuse operative treatment for a fresh fracture. Please mark my words. Now this is a standard treatment if the patient is fortunate to refuse operative treatment for this fresh fracture. Only time we operated clavicle in past was a non-union. And this was 3-year-old non-union. We operated upon, plated, grafted, and everything became fine. Then the commerce took over. And we added one more fracture for our surgical treatment in fresh fracture. It was done methodically by creating an evidence first. Then AO came out with the clavicle plate. And hamara log ka takdir khul gaya. Created evidence by fixing of the fresh fracture and no conservative treatment. Long-term results of grossly displaced fractures, not that satisfactory. They all improve, gross deformity remains. Though deformity itself is not very important, higher non-union rate, 15%, I'm not sure. Even if united with malposition, function is compromised in strength and activity due to shortening of the shoulder breadth. And this was the results. Dr. Harvey cited the results in so many of these fractures, non-union in greater than 15%. And in comparison, complication shrinks to the size of a quarter. This is what he said. Nothing is true, I think.
Non-operative treatment compared with the plate fixation in displaced fracture, surgery, better functional outcome, and in this study supports primary fixation of the completely displaced mid-shaft clavicle fracture in active adult patient. This is a clavicle fracture, and this is everything is healed up, and they said the shoulder sternum distance is reduced, and that gives you a comparatively a deficient function, which is in day-to-day practice, we have never been able to find that. They made this management, these arrangements, these measurements, and then said that healed clavicle fracture treated non-surgically, not at bump, but the shortened shoulder width, which is a major problem. I don't think any one of us have had observed this ever in any of our patients. And we started primary plating. 30-year-old, Synthesis provided a good plate, and I consider myself as a person who starts operating upon everything, whatever comes new. I started doing it, and we prospered. Drill one. Now the issue was here. If at all those who want to still plate it, I said drill one cortex after giving, readjust the drill length to avoid a soft tissue on the other side. Adjust drill length only 4 millimeter outside bone once bone is touching the away cortex. This is a safety measure which you take if you want to put in a drill in the clavicle. Drill sleeve on Jacob's chuck and not slotted chuck, because this is the only way in which you will be able to control the drill going out, really damaging the soft tissues. Simple fracture, we cured him with this complex, excellent surgery. If he had escaped our clutches, he would have become okay without any treatment also. Recon plate inferior to thicker plate, and this is the way we were told. Problems of surgery. So with the literature up to date, I put thick locking plate and fracture healed up. This is what I got. This is what I got. So this fracture, which was treated for a cosmetic reasons, we gave him this scar and made the fracture aligned. Here was the fracture, again non-union. I started off saving, there were 6 nerves which are there. I initially, before the plating, I could conserve 4 of them. At the end of the plating, there was only 1 there, knowing fully well that this has to be conserved. This was a non-union and bad shoulder joint which was there. And some innovative people did this X-fix. Not my idea, it's not my case. 100 chuha maar ke abhi billi haj pe chali. I almost given up surgery for a fresh fracture clavicle. Non-union, I still do it. I announced this and I mentioned this. I don't do any surgery for a mid-shaft, even minimally displaced fracture or a displaced fracture of the clavicle. I feel they all heal up. And even if they don't heal up, if they get a malunion, it's not painful. Young 38-year-old conserved 1 month and 2 months, and everything is fine. He has perfectly all right full function. Today, reasons for operating on clavicle fracture have reduced for me because I do not operate primarily except in few circumstances. Hanging shoulder, I think this is very, very indicated. And then in that situation, I do basically this nailing. This is the nail which has been devised by Dr. Garigune, which is very useful, and I do this nailing. Indication of surgery on a clavicle fracture today to me is an open fracture, or there is a small bone piece which is jutting out of the skin. Yes, I do operate them. Otherwise, it will end up into this sort of a situation. Neurovascular compromise, floating shoulder, and painful malunion or non-union. Please understand, painful malunion or non-union. Because lots of pain, malunion and non-union are not painful. Here is a patient, 5 months full function, non-union of the clavicle. He has no problem at all. All he came was because he was told that you need surgery. It has no pain. I advised him no surgery. Out is a clavicle fracture, open reduction and plating except in non-union. In is conserve or nailing if the fixation is a must. Do you know, in Germany, there is no punishment for the prisoner who tries to escape from a jail because it is a basic human instinct to be free.
Like a basic human instinct for a surgeon is to operate. I strongly feel, please hold on. You do not need surgery for all the time. Decides to operation of fresh fracture, it is not a crime, as it is our basic instinct to operate. Thank you very much.
Thank you very much, sir, for your enlightened talk on the recent management of the clavicle fractures and the advice to the orthopedic surgeons.
Our next speaker is Dr. Amrit Sharma. Please come and talk on the fracture lateral in clavicle.
Respected chairpersons, I'll be talking about the lateral and clavicle fractures, which are a relatively rare subgroup in the clavicle fractures. Approximately 10% of all clavicle fractures involve the lateral end, but they have been reported to have a higher rate of non-union, specifically for the type 2 fractures, and they do not have an established gold standard yet. First, the basic standard AP X-ray does not work so well in a lateral and clavicle fracture because most of the time there's an intra-articular extension or an inferior fragment where the CC ligaments are attached. So a Zanka view is the view which is it allows us to visualize the lateral fragment, which is very small, and also it allows us a direct measurement of the coracoclavicular distance, which alerts us to the possibility of a disrupted CC ligaments. This is the modified Neeraj classification, which is the most widely used classification in lateral and clavicle. Basically, we are concerned about type 2A, 2B, and type 5 fractures, which require an operative treatment. The rest can be managed non-operatively or by simple plates. Working on this, one recent 2020, they have revised the modified Neeraj classification and basically tried to formulate a treatment plan for it. So they have divided into stable and unstable, and the unstable is divided into 4 types, depending upon the ligament status and whether there are 1 ligament, 2 ligaments, or both are damaged. And this is the flow chart which they have been proposed. So as you can see, if it is conservative is for less than undisplaced fracture, type 1 are all conservative. For displaced fragment, if the coracoid ligaments are involved, the CC ligament reconstruction is a must. That is one of the most important points of this paper. In one of the larger series of systematic reviews, non-union rates are as high as 33% in non-surgical management of lateral and clavicle fractures. So these are the 3 subtypes where the most of the debate is for management. We have a variety of fixation modalities for the lateral and clavicle. And in the review, they found, as you can see, the hook plate has a momentous 40% complication rate, followed closely by the other friend K wires and the TBW of the lateral and clavicle. And as you can see, the CC stabilization has one of the lowest complication rates. In another recent review of 2019, they found the odds of complication being 3.68 times less after CC stabilization as compared to a hook plate. And for the TBW, it was 3.2 times higher than the hook plate. In another recent review, a very large study, 41 studies with nearly 2,000 patients, they concluded that the LCP or the contoured anatomic plates along with the CC reconstruction appears to have the best internal method for unstable distal clavicular fractures. This study, again from February 22, it also highlights the importance of an anatomic reconstruction of the CC ligaments. Now, this appears to be some consensus developing that this be the desired modality of fixation, a contoured LCP with a CC reconstruction. And as for the CC reconstruction, this is what we follow. This article is for the anatomical reconstruction of CC ligaments. 2 drill holes, 2.5 centimeters for the trapezoid and 4.5 from the lateral end of clavicle. And as you can see, the conoid is slightly posterior and the trapezoid is slightly anterior. Now, the next part remains the looping of the coracoid. For this, we use this Satinsky forceps, which is a vascular clamp, which has a double angle, so it makes it easier to loop a thread around and under the clavicle, the coracoid. And we prefer to do it from medial to lateral so that we are not found fumbling on the medial side of the coracoid, where the neurovascular structures are located. And also, we like the thread to be as far posterior as possible, as near to the base of the coracoid. For the fixation method, we use 2 double loops of fiber wire, which are looped under the coracoid. 1 loop passes through the drill holes and is tied on top of the clavicle. The second loop passes anterior and posterior to the clavicle and is tied behind the clavicle. This work has been promoted by Dr. Sarda and it was published in IGO in 2019 as a sutureless fixation method for lateral end clavicle. This is what the final picture looks like. You can see the anteroposterior suture going and the 2 drill holes with a knot tied over. The major points is the reconstruction of the CC ligament is vital. And as far as possible, we try to avoid transacromial fixation as it causes AC joint arthritis and it also fails very early. So even if it is done as a supplementary fixation, we recommend an early removal between 4 to 6 weeks before full mobilization is started. And hook plates and TBW are preferably avoided for the reasons listed because they have a very high complication rate. Thank you.
Thank you, Dr. Amrish. Our next speaker is Dr. Ranjit Chaudhary. He's himself faculty from the AIMS, and he's going to deliver the talk on the acromioclavicular joint injuries. He's from AIMS Bhatinda. We have 2 more talks remaining for deliver, and after that we have a lunch break.
Very good afternoon. My talk is the acromioclavicular joint injury, that is AC joint injury. AC joint is diaxial joint. It is stabilized by the static and dynamic stabilizer. Static stabilizer are the joint capsule, acromioclavicular joint, coracoclavicular joint, and coracoacromion joint, where the dynamic stabilizer are deltoid and trapezoid muscle. AC joint have 4 parts. The superior most part are the strongest part. It provides the stability in anterior posterior translation, where the coracoclavicular ligament have 2 parts, trapezoid and conoid part. Trapezoid part are lateral part, and it is 3 centimeter away from the AC joint, where conoid part is 4.5 centimeter away. This is the dissection diagram, shows the conoid and trapezoid part. AC joint allows some gliding primary movement and the minimal rotationary movement. The incidence of the AC joint injury is account for the 9% of total shoulder girdle injury. It is common in male and it could be the direct fall on the shoulder or indirect fall on outstretched hand or elbow. The clinically patient will present with pain, swelling, ecchymosis and tenderness over lateral end of clavicle or AC joint. The shoulder contour will be abnormal. On clinical examination, stability on horizontal and vertical plane. Horizontal plane will assess the AC joint ligament stability with cross body examination, where vertical stability are assessed with the piano test. It will evaluate the CC ligament integrity. There could be, we can also do an O'Brien test. In O'Brien test, if the patient complain of the pain superficially, then it is AC joint pathology. If the patient complain of the deep pain, it could lesion of the slap lesion. And the AC joint injury could associated with the slap lesion also. what to be imaging done? We should include the bilateral AC joint to compare for the contralateral side and measure the distance between the coracoid tip and the lower bottom of the clavicle and compare it. If there is a difference if there is CC interval difference, then there are suspicion that AC joint injury are present. Normally, the AC joint width are the 7 mm in male and 6 mm in female. We need an axillary lateral view to check for anterior and posterior translation. There are a special Janka view in which the X-ray or tilt cephaloid by 10 to 15 degree. In the case of the type 2 and type 3 injury, we may need an stress view with holding the weight approx 10 kg in hand and get in the Janka view. There are Rockwood classification. Classification are based on the integrity of the three structure, that AC ligament, CC ligament, and deltopectoral fascia. And the three kind of the distance or displacement we are going to observe it. It's a radiological classification. In grade 1, the AC ligament are sprain, rest all are normal. Where in type 2, AC are torn, but CC ligament are sprain. And there is superior displacement of clavicle, but is less than 100%. Where is in grade 3, the AC and CC ligament both are torn, but deltopectoral fascia are intact, and superior translation are approx 100%. Means the lower end of the lower surface of the clavicle at the level of upper surface of the acromion. And the CC interval will increase by 25% to 100%. Grade 4 is tear of the AC and CC with lateral end of clavicle pierce the trapezoid in posterior direction. Grade 4 is along with AC and CC, the deltopectoral fascia are also torn. That's why the lateral end of clavicle are going superiorly more than 100%, and CC interval are increased more than 100 to 300 times. And type 6 are a special type. There are inferior dislocation of lateral end of clavicle beneath the coracoid. The management usually depend upon the age, lifestyle, and type of injury. Usually 80% injury are the low grade that are managed with non-operatively. We have already seen the Rockwood classification type 1 and type 2, and type 3 injury where the clavicle displacement are less than 2 centimeter are managed with conservatively, like the sling immobilization, rest, and ice. The conservative management patient could develop the later on delayed AC joint arthritis that may require the excision of the lateral end. The surgical management for type 4, type 5, and type 6, where the type 3 treatment are very big between the conservative and operative. What are the operative intervention are available? There are AC joint stabilizer, there are CC space stabilizer, there are ligament reconstruction and dynamic muscle transfer. AC joint stabilizer are the hook, pins, and K-wires. The CC space stabilizer, that CC ligament, space stabilizer, that are tightrope, dog collar button fixation, and the ligament reconstruction like the CC ligament reconstruction along with AC ligament. And the dynamic muscle transfer is the proximal base conjoint tendon transfer. Here is the open reduction and fixation with the hook plate. This have a disadvantage of need a second surgery, or it can lead in acromion osteolysis, hook pull out, and subacromion impingement. So there are definitely need of the removal of the plate. Where in the CC interval fixation, there's a CC ligament reconstruction. Goal is to achieve the reduction of the CC space and maintain it. It can be done with either fiber wire, fiber tape, fixed with endo loop, button, dog collar button. There are various options. Like I have shown the two. There one single bundle and double bundle reconstruction. There is a biomechanical study done to analysis the single, double, and triple bundle configuration of the CC ligament reconstruction. And they have found it. These are the 4 group they have done and compared it. They have found it the additional posterolateral clavicle hole ligament reconstruction using the cortical fixation button with secure tape result in the better AP stability. This means the double bundle have a better stability than the single bundle. The previous procedure, like the modified Weaver done procedure in which the lateral end of clavicle are excised, transfer of the coracoacromion ligament to distal end and reinforced with the suture wire, fiber tape, whatever, with clavicle and the coracoid. There are comparative study with comparative biomechanical study to compare the modified weaver done with a triple endo button technique, the two on the clavicle, one beneath the coracoid. And they have found the triple endo button reconstruction are proved to be superior to modified weaver done techniques. And there are the meta-analysis, this also shows the ligament reconstruction are better outcome in the functional clinical score, functional range, and the radiographic CC space maintenance. The less done procedure like the ORIF with modified femistar, this is the transarticular K-wire fixation of AC joint with reinforcement of the CC space. And the historical procedure like the Boswith procedure, they're fixed with the CC screw with coracoid. Thank you, sir.
Thank you, Dr. Chaudhary, for concluding in time. Our next speaker is Dr. Vivek Trikha. He is a professor in Apex Trauma Center in AIIMS, New Delhi. He will be delivering talk on proximal humeral fracture dislocations. Dr. Vivek Trikha.
Okay, thank you, sir, for this opportunity to be speaking on a complex topic of a fracture dislocation of proximal humerus. Has it come there? Okay. So fracture dislocation of humerus is an issue which comes to us very often. It has involvement of soft tissues, high risk of AVN, and many people say that you just go in for an arthroplasty, which is good for an elderly patient. But for the younger lot, in our Indian population, most of them come with a younger, higher velocity fracture dislocations. So do we do an arthroplasty for them, or we can still salvage it? And that's what I'll be showing you. Why I go for a fixation for them, and I'll show you with examples right from acute, complex till delayed as well. Because humeral head is preserved. Most commonly that AVN in humeral head, whenever it occurs, is usually segmental or sectoral, and it is not symptomatic in true sense. Even if it is symptomatic, the screw is penetrating, you can remove the screw, but the important movements which are there, the rotator cuff, if you have been able to reattach, you'll have excellent functions and you need not replace it. We all know this Hurtle criteria, which is anatomical neck fractures, which have got a bad prognosis and disruption of hinges. But remember, these are just guidelines. These are not mandatory that it will happen. If it happens, then all fracture dislocations need to be replaced the very next day when they come to us. So what we need to do is understand the personality of fracture. This is a case. Even now, yesterday only, I was here and there is a patient with us having this light bulb sign. Do not miss it, because we normally put the whenever the patient comes, we give them a slab or a bandage in an internal rotation. And many a times that internal rotation also looks the same way when we get an AP X-ray. Do not miss it with posterior dislocation, because these are posterior. When you get an oblique, you can see that. You get a proper CT, it's a fracture dislocation posteriorly, which needs, if you do it first time, you just push it back, it will come. If not, you can go operate, put in a plate or a screw, whatever you want, and you can have excellent range of motions in this if you diagnose it properly. Most of the fracture dislocations are treated from deltopectoral. You do not go through mid-deltoid, because it is anterior. From mid-deltoid, it might be difficult. The posterior dislocation sometimes becomes tricky. I still go through a deltopectoral for them, and sometimes I have used a separate small incision for the posterior part when the bulk of the shoulder is quite big and I am not able to reduce it. This is again a dislocation. You can see bulb sign but broken, a posterior fracture dislocation. We got this result, reduction from a deltopectoral, but he was quite a bulky patient. It is his 7 years follow-up, and you can see that reduction has been done. We have some AVN at 7 years, but his range of motion is okay and he's fine. He does not even have an inkling what is happening to him. unless I tell him that it's an avian. He's perfect fine. You can see the two incisions, the deltopectoral and a small posterior incision by which I was able to loop it up and pull back the posterior dislocation. So what are the reduction principles by which we can get such results? It's the soft tissue attachment. You need to reduce the thing and then make sure that your rotator cuffs are going back. How do you reduce it? Blunt instruments. I just use relaxation of muscles. I always flex my shoulder, flex my elbow, so that all the muscles coming from the coracoid are relaxed, where back the thing. They said that you can do a coracoid osteotomy, but in my series, which is a huge one, I have never done it. But yes, if you have having problems, you can definitely do a coracoid osteotomy, doing the same thing, relaxing your muscles, which is controlling and making that going hinge. There is another technique. People use a tap to hold it like a corkscrew and bring it back. But I can assure you, even in a 40-year-old Indian population, you just do it and come back, your tap is going to come in your hand or your shank spin is going to come in your hand. The second thing is medial pillar reconstruction. Try to achieve medial pillar reconstruction by putting in a tricortical graft if it is comminuted, or an intramedullary fibula. And nowadays, people have started putting in medial plates as well. Or in the post-operative, use the calcar screws, which are so very important. You can also do biological augmentations. Like in this case, I am showing you on the side. You can see the gap. And then I have used a liquid cement, liquid bone hydroxyapatite things, all the various one which are costly or sometimes. But you can even use bone substitute to give you the initial bone augmentation, which can help the screws to be at the right places. And this is my own paper in which we were able to prove that doing this helps a lot. The second thing, as I was saying, was the rotator cuff. Always tie them. Even if you feel they are not broken, tie them. Because you will be having a good construct. And once you are having a good construct, you will have early range of motion without any problems and doubt. So make sure that you do the rotator cuff properly. I'll show you cases. 43-year-old man, policeman, having a small fragment. As per Hurtle criteria, failure. But you can see later on at 3 years, it has united. Mild sectoral avian, but it is okay with it. Another case, dislocation going way down below the coracoid, small fragment. This is how the steps are there. I have not done the coracoid, just relaxing the muscles, reduced it, putting in the wires, and subsequently putting in the plates, holding the rotator cuffs. And this is his range of motion. This is a subsequent 3 or 4 years follow-up. 2 or more X-rays, which I'll show you. Bad proximal humerus, 32-year-old. I sent it to a big shoulder surgeon of in Delhi. He sent it back to me saying that whatever you are doing is fine, because he would not replace this. It's a difficult replacement also, mind you. So he was a carpet person from Jammu and Kashmir. This was the fracture fragment. What we did, I just restored the medial continuity, put in an iliac crest graft. GT was back to the place, just holding it in the position and praying to God. Preventing varus, medial continuity, and rotator cuff attachment. This is his follow-up at 3 years. I was happy when the callus could be seen, even if it shows instability. Some bony union was happening. This is his follow-up at 5 years. This is his follow-up at 9 years. And see his range of motion. The screws have penetrated slightly, but still avian is happening, but see the range of motion. That's what counts. Patient is happy, his outcome is good, he can do all his activities. Can I assure with an arthroplasty? No. Final case. Just I'll take 10 seconds if it is possible from there. A 90 days old, posterior dislocation, missed by trauma center. This was his X-ray, 4-part posterior dislocation of humerus. What I did, you can see, reduced it first through deltopectoral, put in a fibula intramedullary, maintaining the position of medial cortical continuity. This is what I did. Biceps was removed. 3 months follow-up, 18 months follow-up, and that's the range of motion. Why this range of motion? Because I am fixing the rotator cuffs properly, attaching them, holding with good stability and good fixation. This is my paper, which was published in Shoulder and Elbow Surgery, reiterating this, that in a young patient, we need to do augmentation and fixation and not going for arthroplasty, because AVN is not a symptomatic thing for proximal humerus. Rehab is very important, which we should be doing. And the key to success will be finally maintaining that good reduction of tuberosities, head, neck, shaft, medial continuity, and continuity of the medial side. If and when you require augmentation, you should do it. Thank you.
Thank you very much, Trekar sir, for really sharing us a nice tips to reduce all these complex fracture. And probably all of our younger colleagues will learn how to come out with these difficult situations. Our next speaker is Dr. Nirmal Mahapatra, professor from the Cuttack. And he's going to be join us on online, and he's going to be deliver a good lecture over the scapular fractures. Nirmal sir, welcome in CG Icon. Are you listening to me, sir? Very well. Yes, Nirmal sir, welcome in CG Icon.
Okay, sir. Good afternoon. Am I audible?
Good afternoon, sir. Welcome. Please just start with your lecture.
Thank you, sir. I thank Chhattisgarh Orthopaedic Association and Professor Alok Agrawal for giving me this opportunity. So I'll be try to share some of my experience with scapular fractures. Well, scapula is an important link between upper limb and trunk. It is also integral part of shoulder joint complex. Almost 18 different muscles inserted or originate from the scapula, making it highly vascular. They also dictate the rapid fracture healing as well as displacement of fragments. And scapula has a very important function to play. Scapulothoracic joint is a functional joint, and just like a radioulnar joint, and it is when treated, it should be taken into account. It is almost like a base of a excavator. Okay, when the base is weak, then usually the function will not be perfect. That's why the scapula management is also very, very important. The scapular fracture is usually a result of high energy trauma with a high incidence of significant associated injuries. It's almost 1% of the fractures. But what is important that they are usually missed injuries. In a study by Harris, 100 fracture scapula cases, and in the initial X-ray, only 57% could be appreciated on the initial X-ray. So they almost always present as hidden injury or associated injury. So almost 90% cases, scapular fractures are associated injuries. Most common thoracic injury like rib fracture, hemopneumothorax. But what is important from a treatment point of view is axillary nerve injury, almost 30% cases. So they should be properly evaluated. So I always say if there is a fracture of clavicle, you must look for the rib fracture. If the ribs are fractured, then scapula very likely is fractured. And this I name as terrible triad of the scapular fracture. So how does a scapula influence the shoulder function? If there is an injury to glenoid with malalignment, it can contribute to instability or arthrosis of the glenohumeral joints. Fracture like this will never give good results. Then if the neck of the scapula is malaligned or rotated during fracture, then it will almost always prevent the rotation, as you can see here on the left side, and also functional abnormality and rotator cuff dysfunction. So this should be properly taken care of. If the scapula is malunited, then usually they can cause painful scapulothoracic crepitation during movement and also pain. So these cases should be taken in account. If there is a floating shoulder injury with the affection of the superior shoulder suspensory ligaments complex, then usually there is a drooping of the shoulder, malunion, and rotator cuff injury leading to dysfunctions. So they should be given proper attention. But always the scapular fracture presents very unpredictable result. Like in this case, even though it is very grossly displaced fracture, you can see such a nice function. So in a review of the scapular fracture of 520 cases in 22 series, Joldotsky found that almost a majority of glenoid fractures are operatively treated. but the scapular isolated body and neck fractures are non-operative treated. But all these cases are very small number of cases, only case series, and also they use very non-validated and non-specific outcome measures and additional injuries. So the comparison, valid comparison may not be possible between operative and non-operative treatment in these different fractures. In another recent systematic review by Sudhir Kannan of 1,237 patients, they found that if the fracture is in the body of the scapula, then non-operative results usually can give 100% result. But if the glenoid fracture and the scapular neck fracture is displaced, then outcome is usually very, very poor with non-operative results, and operative treatment is mandated. So the management of scapular fracture has evolved over time based on greater understanding of the injury, periscapular anatomy, different surgical approach, and fracture fixation techniques. More and more general orthopedic surgeons are not being wary of the area which is not familiar with average orthopedic surgeons. That is the reason, and with a traditional feeling that non-operative result usually gives good outcome. So a proper pre-operative planning is very, very important, where one should evaluate the chest and also the neurological evaluation, because almost 30% cases you may find axillary nerve injury and 7% cases brachial plexus injury. This should be followed a proper radiologic evaluation with a proper trauma series X-ray of AP, axillary and Y view to identify the fracture. Then 2D CT is a must for accurate assessment of articular step-up and displacement, comminution and fracture location. And 3D CT also should be taken. They're important to draw the glenopolar angle, angulation, and mediolateral displacement, which can contribute to a decision-making process. And after you have identified the fracture, and then they can be classified. Commonly, we use AO-OTA classification, though there are others like Idebor classification, Ida and Miller classification, but this classification is usually commonly used. So, as traditionally thought, most of the fractures, scapular fracture can be treated conservatively. Usually, close reduction of this fracture not possible. So, you have to accept whatever deformity and allow the functional joint to take up whatever outcome will be there. So treatment usually consists of support in a sling, and early motion should be allowed. Almost by 2 weeks, fracture becomes sufficiently united so that you can give supported active assisted movements. And then most fractures will heal solidly by 6 weeks because of the musculature and also vascularity. Surgically, there is no clear-cut evidence on the surgical guidelines. So there are few absurd indications like intra-articular fractures where there is more than 25% of the glenoid articular surface is affected. And if there is concomitant intra-articular step of more than 3 millimeter, then one should think of surgery because this will give good results. There are certain relative indications like displaced double disruption of superior suspensory complex. And then if there is medial displacement of lateral border more than 25 millimeter, if there is angular deformity more than 45 degree, and if there is fracture translation more than 100 degree on the lateral border. These are some of the relative conditions where one can think of giving deciding to go for surgery or not. So also few cases. This was one of my first case. There is a gross medial displacement with reduced glenopolar angle, scapular neck and body fracture. So I did a Jude approach and reduced the fracture with recon plates, basically basing on the bony contours of the columns, different borders which are having thick bones. In between, it is usually very thin bones where plating is really difficult. So this is the function. You can see such a nice function. And another case, you see the one I showed, glenoid is here affected as well as body is affected. It is grossly displaced, more than 25% affected. So this is the CT. So it's almost all cases one must do the CT. So I opened up and used few lag screw and splits to fix the fracture, and this is the final outcome. And you can see function. It is almost 100% function. They usually gain by 6 weeks or 8 weeks almost full range of movements. Then another case, this is a floating shoulder injury, having a grossly comminuted body and neck fracture. Display glenopolar angle is almost less than 10. You can see the body is also grossly displaced. Here, we again opened up the fracture, fixed the clavicle, as well as all these scapula. We opened up by Jude approach. Though recently,
Sir, please conclude.
Sure. It is the one more slides, I think. So this is the operative case, and this is the final outcome of the fracture. So take-home message is all fractures, all these type of scapular fractures should be individualized on the merit of his case, and majority of fracture scapula can be treated conservatively, but there are definite indications for surgery in selected cases. Indications may be intra-articular glenoid fracture, displaced neck fracture, widely angulated body fracture, and double SSSC or floating shoulder injury. Thank you.
Thank you very much, Professor Mahapatra.
Thank you, sir. Thank you, sir. Thank you, sir.
And because of the shortage of time, we are having a lunch break directly.
I understand it is
and
very late.
all the dignitaries
so
and the senior faculties and the members are requested to proceed for lunch. And immediately after lunch, there is a session on the humerus fracture.
Dear friends, 15 minutes lunch break only. And after lunch, share start hoga. It will be Dr. Tanna's sessions. So, नहीं सर, वहां पे उतनी गर्मी में कोई बैठ नहीं सकता. सर 15 मिनट से ऊपर कोई बाहर बैठ नहीं सकता जो है. आधे लोग खाना खा चुके हैं सर, आप खाना खा लीजिए बस. इसके बाद तो आपका सेशन स्टार्ट हो रहा है. वेलकम.
बहुत तेज लेंस ले लिया सर आपने. ग्रेट से आराम से बैठे हैं. कंडक्शन का है ना इसके बाद. हां, कंप्यूटर लगा के रखता हूं ताकि टाइम बचे. आपका ग्रेट क्या है.
Recording stopped. Recording in progress.
We'll be starting session in 5 minutes. So we'll start the session. The next session is on humerus fractures. I'd like to request Dr. Pankaj Davalia sir, Dr. D.P. Bhushan sir, Dr. Satyendra Fulgare sir to kindly come on dais and chair the session.
Good afternoon. After a good lunch, we'll start next session. Our speaker, Dr. Respected Tanna sir, will talk on the non-union fractured shaft humerus. I request Dr. Tanna sir.
May I request Dr. V.K. Jha sir to come on the dais as a chairperson? Chairperson.
You have a follow by. हाँ ठीक से खींचना बैठ तो लगा दे सर केदार सर फोटो खींच रहे नहीं ये नहीं है ना ये कनेक्टेड
Neglected humerus, that was the point, that was the subject which was given. When I say neglected humerus shaft fracture, it probably needs clarification to me. One cannot miss or forget humerus fracture, so it is too painful. So basically when we say neglected, it is unsuccessfully conservatively treated or unsuccessfully operated. Nobody treats the patient with neglect. So that is the main and most definite thing. Most non-unions are due to inadequate primary treatment. First learning is must avoid a non-union. If it occurs, treat it with adequate surgery and do not repeat the same mistakes again. We have a tendency to think we are a nailer, we'll do the nailing. So that's not necessarily the only treatment. I will deal with non-union and if avoidable, how to avoid it in this 10 minutes allotted. This is a conservatively treated. Most of the time, these conservatively treated patients do become all right. 2 months, no mobility, not complete united, and then the surgeon is in a dilemma whether to operate or to continue. My thing is, if it is not displaced, if it is not painful, and there is no obvious mobility, radiological union in conservatively treated callus formation takes a longer time. So you got to be aware that it may take a longer time. Undisplaced humerus like this has very good chance to heal as soft tissue envelope is intact. Most often it takes 4 months to radiologically unite and patient and doctor gets impatient. If no pain, still wait with cast brace and allow elbow movements and most likely heal. If mobility, there is no choice, you will have to operate. And this was the case which was operated upon with the plating, which is perfectly all right. This is otherwise an alternative treatment. This humerus is displaced humerus and hence all soft tissue is disrupted. And the healing is also not going to be as good conservatively. So it is debatable. Plate it. Now here is the another one. This is the one, 2 months, no mobility and hardly any pain. With time it can heal unless the surgeon becomes impatient. Now here, nailing in a displaced transverse fracture to me is an inferior operation as the rotational mobility cannot be controlled even with 2 screws at both the ends. Please mark it, I am talking about a transverse fracture nailing. In a comminuted fracture, nailing is perfectly all right in humerus, but not in a transverse fracture. Why does this happen? As you can see, the surgeon tried to put the nail
it would go here and he tried to hammer it down. Since the nail is very snugly fitting here, it couldn't hammer it down. So the distraction occurred and it was stuck there. Now he couldn't take it out. He couldn't push it in. So he was stuck at that level. This is the stage I saw the patient. It was 4 months after what this happened. How it could have been avoided? Naturally, it should have been, if the nail distal fragment is thin, if the medulla is reamed, and majority of the time, the reamers are not easily available. Small distal medullary cavity in humerus, do not hammer the nail. Now you are stuck, cannot get it out. If he had a reamer, but a small reamers are not easily available unless you have ordered, most hospitals do not have it. So if you have a full thing which is in your nursing home or hospital, small reamers you start with, Zimmer at the moment has it, then you can probably ream the humerus and put the nail in. Transverse fracture, to me, plating is a better option than nailing. Now here it is, this nail, since it was 4 months old, it was no problem at all. It could come out, nail came out easily as it was 4 months already. And I did this compression plate, which it held up very well. And in spite of the nail out for 4 months, he has a full range of movement which is restored. So whether the surgeon, whether it has been mentioned about that the nail really hitting the supraspinatus gives more trouble for abduction is still debated. Here is the second patient, good shoulder movement even though nail. Here is the patient again, as you can see, it couldn't go out. So again, this is the same thing treated with the plating. Now here is a typical Indian jugaad. This is the lower 1/3 fracture. Lower 1/3 fracture, surgeon decided to do the nailing. Transverse fracture, poor indication for nailing. And in order to help the union, the typical this Indian jugaad splint was given. It will not work because ultimately the healing is not going to occur just because you put in the splint. Now here, another one Indian jugaad. This is an oblique fracture. Oblique fracture is very unstable with these two screws. As you can see, they have broken down. So if it's an oblique fracture, it needs a leg screw and a plating. So as you can see, again, the jugaad was done. It's much easier treated with the leg screw and a plating or a compression plate. Now here, these are the cases. We are orthopedic surgeons and not nailers. All inferior indication of nailing do not be sold out by the nailers. I would strongly feel comminuted fracture is a different ball game, but in a transverse fracture, the rotational stability is not there, so the nailing is not an ideal operation. Here you can see the nailing has been done, and you can see this is the one 4 years, 3 operations, and still the whole thing is in a absolutely shambles. And everything has become loose and the bones have lost their things. Now, in summary, the whole literature suggests that intramedullary nailing resulted in more complications compared with the plate fixation for humerus shaft, particularly when antegrade nail was used. The complication rate was higher in intramedullary nail group, whereas the functional outcomes were good in both modalities. My personal, Rudy mentions, however, favors the plate as it seems are consistently good results. To me, my choice in a humerus fracture is a compression plating or a leg screw and a plating. There is enough evidence in literature the plating is the shaft humerus is better. Non-union rate is lower in plating. Reoperation rate is higher in nailing. Plating of the humerus transverse fracture is different from comminuted fracture. In a transverse fracture like this, it must be compressed. A short oblique fracture, never do a leg screw, always a compression. You do the compression with these two screws and this fracture will heal up without any major problem at all. Interesting combination of non-union with implant breakage. This implant broke here, so I had to do the innovation here. This bent Steinman pin was used at the end of it and the implant was removed because nothing will go there. And ultimately the compression plating was done and everything held up. Now here you can see this was the patient. The surgeon had done the nailing.
didn't heal up, so he did this small, flimsy little plate. That's not good enough for that situation. And so why failed? Because of short, thin plate. And so this became now an issue. So how could it have been helped? Remove the proximal and distal locking screws from the nail, compression of the fracture, 6-hole, 2 screws on either side, 3.5 plate, and graft after shingling. Put 1 locking screw in the nail so the nail does not migrate. He could have done this. Now, ultimately, I came into picture at this time, so I had to do the intramedullary fibula. Because 3 operations, so I did the intramedullary fibula, did the compression plating, and ultimately the fracture becomes perfectly all right. And here he has again a good range of movement, in spite of the fact that the nail is still out, as you can see in these situations, and still a good range of shoulder movement. If you want to take a fibula, you can take half the fibula also. In humerus, you don't need the full fibula. You can take the half fibula here, as you can see, make multiple drill holes and then connect them, and you can take this half fibula, which is also very good in a humerus. In a femur, you may need the full fibula, but in a humerus, you don't need the full fibula. ये अटक गया तेरा भाई, टाइम तो नहीं खत्म हुआ हमारा. Anyway, so fracture of the humerus, in summary, if I can say, fracture humerus, transverse fracture, preferably compression plating. Short oblique fracture, no leg screw, do the plating in compression. Long oblique fracture, do the leg screw and compression plating. And the nailing is reserved mainly for the comminuted fractures, and that fracture only the nailing should be done. Otherwise, I feel the nailing is not a superior operation in a fracture humerus. Thank you very much. Next speaker, Dr. Naveen.
Dear friend, a small announcement. Executive body members can come to the green room behind for the meeting. Sessions will continue as they are. President and Secretary CGIU are requested after executive body meeting to inaugurate the trade conference.
Till the time they put on the computer, any questions on this humerus or the clavicle, you can ask at the moment before I start the new talk, because there will be no question answers. We are running late. Otherwise, we'll have to discuss during the tea intervals, if at all there is a tea interval. Sorry? I do either anterior or posterior. I don't go anterior lateral. Posterior is if you can see the radial nerve and save it. Anterior if the fracture is above, upper 1/3. Then I think posteriorly it is too damaging, so I go anteriorly. If the fracture is middle 1/3, in the middle or lower 1/3, I go posteriorly. Because then it is much easier even if you have to put a metaphyseal plate. Anterolaterally, I have never done it. I think initially I used to do it and I feel it's not any advantage to me. Sir, what do you do in gap non-union? The gap non-union is when there is you are not seeing the fracture of the, fracture of the humerus with the nailing. When there is a movement occurring, the bone gets absorbed. In such, there is a gap non-union, which is very common. Because the nail, if it is there, the patient doesn't get pain all the time. So he goes on postponing it for a longer time, and you will get the complete bone will be lost. So in such a gap non-union, clean it out, open up the medullary cavity, shingle it on both sides, compress the fracture, put an intramedullary fibula. Because in a gap non-union, it is much safer to put an intramedullary fibula and do a compression plating. I feel if it is non-union, go all out. It may be an overkill, but don't just do a short of overkill. Thank you.
Thank you, sir.
Yeah, about a 0.5 centimeter gap, you can compress it and still you will be fine. But in a non-union with the humerus, which is a nail, and if it goes through long time with the nail non-union, then it will be too big a gap. Then I would strongly feel, to me, third time if I am operating, almost always I put in a fibula.
Sir, we have...
I think we may discuss it. I may cancel my one talk, which then I think there is some substantiative education all of us will get.
Sir, we have Gmer reamer of 5 mm, 6 mm, 7 mm, and we're doing a lot of interlocking nail, and we usually do very good stable fixation after proper reaming, and we use get good
if you have a good reamer, you can get away with.
Yes, and proximal screw should be fixed in opposite cortex in the neck.
Yeah. Okay, now I talk about the distal humerus. Olecranon osteotomy. I think there is a big debate on olecranon osteotomy. People want to avoid an olecranon osteotomy. To me, if it is intra-articular fracture, do not try to do any Indian jugaad and avoid an olecranon osteotomy. Do an olecranon osteotomy, you will be able to see the lower end of the humerus very well, and then you will be able to fix it up anatomically. Otherwise, the chances of you really fixing up the humerus 100% anatomical are not there. Unless the osteotomy is going right up to here, you will not see the posterior part. So when you see the humerus, you will see anteriorly, but when you go posteriorly, you will know it is malunited or it is malpositioned. And that's the reason it's necessary to have the osteotomy like this. The old teaching, you do the osteotomy and the last part you break it. Once you break it, the osteotomy becomes like this. And then once it becomes like this, you will not be able to see the humerus perfectly. So the way I go about is, I distract the joint partially. I put in some thin instrument in the joint and then cut the bone all the way down. I don't think I've ever regretted. And that's the way I can get the osteotomy right lower down. And then your humerus treatment becomes very, very effective. I do it in this position. Now all of us know very well. And then there is a debate which goes on. Parallel plate or a 90-90. The academic results are the same. Do not get dragged into this. Do whatever you are comfortable, but understand and do it well. I don't think there is any advantage in parallel plating over a 90-90. If it had not come out from the Mayo Clinic, probably it would not have gone so much into the publicity. If it had come from Raipur, probably nobody would have thought about it, because this is how I feel the parallel plating has unnecessarily taken too much of an importance. What is the evidence? Although some biomechanical evidence, this is by J.C. Jupiter and Guton, biomechanical evidence may favor parallel plating, but both orientation are strong enough to mobilize after the fracture. Clinical perspective, no sufficient data to valid comparison. Different patient type and fracture type were compared. And here, the other thing which you should avoid, why things not do well in the distal humerus. You can see this plate is so short. It's not holding anything into the lower fragment. So lower fragment, only one screw due to stinginess. It is never going to function. And you can see in about a few months' time, the whole plate starts coming out. So the principle of two-column fixation is fix up both the columns perfectly well with unequal plates so that they will not have a stress riser. And unless and until minimum 3-4 screws are there proximally and minimum lower fragment into the 3-4 screws are there lower down, you will not get a good fixation. So this fixation is a poor fixation. Now here you can see this fracture is ending here and surgeon has ended here only. Why it happens is on the table so many times surgeon is afraid to go up because he fears the radial nerve. So if there is any doubt, open up the radial nerve, see the radial nerve, and then you can go as much up as you desire. Otherwise, you are hesitant that you may hit the radial nerve. And that's the reason why be on the table, have no problem. Incision which is smaller or bigger, incision infection rate is not really much of a difference there. Now here is after 14 days, the whole thing just comes out, as you can see very well. So such a short fixation cannot be compensated by a plaster. If you think that you will give a plaster and that should be fine, it is useless. Cannot economize on the length of the plate. Now here was the plate. Here I started a lateral plate, was not long enough and was too bulky for this lateral condyle. Ordinary recon plate was good enough. I supplemented with the K wire. So this is the thin plate I pushed it because the thick plate I couldn't put in. And then if needed, you can put these 2-3 K wires and it will supplement the fixation and it will be perfectly all right. So adapt on the table whatever is needed. Here was the thing, everything done well except the plate is too lateral. Now this metaphyseal plate, you got to plate it properly. Here this plate is too lateral. Once it is too lateral, you will see it hitting it on the lateral condyle. Or even an ordinary plate, this also hits on the lateral condyle. So all what you have to do is, you got to see that the plating is done properly. This plate should come here. Unless it comes, as you can see here, this is the where. You must avoid the olecranon fossa, but it should be here. And you got to see after flexion that it is not hitting anywhere the patient is not feeling the plate. That's the only precaution which you have to take. Otherwise, this is a wonderful plate. Any doubt, any lower 1/3 humerus, try to use this plate rather than the plate which you economize and you end up here. It's much easier to end up into this plate and the fracture will heal up ultimately. Come back to standard surgery. First fix the articular fragment and then fix the pillars to this fragment. So here first the articular fragment, leg screw and then temporarily immobilize. And now the pillars when you want to fix up. This is a bigger pillar. So you start with the bigger pillar, put this anatomical reduction and put the plate here. Once having reconstructed this 3/4 of our bone, now that comminuted piece onto the medial side, put it back to this reconstructed. This is the easiest way to get the perfect anatomy restored. Now, in both these cases, this was again a Y plate which has totally been useless now. Both these should have been normal if 2-column fixation was understood. Y plate is useless. Don't use a Y plate. You must put a 2-column fixation. 90-degree or parallel, to me, it doesn't make a difference. Now, here was the bad 80-year-old, bad comminuted fracture. The surgeon treated with this flimsy little plate, and the screws are walking out because in those days there were no locking screws there. And these are locking out and went into non-union. And so at that stage now, partially the fracture, it held up. So ordinary plate and the fracture heals up very well. Only thing is there has to be sufficient screws proximally and distally. Here even a 1 condyle, the surgeon messed it up. Small screw, there are no screws here. He put in the 1 screw which is there. This could be easily treated by this tension band. This is so simple. And you will be able to treat the same thing with this tension band. Now here is the case. I want to demonstrate this. This is the case. Treated, short plate came out. Ultimately at this stage, I took the patient over. And you can see he has an excellent range of elbow movement preoperatively. So I went ahead and I did this tension band wire. And I started mobilizing. Once I started mobilizing, all those wires came apart because the movement which was there was at the pseudoarthrosis. It wasn't at the elbow joint. And that's the reason when you start mobilizing, it comes out. So here, secondarily, I went there. I went down and did this double fixation plating. And then I examined the elbow. After fixing up the elbow, there was no movement of the elbow. So you went down and I completely mobilized intra-articular elbow and got the table movement on the table. Because if the elbow is stiff and you start mobilizing, the fracture will be strained and it will have a problem. So stiff elbow or stiff knee, the chances of healing are very poor. So you must mobilize the elbow or the knees and then only you will be able to get the perfect healing. Here it was done and hence you get the perfect healing and a full range of movement in spite of these 2 non-union. So don't lose your heart. If you do the operation perfectly, if you articular surface, you reconstruct. As you can see, this articular surface was reconstructed after a long time. Still, you will get a good range of movement. So the lesson learned, stiff elbow needs surgical mobilization after fixation to relieve the strain on a new construct. And once elbow is mobilized and post a few days of brachial block to ease out the pain, and everything fell back in the track. In elderly, in porotic bones, it is a spatial situation. Even locking plate will not hold as the fracture is distal and severely porotic. These are the fractures, as you can see, you try to fix it up with this sort of a thing, plate doesn't hold. So my suggestion here is that this is the tension band device which works marvelously well for these fractures. Here is a fracture 9 months after the tension band, everything healed up and you can see the excellent function. Or even here, you can see the tension band and everything becomes perfectly all right. This is a very cheap implant. If you want to really save it on the implant, this is the one which works. And this is what is the evidence of that. This two tension band goes and bites the opposite side and the wire bites, and from that side, same side, you tie it up on both sides and you will have a perfect fixation after the joint is reconstructed. The evidence explores the effect of treatment of the humerus supracondylar fracture with K-wire and tension band fixation through a small lateral incision. This method has advantages of minimal trauma, easy manipulation, and treatment of the humerus supracondylar fracture is a much better treatment. And there is that very much advantage of this double tension band. It has been shown into the many papers into the literature. So if and when, particularly the lower 1/3, lower fracture, where you cannot put in 2 or 3 screws in the lower fragment, this tension band treatment is an excellent treatment and worth trying it out. Functional results and complications of patients treated by this method are compared with the results of patients treated with the plate. Now here is the one, after the treatment, the elbow went haywire, and so in a badly comminuted fracture, you will need a primary replacement. But the primary replacement in a younger patient is not indicated because it doesn't last for a long time. The bad comminuted fracture, you can do a primary replacement into people in 75s and 80s. In 50s, if you do it, it's not going to last long. So it's much better to really reconstruct them and get even a restricted movement, which will last forever. And that's the reason why it is getting established. Long-term results are still not certain. And the long-lasting joint replacement in elbow is still to come. It is not established like knees and hip. So that's the reason it is only when the patient has got 3 to 5 years, probably you can think of replacing this. In conclusion, supracannular fracture fixed with both condyles is must. Long enough, not unequal plates, 90-90 or parallel, the same results, tension band or replacement in elderly. Thank you very much.
Thank you, sir. Now I invite Dr. Naveen Thakkar, sir, for his presentation.
Thank Chhattisgarh Orthopaedic Association and Dr. Alok Agrawal and all dignitaries for such a giving honor, guest of honor. And I'm going to share with you a scientific paper or a technique which changed my way of practice, and it is an alternate way of operating the humerus. This is the question: which technique you are going to use for such fracture? It's a little bit extended one. It's comminuted with the proximal. It is here comminuted lower third with the dislocation. Why we are searching for another treatment? The problem is we have an open reduction, internal fixation, the posterior plating, antegrade interlock intermediate nailing, antegrade retrograde enter nails or flexible nails. What is the problem? Problem in the literature is one is the radial nerve palsy. Another literature what shows is with this open reduction internal fixation, rate of radial nerve palsy, non-union, soft tissue, this has been increased in the rate as you see in the literature. This paper, minimally invasive plate osteogenesis of humerus shaft fracture, is it possible? A cadaver study was done by this gentleman where he has shown this minimally invasive plate synthesis with anterior root, anterior approach is a possibility. With the danger zones has to be taken care of. This is the proximal window you can see here. This is the distal window where you can do a MEPO plating and you can fix the humerus without any problem in this approach. One example here, when we started, this was the fracture And this is the way it was treated with the MIPO plate. The problem, what we found in this MIPO anti-bridge plate, one problem was to keep it reduced. You need one more assistant to keep it reduced. What the literature says, to use the locking sleeves or an external fixator here, where you can keep it reduced and you can slide the plate and you can use the plate. So what we found that in such situation where it is a polytrauma, there were expected problems of stability, how to maintain the reduction with a short segment proximally, and does it require augmentation? So what we found that we can put the flexible nails from the distal lateral condyle and have a reduction with that, with the help of that. You can see here, one incision here, one incision here, and a flexible nails from the lateral condyle distally, which has a good bone stock. And this is the follow-up X-ray and a beautiful union and a good clinical result. So patient was happy. So I adopted this method or technique, and which changed my practice, which may change your practice. That is the message I want to give you. The next case with the elbow dislocation with the lower fracture, where you can see we have done a reduction close of the elbow, and we could put a nails to get the reduction, and then we did a anterior bridge plate, and you can see here the range of motion and the movement and the functional result. You are not disturbing anything as in the nail rotator cuff, or we are going from the lateral condyle. So this is a possible value addition, and that can be applied, and that may help you also. Further, another case, comminuted fracture, lower third. At least 2 screws, if it is possible, lower down. This technique can be used, and one can give a good fixation with a good clinical result. So another problem came when we did a multiple thing, how to remove it safely. The removal is a problem with this, because what is the problem is the soft tissue adhesions in between the holes of this plate. And it becomes the maximally invasive plate removal, because it's a blunt and blind. Ultimately, you have to open up completely, you have to cut that fibrosis, and then you will be able to remove this. So how to solve this problem? So back to the basics. What we are trying to innovate is a plate, MIPO humerus plate, where there is an oblong hole proximally and oblong hole distally only. In between, there are no holes. So there is no soft tissue attachment there, and the removal will be easy. So we are doing mechanical testing with not making the hole. Does it affect any flexibility of that plate? And does it allow the micromotion and the callus formation or not? So it is under trial. We'll come with the results. I'm going to share you a story of one patient where the male 52 operated in 2016, and it was done under nailing. Removal of nail was done. Open reduction, locking plate and bone graft was uneventful. Only complaint was odd feeling, heaviness, tingling numbness of and on. That was the only complaint. Patient wanted to get it removed. It was the anterolateral approach. You can see this anterolateral approach. And this was the plate fixation. It has given a fantastic result, completely united. The first surgeon tried to remove, but it could not be removed. Removal of plate tried by the second surgeon, but again, it was failed by another surgeon also. Explain to the patient that not removable, and the further trial of removal may damage. So patient was shifted to the room from the OT, explaining that it is not better to remove this plate. What is the next? How to go about? Sir, they could not remove the screws from there. And surgeon felt that if I remove with the hollow mill, there will be multiple holes. And they tried and they could not remove. Probably they were not very well prepared also. That may be also a possibility. It was not removed like that. But what will you do the next, sir? Yeah. May or may not be, right. But even if removal is done, with that, the screws were cold welded. It was very difficult to remove whatever the knots were there. But now the story is twisting. Patient complained of the pain and deformity after 3 hours of shifting to the room. What now? Sir, Kedar sir, what will you do now? Two times removal has been tried. It was not removable. And now patient has a peri-implant fracture at the upper end.
If it is not removable at all, then we have to put plate in another plane and put bone graft.
And I put a bone graft.
Yeah.
So which another plane? It was an anterolateral plate.
No, not posterior, anterior. We can
yes. That is what MIPO plating we did with the anterolateral, but with the help of the flexible nail to get the reduction and this anterior bridge plate.
Sir, how you have passed this nail with the screw inside?
Yes, that is the trick. Yeah. Flexible. Now you can see here the scar of that previous surgery, and this is the anterior plate and previous plate and the flexible nail. But you require long span of the fixation.
Very thin nail.
Yeah.
Very thin nail.
Very thin. Yeah. It was just to get the reduction so that we can keep it in the position. And this is the final result of the follow-up of the united fracture. And you can see the scar will lower down the MIPO scar and upper MIPO scar, and it has given a very good function. So this is also one of the possibilities. The literature says that effect of different surgical techniques in the mid-distal humerus shaft vascularity, open reduction and internal fixation versus minimally invasive plate ossesis. They were done a vascularity study. They found that minimally invasive MIPO plate preserves more vascularity. And there is also one recent study of comparing different options of the treatment of the shaft humerus, where the conclusion is the current evidence indicates that MIPO is optimum choice in treatment of humerus shaft fractures, and that the open reduction in plate osteogenesis is superior to intramedullary nail, what Dr. Tanna sir has said already. So surgeon has to balance between the reduce of the risk of the plate failure, rigidity, and at the same time have an optimum interfragmentary movement to get the callus formation and the union. So we have to learn from the nature to remain flexible, at the same time to remain stable. The nature bamboos teach us to remain flexible, still they are stable, even though they have a big height. So as the Secretary of Indian Orthopaedic Association, I request you all, because there is a big gap in the Chhattisgarh members and the members of the Chhattisgarh in the IOA. So I request the office bearers and the members to become a member of Indian Orthopaedic Association. And there are a lot of benefits now academically to the younger generation. So many fellowships we have instituted. So take advantage of that, becoming a member. This is a message to the members. Thank you very much.
Sir, in comminuted humerus fracture, you have passed 2 enders, 3 enders nail, and thereafter you have done internal splinting by passing the plate.
Right.
You can achieve with LRS the same thing.
Yes.
Without putting the plate inside, you can pass external fixator with enders nail.
This is one of the ways.
Yeah.
This is an optional way.
Yes, yes.
There are many ways.
Yes.
Okay.
Thank you, sir. We conclude this session. For the next session, we have a fractures around the elbow. I like to request Dr. K.S. Chabra sir, Dr. B.L. Lalchandani sir, and Dr. M. Rajshekhar sir to kindly chair the session.
I invite Dr. Amit Ajgaonkar for his talk on complex all-ground fracture. Please. This is not done. Plate locking plate.
We all are very much aware about the fixation of the distal humerus, the olecranon. We have been doing olecranon fixations in distal humerus fractures also. But certain fractures in olecranon are different. They are not always the intra-articular type and non-comminuted type fractures routinely which you get. These are the complex fractures in the olecranon. They present as oblique, comminuted, or with a fracture and dislocation. You have to appreciate, you have to diagnose them on the X-rays. Fracture dislocations, let us discuss first, because oblique and comminuted you will be easily coming to know. And in these, the mode of fixation is different. You just cannot go away and do just a TBW. You have to do a plating. Now look, it's a transverse fracture, oblique or comminuted and fracture dislocation. A fracture dislocation would be an anterior or a posterior. I'll tell you what is an anterior and what is a posterior olecranon fracture dislocation, and a Monteggia fracture dislocation. Now this is the slide of this talk. If you just know this slide, your fracture fixation is done. Here, in the first one, this is the anterior, relatively benign type of a fracture dislocation where the whole radius ulnar complex is displaced anteriorly. Look, there's a dislocation, but this is an anterior dislocation. Whereas here, this is going posteriorly. So this is more complex and more difficult to treat, this posterior fracture dislocation. You have to know that one thing you just keep in mind, that a posterior dislocation needs something else other than a plating. So in the anterior dislocation, the most important thing is that the proximal radioulnar joint is not disrupted. The radial head is fractured rarely, but sometimes it is fractured, which may be neglected or may be plated. And collateral ligament injuries are not. So there is no instability in an anterior fracture dislocation. Whereas in the posterior fracture dislocation, look what all has gone. It's a type of a posterior Monteggia lesion. Posterior dislocation of the radial head with a fracture. Coronoid fracture is there. There's a disruption of the proximal radioulnar joint. There's an injury to the LCL complex. The common extensor origin can be avulsed. Persistent instability postoperative. If it is not treated anterior, so this posterior fracture dislocation, you have to treat it not only as a fracture, only bone treatment, but you have to treat it as a soft tissue injury, like you treat the terrible triad also.
With your load shift test.
That's the posterior dislocation.
This is the
so now the posterior Monteggia fracture dislocation can have various types. This is Bado's classification. Bado had talked about the ulnar fracture at the level of the coronoid with disruption of the trochlea, ulnar fracture distal to the coronoid, diaphyseal ulnar fracture, comminuted ulnar fracture from the diaphysis to the trochlea. So it all talks about the ulnar fracture. Ulnar fracture may be more comminuted, maybe its location is different. So this is the Bado's classification. You have to keep in mind that the treatment would be as the classification goes. Your goals of treatment should be restoration of the articular surface, that is most important. Joint stability and motion should be restored. You may not get a good motion, but stability of the elbow joint is most important. As Tanasar also said, that you just don't think about replacements in the elbow joint. You have to get a good stable elbow joint, though your elbow is having less motion. Preservation of power of extension and prevention of complications. So this is a comminuted fracture wherein we went ahead and did this. This is a plain, simple comminuted without a dislocation. You have to go ahead and do a plating. numerous plates which are available in the market for the olecranon. Anterior fracture dislocation, you have to reconstruct the trochlea. Look, maintain the bare area between the two processes. Do not overcompress. You should know where you are going to overcompress your olecranon, and maintain the alignment between the olecranon and the coronoid. This is an anterior type of fracture dislocation. As I told you, the whole radius ulnar column has shifted up. So this is an anterior, relatively benign. Just think about it as only an olecranon plating. Go ahead and do an olecranon plating. The patient will do well. Now this is a posterior dislocation. Look, the whole complex has gone down well. You have to restore the ulnar length, alignment, proximal radial ulnar joint, coronoid fracture fixation, stabilize with a posterior contour plate, and the most important is ligament reconstruction. Very, very important, ligament reconstruction. Don't get bored, don't get tired. You have to reconstruct the ligaments, otherwise you have done a half-hearted job. This is a case wherein we had an anterior dislocation. We went ahead and did this type of plating. Initially, the plating, the post-op results, the X-ray doesn't look that good. But look what has happened. 6 months post-op, and this is 3 years follow-up. And this is the patient at 3 years. And this is the range of movements. So you have to know how you are going to treat it. Your X-ray should be relatively good. You have to use your proper instrumentation and you will get good results. This patient came back to me for an implant removal, which I didn't advise in them. A comminuted olecranon fracture with a comminuted radial head. We went ahead and excised the radial head because it was a relatively benign one, and did an olecranon plating. And this is 6 months down the line and the patient did well. A posterior fracture dislocation here. And this is a very bad one. And here, this is another posterior fracture dislocation where we went ahead and did this multiple platings and ligament reconstruction. And this is the ligament reconstruction, and see the range of movements. There's an extension lag, but the extension is strong enough for the patients to do his routine activities. In all, you have to note that there's an anterior dislocation and a posterior trans-olecranon dislocation. In the anterior, it is relatively benign, but in the posterior, which is worse injuries with higher incidence of OA and poor clinical results. Recognize your complex fracture patterns well. Be prepared for comminution and coronoid fractures. If at all coronoid is there, you have to fix it or lag it with a screw from your plate. Be aware of potential ulnohumeral instability and ligament injuries. Use long posterior contoured plates. Get a CT done to understand the fracture better if possible. Thank you.
Amit sir, may I ask one query, please?
Yeah.
In a posterior dislocation, olecranon comminuted, when the olecranon is fractured and coronoid is also fractured, after reduction, how you fix the coronoid? From posterior only, or you get what for anterior also?
That is
how you hold the reduction?
Debatable question, because it's a very good question. How do you reach the coronoid?
Because in that case,
if you ask,
brachial pull the coronoid.
Me and Tanna sir have debated on it. I talk about going from the medial side, and sir talks about plating and lagging it from the
intromedial.
Yeah, holding the coronoid, and you can lag it. If you cannot lag it, then you have to approach it from the medial side, the coronoid.
But it will displace the coronoid, I think. You have to hold the coronoid first and then fix. But it's very difficult to hold because brachial plexus, brachial muscle is just pull out this one.
No. You have to
usually in coronoid we fix from the interior, intromedial like thing.
You are opening it from the posterior side, along posterior. There you can go, you can approach the medial side as well as the lateral side. And you can hold the coronoid from there inside, not from the skin. Yeah?
Thank you.
Thank you. If it is a benign type of, that is an anterior dislocation where I know that there is good stability, ligaments are maintained, I will go ahead, and if the radial head is not reconstructible, I can excise it.
Hello.
If it is a malignant one where the ligament injuries are there, then you have to you cannot replace you have to replace or you have to reconstruct the ligaments.
Now I will request Dr. Thanna sir for his talk on terrible triad, unhappy triad. There is a separate talk on radial head. I think the doubts will be clear.
First,
we got to see the stability of the elbow joint. You can see two bones, MCL and LCL. These four things combined give you the stability of the elbow joint. Now, if the ligaments and muscles rupture, that means there is the elbow dislocation without any bony fracture, then the elbow is stable most of the time. Till now, we always say it is always stable, but there are a few reports which have come that if there is no bony fracture also, this elbow can be unstable. So they want us to re-examine the patient in about a week or 10 days time to see that it is stable or no. Most of the time, this elbow is stable. You don't need to really immobilize them except the pain for a week, and then you can start mobilization. Now, the normal isolated head radius and neck fractures like this, with MCL intact, if we excise the head of the radius, which we have been doing it normally for all these years till the time the replacement and all came into the picture, elbow joint is stable even if you excise the head of the radius because the MCL is intact. Now, if the radial head and neck fracture with the elbow dislocation, in there what has happened, the head radius is fractured or dislocated and the MCL is also gone. So in such fracture, you cannot excise the head of the radius. So you don't excise the head of the radius, either we repair the head of the radius, either replace it or repair it. Then the stability is achieved most of the time. Now, so many times the surgeon decides to excise the head of the radius into the, considering it an isolated fracture head of the radius. So you got to see it on the table that under anesthesia, it is stable. If it is isolated head radius, there will not be medially ecchymosis. So you see the ecchymosis medially, and on the anesthesia, see that it is stable. Now you can go ahead and excise the head of the radius. If it is unstable, don't excise. You'll have to repair or replace. That is the criteria where you can, and generally, isolate a head of the radius, there isn't much of a swelling. While if there is a fracture dislocation or the MCL is gone and head radius is fractured, then there is going to be a big swelling there. So these are the few points which you got to be considering before excising the head of the radius. So head radius and coronoid fracture, you got to repair both. Then only there is a stability. Otherwise, there is no stability. And after repairing the both, you will have to suture the LCL. If you don't suture the LCL, then also is not all right. So in a typical terrible triad, repair the head of the radius or replace the head of the radius, repair the coronoid, and repair the LCL. This is absolutely mandatory all the time. Now here it is, you can see, this is the one which I was talking about, the ecchymosis on the medial side. The head of the radius is fractured and there is ecchymosis. So even if the elbow is not dislocated on the X-ray which you have taken, this is elbow is dislocated and it is relocated. So that's the one, be careful to excise the head of the radius in this situation. Now we all know with a terrible triad, if all the body structures regain their length, then only elbow becomes stable. Repair the head radius, repair the coronoid, and most often elbow will stabilize. If it is unstable, then stitch LCL. So repaired bolts with original structures give maximum stability. Head radius fracture can be repaired to normal shape when there is a split. If there is a split like this, then it becomes normal. When you repair it, the evidence is that if there is a three-part fracture, it is repairable. But if there is a more than three-part fracture, there is a lovely article by these authors, J.C. Jupiter and Quinterio, that if there is a more than three-part fracture, it is not repairable and you will not get a good supination pronation. So that is the one which they recommend it should be replaced. Associated fracture dislocation of the elbow or a forearm may also compromise the long-term results. So our data suggests that open reduction and internal fixation of the head of the radius is best reserved for minimally comminuted fractures with 3 or fewer articular surfaces. Now here is the fracture head, fracture dislocation. You can see this is the one where one case will almost give us the whole information. This is the one which is fracture dislocation. Now here, head was replaced. Head was replaced. Still you can see there is instability. So went down and stitched the LCL. Stitched the LCL. Still the head is unstable. So now stitch the LCL. Even after LCL also the head is unstable, as you can see it here. So now went down and stitched the MCL. Once you stitch the MCL, mainly the anterior part of the MCL, now the elbow is stable. So stability of the elbow, repair the head, repair the coronoid, repair the LCL. If still not repairable, then repair the MCL. And if not still stable, then give a hinge splint, which is a compromised. So here in this case is a child, 10-year-old child, fall 5 days back when presented with complaints of pain and swelling on the right elbow. Initial X-ray showed a posterior dislocation elbow with radial head fracture. You can see the radial head fracture, which is really displaced onto the medial side with the elbow dislocation. And you can see it in CT scan, the whole thing is very well seen. So, and when I saw the patient, you can see the whole head is really unstable. So this was the head which was extracted out and it was repaired. Once the head is repaired here, now again look for the stability. And here it is beautifully demonstrated. This is MCL. I have put the stitches on the MCL and I am seeing the stability part. When the MCL is loose, the elbow is unstable. When I am trying to tighten the MCL, the elbow will become stable if it is tightened properly. Here I initially tightened it not so well. I pulled it only and still the elbow is unstable. Now I sutured the MCL, crossed it and sutured it. This is temporary. Anterior capsule with the MCL, and now you can see the head is stable. So it demonstrates what is the importance of MCL with anterior capsule in an elbow dislocation. Now here it is, 4 months later, the head is viable. I have told them you may need an excision of the head when the child is elderly. And here it is, after a long time, the head is there. This is 1 year result. Supination, pronation is there. Elbow is not fully flexible. But this is the best you can do for a 5-year-old child with fracture dislocation elbow. Now here was the child which I inherited. Again at this stage, the surgeon did the olecranon. The head of the radius was left alone. Now here it is on the table, you can see it is dislocated. You cannot accept anything which is short of perfect. So here it is dislocated, you could see it very well. So I went ahead and I saw the head of the radius. You can see the head of the radius, I thought it will need a replacement, but you can see there is a split head of the radius and head of the radius is good, but is angulated. So this angulated head of the radius, I corrected it and perfectly normal head of the radius was repaired. And then once it was repaired, you can see it very well. Once it was repaired, fixed it up with the plate and everything becomes perfectly all right. And in this gap which was there, allograft was put in order to stop it. And then the olecranon was repaired again. And here it is, everything comes back to normal. The elbow becomes stable and you can carry it on. And this is the way in which you should repair the whole thing. So here is the range of movement patient has got in 2 months' time. And now it is 8 months, about 75 to 80% range of movement is regained. In conclusion, must repair 2-part fracture. Replace if not repairable, head of the radius I am talking. More than 3-part repair, not very fruitful. Replace. After replace, not very good range of movements, may need to be removed at times, 40% of the times. So head of the radius, even if you replace, it is recommended don't put in a cement. Don't put in a anything which is going to really form bone on the head of the radius. Just put it as a spacer, because 40-50% of the time it needs to be removed. So it will be easier for you to remove. So it's a spacer in order to stabilize the joint. And this is all what you need to do for the head of the radius. Thank you very much. Any questions before the next person comes and talks?
Are you going to put the head in the same sitting or in the second stage?
Sorry?
Are you going to replace the head on the same stage or at a second stage?
It has been repaired very well.
Because so you are repairing the MCL, you are repairing the LCL, maybe a bad injury of the soft tissue also. Would you like to wait for some time or would you go in a...
Whatever you want to do it on day one.
Thank you.
Thank you, Dr. Tanna, sir. May I call Dr. Manish Raj from AIMS Devghar for his deliberation, radial fracture to fix or excise or to replace it.
Meeting है यार.
Respected chairperson, dignitaries on of the dais, very good afternoon to all of you. First of all, I'd like to thank the organizing team and especially Alok sir for inviting me to present my work on radial head. Tanna sir has already made my talk much easier by explaining all the things so beautifully. So basically, I am going to talk today on radial head fracture, whether to fix, excise or replace. The main function of the radial head is it is a secondary valgus stabilizer along with the medial collateral ligament, and it also acts as a longitudinal SCL stabilizer with the intraosseous membrane and distal radial joint. And the most common classification that we use is Mason classification, which classify radial head fracture into 4 types. The common treatment options are conservative, variable to excision, fixation, or replacement of the radial head. If we look for the guideline of radial head fracture treatment, there is not much controversy in Mason 1 and 2 fracture classification, but controversy lies in Mason 3 and 4, whether to go for repair, fixation, or excision, and also in case of ligamentous instability. So first I will talk about the radial head excision. It's the commonest used method, safest also, but the clinical outcome is guarded. And there is higher incidence of elbow instability when you excise the radius, the proximal radius migrate, and for each mm of radial shortening, the distal ulnar load increases by approximately 10%. So the main problem with the radial head incision is when there is ligamentous injury, either medial or lateral side is present. So most important thing is test elbow stability intraoperatively. It is very important to test the elbow stability intraoperatively. And what the literature suggests for radial head excision is that it gives good to excellent result, but it should not be performed when ligamentous injuries are present. If you look at the kinematic instability of the fracture and implant, in cases where there is a ligamentous injury present, the instability has higher chances as compared when there is no ligamentous injury. So in simple, someone has asked when to excise radial head, only critical factor is go for the stability of elbow. If elbow is stable, you can go for radial head excision. If elbow is not stable, don't go for radial head excision. Coming to the radial head arthroplasty, it is incidentally formed to prevent heterotropic ossification, but after in 1980s when modular implant came, there is a very revolution in the field of radial head arthroplasty. Various implants have been evolved, starting from celastic prosthesis, which has a high failure rate, to metallic and floating head radial prosthesis. But the question arises which implant to use, whether to go for monopolar or bipolar, press fit or loose stem, cemented or non-cemented. And the literature suggests use monopolar modular with loose fitting stem. Now this case come to us with the elbow dislocation. We reduce it in an emergency. It shows a radial head fracture. CT scan confirm it. We had done the radial head replacement. And this is the functional outcome that we achieved with the patient. This is another case where this fracture of ulna with comminuted radial head fracture. We
Recording in progress.
And presence of ligamentous injury. And based on these 4 factors, I proposed an algorithm in which if you have radial head fracture, first see whether it is comminuted or non-comminuted. If it is non-comminuted, go for elbow stability. If elbow stability is present, you can go for radial head excision. If elbow stability is not present, go for plating or radial head arthroplasty. And look for combination. If there is severe combination, then go for the radial head replacement. But if you are confident you can fix the radial head, then only go for radial head reconstruction. Thank you.
Any question? Time is remaining there. Thank you, Dr. Manish. Now, this is the end of the session. Now invite another chairperson to I invite another chairperson to take seats.
Thank you, sir. For the next session on hand and forearm, I'd like to request Dr. Kedar Agarwal, sir, Dr. Shailendra Upadhyay, sir, Dr. Ajay Pathak, sir, to kindly chair the session.
Very good afternoon to respected chairpersons and all the dignitaries on and off the dais. My topic is scaphoid fracture. I will be mostly discussing on acute scaphoid fractures. So scaphoid forms important mechanical linkage between the proximal and distal carpal rows. It is a irregularly shaped bone, and most of the surface of scaphoid is covered by articular cartilage. Because of that, it lacks the periosteal healing, and most of the healing depends upon the endosteal healing. Because of its unusual retrograde blood supply, the scaphoid has a high risk of non-union osteonecrosis of the fracture, mostly the proximal pole. It is one of the most common carpal bone to get fracture, and mostly in the younger age group. The mechanism of injury is mostly a fall over the outstretched hand with radial deviation, and the patient typically presents with a radial side wrist pain, and many times late presentations are also common. So thorough physical examination in high suspicion cases is important because as per this paper, there is high incidence of missed fracture in case of scaphoid fractures. So thorough physical examination starts from a good clinical examination. It includes tenderness on the anatomical stub box, which is does soft spot the distal to the radius styloid, tenderness over the scaphoid tubercle, which is over the volar aspect, tenderness on longitudinal thumb compression. We can ask the patient to do a strong pinch and anatomical snub box pain in ulnar deviation and pronation. And if all these 4 or 5 tests are positive, then it is 100% sensitivity and 74% specific for scaphoid fractures. Adding scaphoid compression test, specificity reaches to almost 74%. So thorough clinical examination is important while we are dealing with a patient with or we are suspecting a scaphoid fractures. Now, after thorough physical examination, the role of X-rays are very important. So first important X-ray is posterior anterior view. PA view is important, and we have to get the PA view with shoulder in 90-degree abduction, elbow in 90-degree flexion, and forearm fully pronated over the X-ray film. Second, PA view in ulnar deviation. Now we know the scaphoid is obliquely placed. So once we do the more horizontal and whole scaphoid profile is visible on the X-ray. 45-degree pronation view and lateral view to rule out humpback deformities. Adding oblique views, that are supinated and pronated oblique views, also increases the sensitivity and specificity of the X-rays to almost 100%, which are helpful in diagnosis of scaphoid fractures. But still, up to 25% of the X-ray fractures are not visible on radiograph. Our classical teaching is to wait for 2 weeks and then repeat the X-ray. But what the present recommendation says, and if the sometimes patient don't want to wait for 2 weeks, if we want his diagnosis early. So as per the present recommendation, clinically suspected fractures, spatial radiographs are negative, then we have to switch on to the higher investigations like CT scan and MRI. So MRI is a second line test in negative radiographs. It is helpful in diagnosis of other carpal injuries, ligament injuries. It has a highest sensitivity and specificity. So if the X-rays are negative, and if the patient will have a strong clinical suspicion of scaphoid fracture, then we can go for MRI or at least CT scan. If the fracture line is visible on X-ray, then whether it is a stable fracture, unstable fracture, so we have to needs a CT scan, and CT scan is to be oriented along the longitudinal axis of the scaphoid with 1 mm of cuts. It is helpful for surgical planning and to diagnose the other bony injuries. So MRI, if the X-rays are negative or in case of occult cases, and CT to decide the treatment part and to see whether the fracture is stable one or unstable one. So once the fracture is diagnosed, which ones to treat non-operatively, which one needs surgery, and which method and implant to use. So the determinants of the treatment are stability of the fracture, location of the fracture, that is whether it is a distal pole, waist, proximal pole fracture, and patient factors. If a patient is a high demand patient or an athlete, or he wants his function to return to function early, then we have to accordingly plan it. So as per this Herbert classification, stable acute fractures are only 2, fracture through the tubercle and incomplete fracture to the waist. Rest are all the unstable fractures. So undisplaced or minimally displaced fractures as per X-ray, CT or MRI are the one with less than 1 mm displacement, no angulation and no translation. And the displaced one which have more than 1 mm of the angulation, more than 1 mm of displacement, lateral intrascaphoid angle more than 35 degree, bone loss comminution, proximal pole fractures, and peninsular fracture dislocation. So these are all the fractures which needs surgical intervention in one or the other forms. Stable fracture can be very well treated with the help of scaphoid cast. It has shown that it gives union rate up to 85 to 93%. But the position of the scaphoid cast is important. We have to apply the cast in either neutral wrist flexion or slight palmar flexion with thumb in abduction. So why wrist need to be flexion? Why slight flexion is needed? Because of this important ligament, that is radioscaphocapitate ligament. So once it is along the volar aspect of the scaphoid, it acts like a ribbon. So if we dorsiflex the wrist, there are high chances of displacement of the scaphoid at the fracture side. So it is recommended to apply the plaster in neutral wrist flexion or slight palmar flexion with 10-degree radial deviation and thumb in abduction. It is always better to incorporate the thumb, because as we can see in this picture, the compression forces through the thumb acts on the fracture side, and there are chances of displacement of the scaphoid. Nowadays, people are following aggressive conservative treatment in which in this minimally displaced or undisplaced fracture, we have to apply the cast, and after 6 weeks get a CT scan. If the union is well, then continue with conservative treatment, or else switch on to percutaneous fixation or surgical intervention. So surgical fixation is needed for displaced fracture, undisplaced fracture and comminuted fractures. Internal fixation is by either percutaneous technique, open method, arthroscopy assisted nowadays, and fixation and bone grafting if SOS is required. Commonly used implant is a headless cannulated screw, that is Herbert screw, which provides compression at the fracture, promotes endosteal healing, prevents articular cartilage damage, and gives the rotational stability also. So percutaneous fixation in case of minimally displaced fracture, or in the displaced fracture where we can able to achieve the reduction, we can go for percutaneous fixation by either volar approach or dorsal approach. So entry point is most important thing in if we are planning for percutaneous approach. If the fracture is at the distal pole, or if the fracture is at the waist, then it is said to choose a distal entry point, which is the volar aspect. And for proximal, if the fracture is at the volar aspect, then we have to go for the dorsal entry point. If we are planning for volar approach, volar entry point, then we have to keep the wrist dorsiflex, or we can just put a small pillow or towel below the wrist and slight radial deviation, so that we can able to point, we can get a proper trajectory towards the scaphoid, and we can insert the K-wire through the center point of the central axis of the scaphoid. And if we are dealing with a proximal pole fracture and we have chosen the proximal entry point, that is the dorsal entry point, we have to keep the wrist palmar flexion, and then just distal to the Lister tubercle under Shyam guidance, we have to insert the K-wire, but there are high chances of displacement during this. So we have to initially we have to start marking our with the help of K-wire the central axis of the scaphoid, both in AP and lateral view, and where the intersection point is there, at that point we have to insert our K-wire and check both in AP and lateral view whether it is going to the central axis. We can add one more K-wire to give additional stability, measure the length of K-wire, then gradually drill it, and we can insert the scaphoid screw after proper measurement. And we have to check it both AP and lateral view and oblique view, so that the screw is through the central axis of the scaphoid bone. When to open? If it is displaced, irreducible or comminuted fracture, or reduction is not acceptable, then we can go for open. We have to open it. Commonly used approach is a volar approach, because it is useful to correct humpback deformity, least disturbance of blood supply, and good visualization of entire scaphoid. So this is a common volar approach through the FCR sheath, where we have to expose the proper scaphoid unit and long radial unit ligament. Sharp dissection, we have to do the sharp dissection, expose the entire scaphoid, and then fix it. If required, we can go for bone grafting or whatever implant we are using. But closure should be meticulous. We have to properly close the capsule and the ligaments which we had cut. For proximal pole fracture, all displaced and undisplaced proximal pole fractures need fixation, either open reduction or mini open reduction by dorsal approach or dorsal percutaneous approach. But we have to check repeatedly regarding the displacement of the fracture. So to conclude, suspected scaphoid fracture where initial radiographs are negative, either MRI and CT need to be carried out. CT scan for displaced, undisplaced fracture for evaluation and fracture healing. Union can be achieved in the minimally displaced fracture with the help of cast, and internal fixation is required if it is a displaced fracture or proximal pole fracture. Thank you. Thank you very much for your patient listen.
Nice talk. Nice talk. I would call upon the next speaker, Dr. Purnendu Saxena sir, to deliver his talk on crush injury of hand.
So we'll speak on in the next.
Thank you very much, sir. I think this presentation would be just a framework on which we can decide when we get all these crushed hands. Every injury is unique, but we need to have some framework to proceed on them. So basically, it could be a radial injury where thumb is injured, thumb is not there. It may be ulnar or central where thumb is present. It may be extensor surface injury or the injury to the volar surface, and distal transverse amputations. These are very common. There could be obviously combination, and there may be degloving injuries, but for a working understanding, this is where we can start with. So obviously hand injury is a domain where orthopedic surgeon and plastic surgeons, they work together. And I have an experience that people see the things differently. Plastic surgeons see the things like skin, complexion, fat, but anyway, how thick the skin is, how sensitive the skin is, where can we get the skin covered from. So that is their way of seeing the things. And as you know, orthopedicians, they see the figure. But with both these views, what we actually want to achieve is a good function and good result at the end of that. So it is a team approach. And in general, a hand clinic should have orthopedic surgeons, plastic surgeons, physiotherapists, orthotists. And I have put another thing, dedicated patients. Many times these patients are not as motivated as you would like them to be for to get a good hand results. Many of them, they depend on their paymasters, and paymasters are much more concerned on day one and not later on. Many of them, they don't want good hand function, but they want a disability certificate. So a dedicated patient is a very challenging thing in this field. How to manage crush injuries? So obviously see the figure. Here we mean, by figure we mean the position of the wrist, position of MP joints, IP joints, position of thumb in relation to rest of the hand. And obviously chest frame helps nicely when we maintain this. And obviously to see the cover, plastic surgical procedures are required. Function should be kept in mind from day one. Whether we want to achieve a bipolar hand, can we achieve the bipolarity? Can we get some hook functions? How the tendons are working, how the nerves are there. Is it going to be sensate or insensate? Can we maintain it somehow? So function is to be kept in mind. And another thing is, for the hand to be working in the future, you need to start functioning from day one in some or other way. So we will discuss it further, but change the frame, change the rigidity of the hand frame, add splints and get it done. So this is a radial injury where we haven't got any thumb or index finger here. Day one, we decided to rotate the third middle finger's metacarpal to bring it in opposition to the rest of the thumbs, try to maintain bipolarity. Gradually, the frame is being reduced. The dressing is to continue. Position has to be maintained at the wrist, MP joints. And obviously, function needs to be, some kind of function has to be started as soon as possible. Nail tractions help maintaining the mobility of these ulnar two fingers. We know we want to have bipolarity, but also the grip is the function of the ulnar side. So these two finger movements are very important. And we eventually get reasonably good results. So thumb reconstruction is what is the priority on the radial side. Take it that way. Policization, wraparound flaps, toe to thumb transfers, bone grafting, lengthening, all these things. But we obviously can't go in details of all these things, but that is the priority for radial injuries. Now, central or ulnar injuries. Here, this is a patient who came late. He has got an infected bone and wound there. From orthopedics point of view, the wrist is completely flat, thumb is in nowhere in the same plane as the rest of the fingers, MP joint is straight, there is osteomyelitis. So this needs to be improved. Obviously, we correct the position, we try to maintain the mobility of whatever is left, and get rid of infected part, get some cover. So again, see the figure, see the cover, start functioning, keep on using, and must appreciate that ulnar fingers, when we talk about the ulnar injuries, they provide the main strength of the grip. So this kind of function needs a continuous focus on movements. Third is extensor surface injuries. Extensor surface injuries are the least destructive, I would say. Obviously, again, in this injury, there are extensor tendon injuries. Also, it's a combination of index finger injury. So you need to stabilize these fractures, position them properly, let it heal. And while healing, you need to obviously give some nail bed traction to keep it moving. And as the time goes, you allow or give freedom to fingers so that they are not rigidly fixed, but you start to move them within the frame. Frame maintains the position at the wrist, and you start to get grip function. So this is what extensor surface injuries are. Again, we need to have skeletal stability. In this example, we don't have that problem of extensor tendons. They were exposed and gone, but skin was good. But in many cases, you need a good skin cover as well. You can do a split thickness skin grafting on day one, and you can go on and do a flap later on, and you can do the extensor tendon reconstruction later on. You may need reverse knuckle. This is an example where initially there was a split thickness grafting was done, and later on a flap was applied. These are reverse knuckle bender splints and flapper splints, which we need to get movements eventually. Volar injuries, as you know, they sometimes suture it and send it to you like it's nothing there, but obviously you can see that two flexor tendons are gone. See the cascade of fingers, and when you expose the suture wound, it is a big injury inside affecting tendons, nerves, vascularity, and so on. So again, tendon and nerve injuries are the important aspect of the volar injuries. Plastic or hand surgeon involvement early is required. You need to go for extensive incision, start defining the internal structures, especially from normal to injured area progression. And restoration of, once you have repaired it, natural cascade of finger must be maintained. You need different kind of flaps and procedures like groin flap, free flaps, reverse radial artery flap to get the cover. Tendon injuries must be dealt appropriately. This is modified Kessler suture, which is the mainstay of our work. Atraumatic needles to be used, 3 central core sutures, then circumferential sutures. Important thing is also to focus on the physiology of the healing. Early loading of tendons leads to better collagen tissue alignment. But you should also remember that the suture is weakest, or the repair is weakest at around 3rd week. So a good balance between the two has to be maintained. Belfast regime is good about it. And you can also use fixators, our chest fixators as a splint. Now, transverse amputation, they could be phalangeal, they could be metacarpal level, they could be thumb amputation, there may be ulnar loss. Here, basically, we are much more relying on microvascular surgeons, especially for reimplantation and toe transfers. You should also remember that even though it is looking just simple cut, but there may be extensive soft tissue injury, there may be a stretching of lumbricals, and there may be compartment syndrome within the hands. And here are some pictures example of second toe transfer reimplantation. So I just wanted to give a basic framework on which you can plan reconstruction of your mutilated hands. Also very important is to document and assess the injuries in objective fashion. I think this is a hand injury severity score, especially those young guys who want to do some basic research on this side. They should use this system to document the injuries and also correlate it with some objective scoring system. Thank you very much.
Thank you, Dr. Saxena. Now I invite Dr. Jiten Misra to deliver talk on upper limb reconstruction.
Good afternoon, everybody. At the outset, my special thanks to Professor Alok Agrawal sir and his entire dedicated team for arranging this conference. And this is a very huge topic to be covered within the stipulated time. Thus, I included only the workhorse flaps for reconstruction of different anatomical region of upper limb in my slides. So there is an increasing trend in the trauma, so that there is an increased need for the reconstruction around different anatomical zones of the upper limb. The tissue defects around the upper limb are potentially disabling. So appreciating the etiology of and socioeconomic implications of upper extremity wounds is essential for successful outcome. The paucity of the local tissue and most often its involvement in the zone of trauma complicates the reconstruction procedure, and it is often challenging for the reconstructive surgeon and the optimal options to be chosen from the myriads of flaps available. And the indications being traumatic tissue defects, burn, tumor, congenital anomalies, contracture release, infection, osteomyelitis, and in case of exposed to prosthesis, and in cases where the joint replacement is planned in the deformed joint where there is a lack of tissue. So the essence being to protect the underlying vital structure, to restore the form and function. Pliable but stable coverage is needed at the joint areas like elbow and wrist, and prevention of contracture across the joints, and simultaneous reconstruction of important underlying structures, or the secondary reconstruction of the damaged structures later on after flap coverage. And replacement of like and like tissue is the fundamental of principle of reconstruction. Also, due care must be given to the flap donor site. So it is for the surgeon to choose for the reconstructive ladder, which is the basic for reconstruction, or use the reconstructive elevator to achieve the goal. If the surgeon is versed with the microvascular technique, then he can use the reconstructive elevator to accomplish the goal. Coming to the regional areas of reconstruction, the workers flaps for digit and thumb reconstructions are cross finger flaps, Atasoy VY advancement flap, Littler's digital neurovascular flaps, and for thumb defects, FDMA flap, posterior introsseous artery flap, reverse radial artery flap. And some illustrative cases. This is a case with necrosis of the distal phalanx of the thumb, which was reconstructed with first dorsal metacarpal artery flap. This flap is based on the first dorsal metacarpal artery along with its vein, and it is made sensate with the superficial branch of radial nerve, which is supplying that area. And the limitation being it has a limited donor area, and needs meticulous dissection of the subcutaneous pedicle. This is a cross finger flap. It is conventionally used for the tip of the finger as well as the volar aspect of the finger. And the limitation of the flap is that it is a staged procedure, and the flap being detached after 2 weeks. And for that period, the fingers are being strapped and immobilized. This is a BY advancement flap. This is for the tip of the finger injury, where it can be carried out and local anesthesia, and it is sufficient for coverage of the teeth defects. Reverse dorsal metacarpal artery flap is very useful flap for reconstruction of the web spaces and the proximal phalanx, distal phalanx. It can be a pedicle flap, or it can be subcutaneously tunneled through the tissue to cover up the area. The groin flap can be customized, as in this case, there is multiple defects over the thumb and as well as the polar aspect of the hand. And the bifid groin flap can be carried out. And of course, it is a staged procedure. A groin flap for thumb amputation defect as well for the hand defect. This is a case of post-traumatic defect over the thumb, which was reconstructed with reverse radial artery forearm flap. It is one of the workers' flap for thumb defects, dorsum of hand, and volar aspect of the hand defect. This flap, the limitations being, it includes the one of the major vessel, and the prerequisite for this flap is there should be ulnar artery patency, and the arch, palmar arch should be patent. This is reverse radial artery perforator based flap. This is a modification of the previous flap where the radial artery is not included here. And neurofascicutaneous flap is elevated on the subcutaneous pedicle, and flap is islanded, of course. And this is based on a perforator which is located 4 centimeter proximal to the stylet process of radius. And this is a very suitable option. And here the limitation being the flap donor area needs to be grafted, which may be unsightly and unacceptable cosmetically to the patient. For hand defect reconstruction, the options are many, and among which the workers' flaps are posterior introsus artery flaps, reverse radial artery flap, reverse radial artery neurofascicutaneous flap, propylar flap, free tissue transfers like anterolateral thigh flap, latissimus dorsi flap, groin flap. And in case of loss of metacarpals due to trauma, the reconstruction can be done with a free fibula flap. Some of the illustrative cases, this is a post-traumatic dorsum of hand defect with loss of soft tissue and with exposed tendons and metacarpal bones, which was reconstructed with anterolateral thigh flap. This is a very suitable and workhorse flap for all kinds of upper limb reconstruction. And the pedicle being the descending branch of lateral circumflex femoral artery, which is not a major vessel and which can be sacrificed. And you can see the razor with a very stable and pliable coverage over the dorsum of the hand. Here the etiology is burn due to spillage of the molten material, and similarly this defect was reconstructed with a thin LT flap, and here the bulk is less. This is a posterior introsus artery flap which is executed for coverage of the post-traumatic hand defect. Here, the circulation is dependent on the communication between the anterior introsus and posterior introsus artery. And this pedicle can be tunneled to the subcutaneous tissue, and it can reach up to the metacarpal phalangeal joint. And this is a well-suited flap for the dorsum and volar aspect of the hand, even for the thumb, even for the past web space. This is one of the cases of composite tissue loss due to trauma, where there is loss of fibula, loss of multiple metacarpals with loss of tendons and MP joints of the first and second metacarpal phalangeal joint, and there is also a subtissue loss. It was addressed primarily with a osteocutaneous fibula flap, where the segment of the fibula has been filated and maintaining the circulation and periosteal blood supply to the distal segment of the fibula. Both the segment of the fibula has been used for the reconstruction of the metacarpal and the subtissue being reconstructed with the skin pattern. Reconstruction options for wrist and forearm are many. Propeller-based, perforator-based propeller flap can be done. Free LT or latissimus dorsi flap can be done. Keystone flaps, groin flaps, and abdominal flaps are other options. And for coverage of the forearm defects where the only muscles are exposed, skin graft can take over the charge. So this is a propeller flap for wrist defect. The concept of recruiting the proximal non-affected, non-traumatic tissue for reconstruction of the distal defect where the tendons are being exposed basing on the perforator. This is a perforator-based propeller flap, and the flap is rotated 180 degree to cover the distal defect. This is a groin flap which was used for the recurrent adnexal tumor. This was a post-traumatic defect where the dorsolateral aspect of the wrist was covered with the anterolateral thigh flap. This was a defect almost involving the lower half of the forearm and the thinner aspect of the hand, which was reconstructed with a thin LT here. A big LT was elevated 20 into 10 centimeter and covering the defect with safeguarding the underlying bones and tendons. This is a new concept of keystone flap where the proximal part forearm skin island was elevated adjacent to the defect, and based on the subcutaneous flimsy attachment incorporating the perforators from the radial artery, and the flap is advanced to cover the defect. Here primarily we undertook the median nerve repair with sural nerve cable grafts.
Dr. Misra, please summarize.
Sir. So for elbow defects, the proximal pedicle radial forearm flap is very much useful. And latissimus dorsi flap can cover the arm and elbow defects. And reverse lateral arm flap can be used for the elbow defects. As well, abdominal flap are the reserved option. So majority of the upper extremity defects can be covered with the latissimus dorsi or ALT flap. And for small defects, regional flaps can be planned. And to conclude, the defects around different anatomical zones of upper extremity have anatomical and functional challenges. The ultimate reconstruction, success of reconstruction relies not only on the flap survivability, but also physiotherapy and motion exercises. And this upper limb reconstruction can be successfully undertaken using workers' flaps presented here with meticulous technique. Thank you for patience.
Any questions, please? No question. Thank you. This is the end of the session. Who invite करेगा ना?
Our next session will be on lower limb fractures. I would like to invite Dr. K.D. Tiwari sir, Dr. H.S. Agrawal sir, and Dr. Jayesh Dave sir to chair the session, please. I would like to invite Dr. Ankit Kumar Garg for the first talk in this session on trauma scores and their relevance.
इसको बंद कर दो, ठीक है, और यहाँ से ओपन करो। अब देखो, इंटरेस्टिंग होता है।
Yeah, you can start. Good evening, everyone. As we all know, the management of open injury has changed over a period of time. Initially, it was an era where life was given more importance and we had an era of life preservation. Then we came for the limb preservation. Then the era came to prevent any sort of infection. And now the current era is to give as much functional restoration as much as possible. So there are various classification systems used for open injuries, namely Gustilo-Anderson, Ganga Hospital score, Mangled Extremity score. So Gustilo-Anderson classification, it was basically given by Gustilo and Anderson in 1976, where they divided wound into 3 types on the basis of size, less than 1 centimeter, 1 to 10, and more than 10 centimeter. And in the year 1987, they further divided the type 3 on the basis of the injury, type 3A with extensive soft tissue damage, but soft tissue coverage over the bone was adequate. 3B, where a secondary soft tissue procedure is necessary for the flap coverage. And type 3C, where limb survival is depending on the arterial injury repair. So if we see all these photos, we find all the 4 limbs will classify in type 3B. But the treatment option for all the 4 limbs are different. While the one on the extreme right is very difficult to salvage, is very difficult to provide a functional restoration. So there brings the limitation of this Gustilo-Anderson fracture. And they had a wide spectrum of injuries. They did not address the basic question of salvage and amputation. And the score doesn't evaluate the severity of injury to skin, bone, musculotendinous unit separately. Then Professor Rajshekharan sir et al. In year 2006, they devised a score for Ganga Hospital Open Injury Scoring System, where they provided importance to the 4 structures: skin, fascia, bone and joints, muscle and nerves, and comorbid condition. While skin, fascia, bone and joints and muscle scoring were given from 1 to 5, comorbid condition each has got 7 conditions, each has got 2 points. So if we look at the skin and soft tissue covering, score 1 is without skin loss, but the fracture site is at different level. 2 is at skin at the fracture site, but skin loss is not there. 3 is again fracture is at a different site, but there is a skin loss. And 4 is skin loss at the fracture. 5 is a circumferential skin loss exposing the whole bone. When we look at the functional units have partial injury to the musculotendinous unit, complete but repairable injuries. Then we have a loss of 1 unit or 1 compartment or complete section of a posterior tibial nerve. Then 2 or more compartment or subtotal amputations are graded 5. When we look at the bone scorings, anything simple, oblique with less than 50% of involvement is 1. More than 50% involvement is 2. Segmental fractures or periarticular fractures are 3. Bone loss with less than 4 centimeter is 4. And bone loss with more than 4 centimeter is 5. And each comorbid condition have been given at 2 points. There are 7, namely age more than 65 years, injury debridement interval, organic contamination, drug-dependent diabetes, injury severity score more than 25, hypotension, and another major injury to the same limb. All the components of the limb and cofactors are assessed separately, and together the individual score provides the guideline in the treatment. The total score helps to prognosticate between the salvage and the outcome. The guideline recommends that below 14 we have to attempt for salvage, 17 and above is the threshold for amputation, and 15 and 16 are the gray zone where it has to be decided on case-to-case basis depending on the patient factors, surgeon factors, skill of the team. There are other salvage predictive scores like MES, LSI, but all these scores are basically designed to assess the ischemic limbs with combined orthopedic and vascular injuries. Like the MES, also commonly used, especially outside India, it was devised in 1990 by Johansson, and it is basically consists of 4 parts where tissue injuries, shock, ischemia, and age are given importance. Anything age above 30 years is only given a score, and most important part of this component is ischemia. So when we look at the various cases, we have a case of a 24-year-old gentleman with a bilateral segmental soft tissue injury. And when we look at the Ganga score, we calculated post-debridement the score. Once both the sides fall into the gray zone of 16. Now the major question comes whether to go for an amputation on both sides or salvage one side and one side amputation or attempt a salvage on other side. So what was done was primary LRS fixation was given on both sides. A flap and secondary soft tissue cover was given. And gradually the bone was docked, and over a period of 2.5 years, the bone finally both sides united, giving a very good final functional outcome. The patient is, as you can see, playing football, cycling, and has been restored maximally to their normal life. Second case is of 71-year-old man who had an RTA, and there's a circumferential loss. He had a history of myocardial infarction 3 months ago. He's a diabetic, and the Ganga score was 15, while the MES score was just 5, which indicates that we should go and attempt a salvage first. But considering the patient factors, other factors, the choice of treatment was given as an amputation, and the patient was rehabilitated on that. So there comes whether the scoring systems like MES, Ganga Hospital score system can predict limb salvage or not. When we look at the threshold, like for Ganga score at the 14 and MES at 7, which is the desired amount for threshold, we find that MES is not specific. Both the scores are sensitive, but MES lacks specificity to predict the salvage. And the same paper which has denoted that the Ganga score was superior as compared to MES, LSI and other scores. Similarly, a recent study we have published in 2021, where we have found that despite increased cost, number of procedure and long duration of treatment in salvage, they have a better option and they have a better quality of life as compared to other amputation group. So to conclude, open injury must be treated with sound experience. Even minor fault in decision making can lead to secondary amputation. Firm guidelines and treatment protocols are necessary. Failed salvaged and salvaged but functionally useless limb and increase amputation, it will lead to increased secondary amputation. So scores are critical for us to able to predict successful salvage and ultimate functional outcome even at start of treatment. Thank you.
Now I call upon D.D. Tanna sir, who has most innovative method of presenting and making the very difficult topic look very easy. He will deliver talk on distal femur fractures.
Femur fracture. We all know antegrade nail in the distal femur, it moves about and it gives you this sort of an instability. So antegrade nail in a distal femur with 2 screws, which we conventionally do, is contraindicated as far as I am concerned. Diaphysial is a poor site for conventional 2 screws, and because the hold of the nail is very poor distally when the femur is expanding. As you can see it over here, the hold in the distal part of the femur is very poor of the nail. It is only moving around, and proximally it is good, but distally there is no hold at all. So antegrade nail with 2 screws is no into this junctional fracture of upper 2/3 and lower 1/3. This is a fracture, same fracture which I am talking about, and it goes into non-union. And probably if you have 3 or 4 screws distally, it may still function and if the nail is been put subchondrally, it is better. This is the one which is otherwise antegrade nail. Even if it is dynamized, it does not work and it goes into non-union. Nowadays, the nails which are available with 4 screws in differential direction in the distal femur, then the antegrade nail supposed to have a better chance of succeeding than the original 2 screws which we were talking about. Now, my expression is here, if in case there is a comminuted fracture or a long oblique fracture like this, I did the nailing and I felt it was not stable enough. So I added up a plate and ended up into a perfect healing. So I feel that if you're doing the antegrade nail in such a fracture which is not going to be stable because it is first is long oblique and it is at the junctional level, additional plate was most helpful for this fracture. Or as I strongly feel that distal femur nail is the ideal treatment for such a junctional fracture. If there is a junctional fracture, nowadays the distal femur nail with 4-5 screws distally is far more effective. The effect is not necessarily because it's 4-5 screws, but the distal femur nail has an excellent hole into the distal femur cortex. So it is the cortical hold which is there. That is the one which gives you the best chance, and there is good stability which is achieved. So even with these 2 screws, 1 screw and 1 bolt there, it can still give you a good result, and the things really held up. So good distal fixation, 3 factors. One is a good subchondral fit, which I feel is the most important. Multi-directional, multi-angle locking screws in a distal part or a spiral blade plate give good fixation. Main, I think, is a subchondral hole. So even if an ordinary nail with a subchondral hole, 2 or 3 screws, if you can put it, it has a much better chance to heal up than antegrade nail. At this level, exchange nailing is also not certain as the distal stabilization is poor. So even if this is a non-union, no question of an exchange nail or even a plain bone grafting. Needs an improved stabilization. So supplementary plate is a better. So here it is. As you can see, I have put in the supplementary plate and I have put in the medial graft. The medial graft which I am talking about, this is held up completely. So in this fracture, the non-union, and I have gone ahead and put in the medial graft with the accessory plate, the things have held up. This is what I call a medial graft. This is where the plating is done at the junction, at the level of the fracture. Anteriorly, I find it out in the Shyam and then made the incision and do a medial, anterior medial and posterior medial shingling. Shingling, I feel, is one of the most important part of a healing of a non-union, because just putting in the bone graft into the raw area, which is not ready to revascularize, the bone does not heal up. So that shingling is one of the major part of the healing. Now here it is the same situation, the nailing and the plating and the whole thing ultimately heals up. So nail and a plate is a very good combination for these junctional fractures. Primary treatment of the junctional fracture, my choice, first is distal femur nail. Second is antegrade nail, if you do it, then supplementary plate. 3-4 screws distally is the other choice, but definitely not an antegrade nail with 2 screws. Now I talk about the distal metaphyseal fracture, 51-year-old, short plate and a lateral graft. This is not a good surgery. This short plate, it does not heal. So that is what is needed for this sort of a thing. It is non-union, we see it again and again. And basically, for such fracture, the primary treatment is 11-12 hole plate, 3, 4, 5 screws there, nothing in between, and proximally alternate 3 or max is 4 screws. So this will give you a micro motion, and then you have a very good chance of healing of this fracture. This is the way in which it has to be executed. Lower down, you fix it up, and then higher up, you can do this, and this is the way it can heal up. And as you can see this fracture, and then you can get a good function there. So micromotion mode in a comminuted fracture is a treatment of choice. this is the way it completely heals up. But in a fracture like this, you can treat them with the leg screw, good leg screw, and then a short plate with that is a rigid fixation. Now, once you put in a leg screw, you don't need a micro motion mode. You can treat them in a rigid fixation, and then the fracture heals up perfectly well. Same thing is over here. This oblique fracture with the butterfly, put a leg screw and it heals up very well. When you put in a plate, there is a possibility of correcting the deformity if at all it is there by changing the plate slightly here and there. But you must see that the plate is right there into the anterior part of the femur so that it is straight there and it is not toggling, is not on the one side or the other side. These are the things before you start screwing, you must assess this. So leg and a short plate or a MIPO and a long plate with proximal alternate screws. Now Munnabai is confused. Now what to do? Some is talking about this plate and some is not talking about this plate. So my practice in a comminuted fracture, always a MIPO long plate, minimum 11-12 holes. And if it is a oblique fracture, always a leg screw and a rigid fixation. So I want to make it clear. Now in a MIPO, in a comminuted fracture, still there is no assurance that even if you put in a long plate in alternate holes, is going to heal up. And that's the reason why the safer thing to me, I work in a private setup most of the time now. So in that setup, I feel that if it is a badly comminuted fracture, one long plate and a one short plate on the medial side is the ideal situation, even primarily, without any problem. Now this fracture leg screw has helped it over there. Now this is 40 years back, where we didn't know the principle of a micro motion. But since this was so comminuted, this was treated by me with this sort of a blade plate with the screws distally and the screws proximally. And the whole thing heals up very well. So this is what you come by practice, that this is what you need, because in between that comminuted, you are never going to put the screws. Now the non-union of the distal femur. This sort of a non-union, this is a good case, I always show it. This is Shushruth Babulkar's case. This is a typical non-union which is there, and this gave way. Once it gave way and the plate broke, we have a basic thing is that if you do the revision for a non-union, it has to be a rigid fixation. But see, he has done a micro motion mode. He did this plate in the 3 screws here and only 2 screws there. And so beautifully, the whole thing heals up. I have never done this. I don't do this. But this Dr. Babulkar has done it, and he feels that few cases he has done it and he has succeeded. And to me, such a fracture is day one failure because you have done this. Now the surgeon grafted it. Such pressure, the grafting is not the issue. It is the instability and all. Your grafting also broke down. So I came into the picture. I did the double plating and the grafting, and the fracture heals up. So double plating in a distal femur is a much better option, much safer option, instead of going into the theories of whether you do this or a MIPO plate or this. In a comminuted fracture, do a double plate. In a oblique fracture, do a leg and a plate, rigid fixation. Again, into the lower 1/3 fracture, in a periprosthetic fracture. This is the one which goes into non-union. Is mainly because in a periprosthetic fracture, when we put in the plate, that plate holds only one screw distal. So this is not good enough. So in a periprosthetic fracture, which is below the flare of the femur, primarily double plating. No issues about it, no debate about it. Do a double plating, you will have a best fixation. So any periprosthetic plate below the flare of the femur, double plating. And here you can see the double plating solves the problem. So in conclusion, in conclusion, you got to see that the junctional level, distal femur nail or an additional plate, distal femur 11-hole minimum plate and a proximal alternate 3 screws. Non-union rigid double plate and a graft is a treatment of choice in a badly comminuted fracture. Thank you very much, friends.
Tanna sir, I had 2 questions. You highlighted the importance of the medial grafting. And in one of the slides, I saw that you had some additional incision anteriorly. So what is the great advantage of medial grafting?
In a non-union setup, no compromise. It is a double kill. It is an overkill. This is what I do. In that non-union setup, change the plate which is broken, lateral plate, medial unequal plate, both of them ending at a different level, and the medial graft after shingling. Shingling to me is the most important part of a non-union treatment, because you just put the graft in non-union. There is no zone which is going to revascularize the bone. So that shingling which you have done 2 inches above and 2 inches below, and put the graft in that zone, that is the one which is going to heal up.
An additional incision is required.
Please speak in the mic, I can't hear.
Additional incision is required for the medial grafting.
Yeah, medial, I have shown you that other one which is there. Anterior medial. Thank you.
Thank you, sir. To continue the series of trauma, we have Dr. Amit Ajgaonkar. After a nice siesta, Amit had a wonderful siesta. I was seeing it. He's going to speak about closed proximal tibia fractures. Amit, please. That is being practiced for a long time. We put a small
in a proximal tibia. If you have a coronal fracture, you have to go ahead and do a dual plating. We all know by now that there are all these fragments. Luo has classified this. So whenever you look at an X-ray of a proximal tibia, just put all your fragments, all your fractures in these fragments. The medial condyle is concave and the lateral condyle is convex. Precisely that is the reason when there is a medial condyle fracture, there is less comminution than the lateral condyle. Always remember that the lateral condyle in a tibia is more comminuted than the medial condyle. So the medial condyle needs to be fixed first. Whenever you have a CT, the CT will decide the position of the patient you have to start with, as well as the position of your plate. Now, if you have to put a plate over here, you have to go prone. If you have to put a plate over there, it is a figure of 4 position. You can do it in the supine position. And this part, the posterolateral part, you have to go prone because it is a Frosch approach. This is a supine position, figure of 4. It's very difficult to get a reduction in a figure of 4. You have to go between an oblique incision between the pes anserinus and the medial gastrocnemius. Identify your saphenous nerve. It goes along with the pes anserinus anteriorly. The medial head goes posteriorly. You are banged down on the posteromedial fragment. Posteromedial fragment, you will get a good reduction only in extension. You extend it, get a reduction, put a K-wire, flex it, and then put a plate. So whenever the knee is extended, you will get a good reduction. And that is a reduction. Use the plate. And this is the way you have to buttress the beak of the fragment so that you get a good reduction intra-articular also. You need not visualize the intra-articular portion. Once you have done this, only then you can proceed to the lateral side. Here, this is the beak which is buttressed by the plate, so that you are confirmed that there is an intra-articular reduction. If at all need be, and your intra-articular step is doubted, you have to go ahead and this is the step, if at all required to be done an intra-articular reduction, submeniscal arthrotomy. Hold the meniscus with a suture, reflect it, see for yourself or feel for yourself the intra-articular portion, and then reduce the intra-articular and then put the plate. Precisely, that's a posterolateral plate, posteromedial plate. After that, you do the the lateral plate, lateral raft plate. Lateral raft plate is always done later, otherwise those big screws buttressed plating as a complete fixation. Never hesitate to go posterior. If you have to go posterior, that is in the prone position, you can go in the prone position, absolute prone, keep your foot hanging down, you will get a reduction in extension. And these are the incisions. If you just want to do a Lobenhofer incision and it's just a medial plating, then use this, the inverted L. If you want to go ahead and do a lateral plating from a posteromedial incision, you have to extend it and an S type of an incision has to be taken. These are the structures we all know. Medial head of the gastrocnemius reflected. You get the posteromedial fragment. If at all you want a slightly more exposure, you just release the medial head of the gastrocnemius from the femoral condyle, and then you get a better exposure of the posteromedial fragment. Do a different window from the same incision. Reflect the lateral head of the gastrocnemius, and there you have space for the posterolateral fragment. A small space, but an oblique plate can be fitted over there. This is the case wherein it was a complicated posterior condyle, and we went ahead and we did this. This was the CT scan and this type of plating. From the posteromedial approach, we put this posterolateral plate, and this went down to a good healing in 3 months. Another case wherein there was just a small post-PCL avulsion type of a thing. This is the PCL avulsion, and we went down posteriorly, bang posteriorly, and got the PCL down and that fragment over there posteriorly. Frosch approach for the posterolateral fragment. You are bang on the medial border of the fibula, extend it up, identify the first common peroneal nerve, which is very easy to identify. Common peroneal nerve, once identified, go down, reflect your lateral head of the gastrocnemius, down you are on the popliteus. Reflect the popliteus, go down, and then there you are on the soleus. And there is this artery, the genicularis inferior artery, which needs to be identified. This is the genicularis inferior artery. Before plating it, just tie it and then cut it after tying the artery. You may land up on the anterior tibial if you're going more down. So a small plate only will fit on the posterolateral aspect. Though, very rarely, I've done a few cases, 7 to 8 cases such, but twice I've cut the anterior tibial, though I've not landed in much problems, and I put longer plates. This was the position. This is a plate. The foot is hanging down. You go bang on the medial border of the fibula, identify the common peroneal nerve there. Soleus is reflected. And then there the genicularis inferior, you will not be able to see here over very well. Inferior genicularis is ligated. It's cut a small space on the posterolateral aspect of the tibia and put a small plate. Look at this. Look at the CT. How bad is the posterolateral fragment? You have to go down, do a posterolateral plating, and there you've done a good job after elevating and putting a graft. This is another case wherein you have gone ahead and done this posterolateral with the same Frosch approach, lateral head, and the anterior tibial artery. You have seen it very properly, not ligated it, but saved it and put a small plate there posterolaterally. Overall, if you want to see, if you compare the acetabulum and the posterior tibia, the proximal tibia over ages we have been doing, patients have done well. It's a forgiving surgery probably. Today, in the last 10 years, we have identified the posterior fragments and we have started doing the posterior platings. The results are much more better. But in the acetabulum, you need to have a very good articular congruity, whereas in the tibia, you forget about the congruity. You may land up in a small step, but you have to have a good stability and alignment. Once you get a good stability and alignment, your results are fantastic in proximal tibia. Don't worry about that. So concluding, posterior, lateral, medial fragment needs identification on the CT first. Don't worry about the 3D. 3D CT is for the patients and their relatives because they understand it. For us, it's the 2D with axial cuts at the plafond level. Maintain the condylar width, articular congruity, the posterior slope. Do not hesitate to go posteriorly. Take some time, prone position, then again a supine position, but always do a good job. Thank you.
Thank you, Dr. Amit. May I now invite Dr. D.P. Bhushan, President Central Zone, for his deliberation on metaphyseal fractures tibia. आनंद जोशी दिख नहीं रहा है, अभी आया नहीं क्या?
This is known as sandwich technique. Dr. Tanna before, Dr. Tanna after me. Along with Amit Ajgaonkar. कहते हैं ना, तीतर के आगे दो तीतर, तीतर के पीछे दो तीतर. What is metaphysis? What is metaphysis? It's a part of long bone between diaphysis and epiphysis, obviously. And in adult tibia is the area of tibia which is between the articular area of the part of the tibia where the proximal widening of the medullary cavity starts, or the part of upper tibia that is 1.5 times, just multiply 1.5 to the articular surface and it goes down, and it's relatively rich blood supply. There is AOTA classification, as you all know. So the proximal tibia fracture, it is extra-articular fracture as against Dr. Ajgaonkar. It can be a wedge fracture. It can be a multifragmentary fracture due to high energy. It can be extending up to the articular surface due to excessive quadriceps action. But they have found that nailing or plating both are okay. Then if it is another paper, again the same conclusion. The meta-analysis shows that the study found similar union rate, as you can see. Malunion rate and infection rate for intramuscular nailing, intramedullary nailing and the plating, IMN was more patient satisfactory. Then the fatigue failure in extra-articular, it has also the same rate. Conclusion, for the fixation of the extra-articular, there is obviously the same result. Then intramedullary stabilization, extra. So there are many papers, as you can see. Now, we have options of intramedullary nailing, plates without angular stability. So the plate without angular stability, the indications are displaced or unstable fractures with good soft tissue envelope, or open fracture with good bone quality, and there is some compartment syndrome, so we do the fasciotomy along with it. Contraindication are short proximal fragment, we cannot fix it otherwise. Open fracture with severe contamination. There's an extreme osteoporosis, as we had already been talking, that it is not an indication for the small fragment plating. Advantage, stable fixation. Disadvantage, there's a good amount of soft tissue dissection. There is a devitalization of bone. There is surgical risk due to the large skin incisions and may necessitate a second plate to obtain the stability, as has already been told, as you can see here, or angular stable plate, that is less. It is used in open fracture, displaced, almost the same thing, excepting that if there is a very short fragment, we can use it. And contraindications are severe open and contaminated wound and medical comorbidity. The advantage, it is less traumatic for the soft tissue, the less. Buttress fixation of the metaphysis and bridge plating of the diaphysis extension, which will prevent subsequent displacement. It is stable, does not require anatomical reduction, and it is minimally invasive with the restoration of the correct mechanical axis, because it is usually pre-contoured. There is disadvantage, the risk of neural trauma with plating, because we are passing it subcutaneously sometimes and sometimes submuscular. It is technically demanding. Obviously, the cost, it requires intraoperative good imaging, good assistant, use of slightly complex instruments, and difficult to obtain and maintain the reduction, especially if the beak is coming all the time forward. As you can see here, it has been done by somebody. There is anterior angulation and there is a space despite so many screws. It has led to the procurvatum, joint spanning gastrocnemius forces. Once they pull the femur, they add to the anterior angulation. Unopposed pes and cernus acts there. Soft tissue problem and the open fractures are there. And mismatch of wider canal of proximal tibia, obviously. If we go for the intramedullary nailing, we have to go through the expert nail. Initially was not considered as a choice, but with a better implant, it is done. As you can see, there are different levels, different screws. And if it is proximal, you put more screws in the proximal fragment. If it is a distal fragment, as in 3, you put more screws and oblique screws, as told by Dr. Tanna in the distal femur. You have to put different screws, multiple directional in the distal fragment. But if it is in the center, you can use it as the simple nail. So, to address the deforming factor, nails with no locking screws, expert nail, number of locking screws, expert nail, it has a smoother Herzog bed. So, it can be put through the suprapatellar approach. There are 2 cortical coronal blue screws and there are golden screws. Golden screws are more for the proximal fragment. Medial shift of the entry point may injure anterior horn of the medial meniscus. As I was discussing with Amit, he said in 67% of the cases, there is anterior ligament. So if you go posteriorly, it will be damaged. And direction of guide wire to neutralize the deforming forces. As you can see, it is a suprapatellar attempt of giving the screws, giving the entry point, and then it should go parallel to the anterior border. So in the line of medullary cavity, medial to lateral tibial spine in AP view, wire bone all should be parallel to the anterior border in lateral view. This is very essential. Nailing in the semi-extended and with the help of a special sleeves may enter through the quadriceps, which has become popular recently. Reduction technique can be direct and indirect to restore the length of the tibia. Reduction of displacement, this is very important, maintain the alignment, correct the rotation. Large distractor can be used from the medial side so that if needed, you can plate from the lateral side. There can be blocking polar screw. As usually, we put the polar screw, we go towards the obliquity. So we go here on the lateral side. What I do, I put a long Steinman pin as the polar screw. And there is anterior angulation. While passing the guide wire, I pull it down so that the angulation is taken care of. And then we pass the nail. Implant used can be many things, but my preferred choice is a Steinman pin with a handle outside to use as a joystick. So the percutensor reduction technique, you can see it. Unicortical plate is another option. Anteriorly, you cut it. The area which is projected, fine, you do not touch it. The area which is behind, you just do the unicortical screws and the fracture, plumb, fits, then you can do the nailing. As you can see here, is a provisional plating. Many of us remove it just after putting the plate. There are other tricks. Nork has used the discarded large fragments. If there is a discarded large fragments, you autoclave it, put it, do the nailing, and just remove that. You see here, this is the case. Double plating was done, a long and a small plate. Again, extraarticular proximal tibia fracture nail all plate. Again, this paper also says that it goes all right. This is what I wish for all of you. Thanking Alok Agrawal and thanking all of you for this.
Thank you, Dr. Panak Bhushan. Dr. Panak Bhushan comes from the way of the Dhanbad, and he is having tremendous experience of dealing with trauma. And you know better Dhanbad is the land of Wasapur, so he has been tremendous experience of dealing all sorts of the trauma. Now I invite our professor D.D. Tanna, the master of his class. Dr. D.D. Tanna is welcome. He has set up a landmark in all the field of the trauma. Hello. And we follow him all the field. Hello. Dr. Tanna is welcome. He'll be delivering his lecture on the distal tibial fracture. Please.
Now, as you know, this fracture, short oblique fracture, nailed with the conventional nailing, 2 screws only, and stupidly the surgeon dynamized it, and as you can see, it doesn't work. So all of us know that it should be dynamized proximally, not distally, but still this oblique fracture is an unstable fracture. Now here this is oblique fracture in a distal 1/3. When you put in the nail does not have much hold on to the distal fragment, same thing as a femur. So the nail when you put in, it needs multiple multi-directional screws in order to get the stability. So this is the nail which you put in a transverse fracture. This was supposed to be a transverse fracture, but you can see here ultimately it was an oblique fracture and it auto-dynamized, and the whole thing can be easily treated with the plating. So the nailing is a good operation for the lower 1/3 tibia, provided you know exactly what you are going to do for that. Because unless and until you get this nailing perfectly well, it's not going to work it out. So this old nail, which was there with 2 screws, is not a good construct for the lower 1/3 of the tibia. If for a transverse fracture, any of the nail is all right. Even if that short nail which is there in the transverse fracture, it will work and the fracture will heal up. There is no issue at all whatsoever. The fracture will heal up. But in a long oblique fracture, in an oblique fracture like this, it has to be a nail which is the expert nail, which has 3-4 multi-directional screws. And hold the fracture with the clamp, and then put a nail, put in 2-3 screws, whatever you can put in, and the fibula plate, because these lower 1/3 tibias are always at the same level. You must stabilize the fibula. If you believe into the nail or a K-wire, you can put in, but that's not stable enough. My choice is a plate. You put in a plate because the fracture is at the same level. And in lower 1/3 tibia, plating of the fibula is a very useful thing. It will improve the stability. Now here you can see again a fracture which is comminuted intra-articular. You can fix it up, and then with the 2 screws you can really put in still the nail and can get away with it. So the nailing is much better for the skin problem, because the skin problem in lower 1/3, there is always going to be a skin issue. So the nailing, if you can execute it properly, it's a very good option. Option lower 1/3 oblique fracture tibia nailing is in oblique fracture, leg screw is definite surgery, neutralized with plate. Or if you're doing the nailing, even if there are many 2-3 screws you can put in a supplementary plate into this oblique fracture. And then you know that is going to be 100%. It can be an overkill. I agree about it, but then you know it very well that it will be a very good 100%. Now in a short oblique fracture like this, the option is you can put in a leg screw You can put in a plate and still the whole thing will heal up. Or here the leg screw, which you can put in, a thin plate which you put in, and still even this thin reconstruction plate with the leg screw is going to heal up, because he is not going to walk about. But the leg screw has to be perfectly executed so that the fracture line completely disappears and then neutralized with the plate. So all these are the reconstruction plate, as you can see, because on the medial side, the skin is again the issue, and that's the reason this is what you will have to do it. All these are the reconstruction plate, you can do it, but it has to be supported by a 2, 3, 4 leg screws depending upon this long oblique fracture. Now in this sort of a situation, such fractures can be nailed. Here I think I am very fond of putting in a leg screw and a nail. Here you can see I have put in the leg. If you go back, there is a long oblique. So I have put in the leg and then I have neutralized with the nail. So this also gives you a very good fixation. So the leg, once you have done, there is no need to put in 3, 4, 5 distal screws. Even 2 screws will be all right. This is the way you can handle it. So such fractures can be nailed, but the reduction is not always anatomical due to spiral nature. And these are the ones, as I mentioned, you can do it very well. Now, once you have done that, such a fracture, you can easily do a fracture which has been bypassed, and you can do the mippoplating. Mippoplating is not a very thick plate. So those who are not comfortable with the distal tibia nail, which is the first choice I feel into those situations, the nail with the many screws distally and the nail into the center of the tibia, that is the ideal situation. But those who are not comfortable, or even on the table you cannot get it perfectly well, do not hesitate, put in a leg screw in such fractures or put in a mippo plate, and still you will be able to really execute a perfect job, as you can see it here. That's the reason I think you got to be very, very clear on the table what you are planning to do. And once having executed it, and even if it is you to change the plan, there is no reason for any hesitation. You can get these things and perfect anatomy is restored, the good axis is restored. So nailing is though a much better option if you can get the nail into the center of the tibia. But quite often in a nailing, you may get up into the small deformities. Now into the non-union at this setup. This is the one where it was treated like this. And this is 1 year. You feel this is non-union or this is not non-union? Kemka, do you want to commit on this? Is this non-union? This is not non-union. 1 year. Why it is still appearing as if the callus has formed? There is angulation. Yeah, here you can see now, CT scan shows a non-union. And when I opened up, I realized why these things were there. The surgeon had put in this Indian hydroxyapatite, which was not getting absorbed. And that's the reason you were getting the picture as if it is not united. So this is the Pakka non-union. Now that non-union, you put in open up the medullary cavity, proximally, distally, remit from the fracture site itself, remit distally so that you will be in the center. And then once you have done that, everything is in the center. You can put in a nail and a plate and a graft, and this fracture heals up very well. So again, as I said, in a non-union setup, nail and a plate is a far better option, which you want to do it here. Now here was the case, comminuted fracture. Now you can see it is a short plate. Like a femur, if it was a long mippo plate, probably it would have held up. But it is a short plate here, so it did not heal up. So the grafted, and still it didn't heal up. The whole thing was completely 11 months after a bone grafting, 2 years walking pain, and then there was a Pakka non-union there. And that is the reason why you can see it here. This is the Pakka non-union which is there. So ultimately it was grafted intraosseous, and the shingling which was done, the shingling is the one which is most important. As I said, you do the shingling and then the plate and the things heal up. Now here, quite often, as I said, if the surgery of the nailing is not done perfectly well, you will get here everything is fine. But you see the nailing which is done by one of those nailers, and you can see the axis is not right. So the chances of deformity or a small axis deviation is very high into the nail, particularly if you are doing it, and even though you think it is in the center, and still it is so many 3-4 screws and the polar screw, but still the axis of the tibia is not all right. I feel here that the fibula with the nails, the K-wire, is again not a very good construct. It doesn't give you that good of stability. Now here there are so many meta-analysis which says intramedullary nailing and plating in infection rate favoring intramedullary nailing and malunion rate favoring plating. Because in the lower one-third tibia, if you do the plate, the skin problem is always the major issue. And that's the reason the nailing is the ideal thing. So aim at doing first the nailing, keeping the nail in the center, holding the fragment, putting the polar screws to keep the nail into the center, 4 screws distally, at least minimum 3 screws distally, and the fibula at the same level which is plated. So in conclusion, lower end of the tibia, the choice, nail keeping in the center and medullary cavity if needed, a polar screw. Multiple screws distally, always fixed fibula. Nail on a plate, my choice is a plate. Short oblique is unstable in nailing, but with multiple multi-directional screws, still it is okay. Leg and a plate is equally effective, but the skin problem is a major issue. In conclusion, short oblique fractures, leg screw is my treatment of choice, neutralized with the thin locking plate. And you otherwise you can do this sort of a plate, where the plate, if it is not medial, if it is lateral like this, then it does not create a skin problem. Thank you very much.
Thank you, sir. Thank you for a nice talk. And now I'll invite Dr. Anand Joshi. Dr. Anand Joshi is practicing at Raipur only, but he's having vast international experience. He had been in the UK for more than a decade, so he would be giving us so many tips and tricks here or there that will be beneficial. I welcome Dr. Joshi. His topic is calcaneum and talus fracture.
So just a show of hands. How many of us thinks that Essex Loper-City were 2 people? Anybody? No?
Essex and Loper-City were 2 different person, or it is a 1 person?
2 different people.
You asked the question, but we don't know the answer.
So we will have the answer in the last slide. Sorry? Yes, Essex Loper-City. That was a good one. He would have been happy. So I worked in the hospital where Peter Essex Loper-City worked. And some of the work he did phenomenal. I mean, he died at age of 35 or something, and did phenomenal work within those 35 years. He presented his treatise on calcaneal fractures, I think in March 51, and then he passed away the next month. Imagine if he was a wonderful pianist. His piano still stays there. Yeah, that's the last one. And he was an anesthetist by training. He was initially an anesthetist, went into army, was with the paratroopers, and Second World War was a wonderful place to see all this paratroopers breaking the calcaneus. So his first paper was on how should the paratroopers jump from the aeroplane. वो बैग लेके आओगे
सामने मगर यहाँ नहीं आ रहा है.
Okay, that's fine.
Oh, okay. Now I can move arrow.
All right.
Is the arrow. Now it has come to quickly. Now I will be able to.
Say play. Hopefully it does.
Yes, sir.
And then we go to the first slide, if possible, please.
Yes. My goodness. Why it has gone black now?
So I can speak from there. I can speak
No,
from there.
you can see here also.
All right.
But it goes back.
All right.
डुप्लीकेट किया आपने डुप्लीकेट किया यहाँ आ गया पर दूसरी स्लाइड जाती है ना
फर्स्ट स्लाइड पे कैसे
वापस
आएगा?
वो चला जाता है फर्स्ट साइड बार से आया ऐसे स्लाइड एरो ही नहीं बता रहा मेरा एरो चला जा रहा है
Dear friends, this is to just inform you that after the last two lectures, high tea has been arranged outside. So please enjoy the high tea before leaving and coming to the banquet. Thank you.
Thank you.
आप ही के साथ क्यों होता है बताइए?
Thanks a lot. We need a clever person. Right. So I'm Anand. I have had the privilege of being trained in UK, and we're going to talk about calcanei. What we plan to do is revisit the anatomy and briefly understand the assessments, the classifications, and focus more on how to make decisions, the goals and indications for operative treatment, describe the potential adverse outcomes. Right. So most commonly happen in young people. Common is broken tarsal bone. Most of these are high energy injuries, and 3/4 of this will have intra-articular involvement of the posterior facet. The rule of 10% will be open, 10% will be bilateral, and 10% will have an axial skeletal injury. So be careful about that. The calcaneum has 4 articular facets. The posterior facet supports the talar body and hence is important for weight bearing. It is the restoration of this facet which is important. The injury is not only osseous, it's a severe soft tissue injury. The skin envelope is critical in getting good results. So initial assessment should be towards that and to rule out compartment syndrome. Remember, the wrinkles have to appear before we think of surgery, unless there is a tongue-type fracture with soft tissue compromise or a diabetic tuberosity avulsion. Radiographic, initial x-rays give you enough information, including the lateral view showing all the articular facets and the morphology of the calcaneum, including the height and its length. That also provides the scene for drawing your bolus angle. Is it significant? So yes, Buckley's trial showed that all those who had an initial presentation of less than 0 degrees of bolus angle had nearly 6 times more likelihood of having a subtalar joint fusion in first 2 years. Therefore, it may probably correlate with better functional scores. At least 3 studies have said that. The axial view tells us about the tuberosity relationship and the lateral wall explosion, if any. The Brodens view is used during surgery to assess your posterior facet reconstruction. The CT scan is the workhorse. It tells you not only about surgical planning, but about the classification, the number of fragments the posterior facet has broken into, and into the geometry of this fractious lines. Peter Essex University classified these into 2 types, the joint depression side type, where the fragment was fractured, but was the posterior facet was fractured, but was away from the tuberosity, and the extra-articular tongue type, which was a more challenging fracture to manage. Sanders classification, is it of significance to us? Yes, it helps us in planning surgery, and we know that type 3s are 4 times more likely to need subtalar fusion as compared to Sanders 2, and hence it has got a good prognostic value too. So whom shall we stay away from surgery? The non-displaced ones, the extra-articular ones, the minimally displaced ones, anterior process fractures, less than 25% involvement. Major treatment considerations include the patient factors, the personality of the injury, and surgeon's training. So how does that correlate? As early as 1952, Essex-Loprasti showed that 40% of patients above 50 had an unacceptable outcome. That study was then continued, and when subgroup analysis was done, it was found out that above 65, the outcomes were similar if the comorbidities were not present. So there was something to do with these comorbidities. What were these comorbidities? Insulin-dependent diabetes, peripheral vascular disease, neuropathies, end-stage renal disease, and congestive heart failure. So all others would probably have equally good results, which was confirmed in 2010 again. Socially, you want to stay away from the smoker and the drunkard and the guy whom you cannot rely upon. These are the guys best left alone on the streets. A bigger chunk of people who sustain the injury at work are the difficult ones to manage. High degree of soft tissue injury, higher degree of infection, higher degree of osseous injuries, poor functional results with need to fuse. Surgeon factors, these are very niche areas and really have a steep learning curve. It is challenging to treat them operatively, and sometimes surgical complications may be worse than the outcomes of non-operative treatment. So whom do we fix? We fix everyone who has a displaced intra-articular fracture, is an active patient, and has no comorbidities. We know that those who have work compensation would probably do worse. Anywhere where the ORIF has better results than non-operative outcomes, we use it, even though knowing that they will need subtalar arthrodesis in the future. What are the goals of the treatment? To restore articular congruency so that the subtalar arthritis does not happen, restoration of morphology so that the person can wear normal shoes, and to prevent the talus from settling down and creating an anterior ankle impingement. What can we use? We can use external fixators. A medial frame can be used very well to address lateral sided skin. It can be used even to correct the deformities and can be the definitive treatment. The extensile lateral approach is the workhorse of treatment. It permits direct reduction of the fractures. It's easy to address the lateral lateral blowout. Challenge is wound healing. So you need to wait. You need to give soft tissues chance to resuscitate. You create a full thickness subperiosteal flap, protecting the nerve. You do not touch the flap itself. You just retract it with K wires. And the reduction goes from anterior to posterior. You first reduce the tuberosity, anterior tuberosity to sustentaculum. Then you lever up the tuberosity itself. And then you reduce the tuberosity to the sustentaculum. And reduce the posterior facet directly under the talus. The plate works as a washer for the screws. You have these areas where you will get a good hold in the screws. And when you close it with periosteal suture on the dorsal flap. You do not go through the flap at all. And this is very, very important. You elevate it for 48 hours. The newer approaches have been to use the Cyrus tarsi approach to address the posterior facet. It permits direct reduction of the anterior process too. It is difficult to use after a time interval because everything starts gelling up. You cannot put bigger implants from that edge. You use your 3 screws, one in the medial wall, one in the lateral wall, and the articular support screw, which is like the stand you use in a scooter, then a single stand, it supports. Primary subtalar arthrodesis has 2 scenarios, one acute and one late. We know that even in those who have a late subpterojoint fusion, if they have had an initial fixation and the calcaneal morphology has been better restored, then they would do well in the long run. What is the evidence? So there have been 2 or 3 meta-analyses till now. One of them was very much against surgery, but 2 of them have said that the open reduction internal fixation restores structure and therefore improves foot function. They are more likely to resume their pre-injury levels, but has got higher risk of complications, and hence the soft tissue resuscitation is of vital importance. Summary, they can be extremely debilitating injuries, especially in young people who can be out of job for long durations. You need a thorough radiographic assessments, a low threshold for imaging the spine if necessary. Operative indications should be arrived at carefully after judging the patient's comorbidities, his ability to engage in the rehab, and his keenness to get back to work. First principle, remember, do no harm. And this is Peter Essex Lopresti, the man I spoke about. He bought the treatment from the Cotton's mallet to the K-wires, and from the K-wires to the plating has taken about 15 years. He represented a big jump in the management of calcaneal fractures. And even he said that those who are going to work are not going to get back to work. So that is one area we haven't been able to win over. Thanks a lot, Alok, Harsh, and all the team for giving me this chance. And I shall close my talk over here. Thank you.
Thank you, Dr. Anand Joshi. He has completed his lecture well in time. So we have got 2 minutes. Any question? 1 or 2 questions? We can give your reply. Anybody is having any query? Okay, sir. Thank you.
And I was supposed to speak on talus as well. The talus is going to be covered tomorrow by Mr. Asati. Please make your way to the hall B if I'm not wrong. 3 o'clock. Thank you.
Now I invite Dr. Amit Ajgaonkar, another dynamic surgeon who is coming from the Mumbai, and he is not new face to our Chhattisgarh. He has been visiting frequently, and we know his capacity, capability, and everything. You are welcome. Please, sir, proceed. Crush injury, foot.
As orthopedic surgeons, most of the things have been discussed. The Ganga score and all those things. What we need to know is different. How to go about with a crush injury of the foot. After showing a few slides initially, I will have a small interactive session. What is a crush injury? It is a compression of the body parts causing localized muscle and nerve damage. Muscle, because we all know that muscle damage can cause what? Myoglobinuria. So you have to take care about the urine part of it, the kidneys, and the electrolytes. Whenever you get crush injuries, what I feel is never just dress this and keep it aside to be done on the next day. The surgeon seeing first should start debridement wherever it is. Probably in the operation theater, possibly in the operation theater, and spend, probably the senior most should do it, and spend at least 1 hour on doing the debridement. Remove everything what is dead, what you see black, remove everything, whether it is a nerve, artery, muscle, bone. So remove everything and use saline bottles, use pulse lavage, use everything, whatever is needed, and clean, and the tissue should be white, clean. We use vac if needed. The heel pad avulsions. Heel pad avulsions are different. I would like to ask heel pad avulsions. How do you treat, and what is a heel pad avulsion? What is a salvageable heel pad avulsion? Anyway, how to treat a heel pad avulsion? Sir, Bhushan sir, any idea? you must be getting this heel pad avulsion. How would you treat? Go ahead with treating it. Oh, correct. Yeah. So the added injuries should be noted, and the wound can heal, would heal, not with exact approximation. It would heal with secondary intention. Always keep in mind that there would be fluid retention in the extremities, myoglobinuria, electrolytes should be taken care of, and secondary complications noted. Primarily survey the patient, stabilize the patient, resuscitate if needed. Secondary survey is also needed. Diagnose through examination. Treat the systemic effects of compartment syndrome similar to crush injury, and further on. Anchorage of partial avulsion of the heel pad is done with multiple K-wires. Never leave heel pads just sutured. If you have a heel pad avulsion, just put K-wires, multiple K-wires, and don't suture the wound. Just don't suture the wound, it will always heal. If you have a nice heel pad which has got an attachment distally and either medially or laterally, you have a salvageable heel pad. Just put multiple K-wires, and with multiple K-wires, it is going to heal, and you will have a very good result. Another heel pad avulsion, if needed, you have to add a VAC. Compartment syndromes, if it's a closed degloving injury. If it's a closed degloving injury, identify it. Compartment syndrome needs to be tackled. If it needs to be tackled, you can do it in the OPD also. This is a small compartment syndrome. You have to just cut on the second metatarsal and the fourth metatarsal, and if needed on the medial side of the heel pad. So once you give those cuts, you go down up to the bone, go down on the plantar aspect and release the compartments. Don't suture it. Just give a nice wash. Even if it is done in the OPD, do it. Don't do anything. Just take 2 nicks and do a nice release of your compartments. Once you release the compartment, that is how the compartments should be released. You go down on both the sides of the metatarsals, go down on the plantar aspect and release it. Keep it open. It will heal by secondary intention, no problem. What will you do for this? Alok, what would you do for this? A 23-year-old male, a crushed injury, a complete crush probably, has come to me, and aggressive debridement. Yeah. So you will all go for a salvage? No? Dr. Joshi? So? Back to work as soon as possible. Yes, true. I thought once you amputate, give him a prosthesis, he's back to work as soon as possible. You're absolutely right. Today, 2 to 3 years down the line, I feel so. But the thing is that, Indian patients, if they want to go to the washroom at house, if they want to just go outside for a stroll, they'll always have to immediately wear their prosthesis. In the night, if they want to go to the washroom, how are they going to travel to the washroom? I thought that let me try. Let me not give up. So what we did is we took the patient. In fact, it was a Sunday evening and I was alone in the operation theatre. I took around 4 to 5 hours debriding it. Debrided. You should have, I would like to tell you that this type of a tray is very useful. You should have this type of a tray where you debride the patients very well. You should always use a pulse lavage. And these things should be there in the operation theatre. And this was the result of that crush injury of the foot. And this got infected. We had put multiple K-wires on the heel pad also with maggots, which I was happy that there were maggots. The maggots destroyed all the necrotic tissue, and this was the follow-up. His first metatarsal was necrotic. We had to remove it. And this is a follow-up. This is a follow-up. Now, this is nearly 6 months down the line. There is a lot of swelling, multiple K-wires inside. The patient was pretty okay. And there was a void over there with the first metatarsal removed. And this was his X-ray. We replaced that first metatarsal with the fibula. We put a graft over there so that the varus was prevented. And ultimately, 3 months post-op, this was the patient. So this was the patient. If you are positive, the patients, you can give good results, but you should be firm in your mind that your debridement, the first debridement is very important. If you use whatever you want to, you should have everything ready on table. This is a patient walking after around whatever 6 months, 7 months, 3 months. And this accident had occurred when he was riding his bike, and another dumper went over his foot and braked on the foot. So that was he. Summarizing, I would like to tell these are the few points we have to remember. The senior-most surgeon should do the surgery of debridement. Don't consider it as a small surgery or surgery for the juniors. At least 15 and more saline bottles should be used. If you are using less, then you have not done a good debridement. Pulse lavage, VAC should always be used. Plastic surgeon on day 1 helps. And never give up. Thank you.
Thank you, Dr. Amit, for showing such a beautiful slide and good work. This is how this session ends here, and we'll proceed for the next. Thank you.
Thank you, sir. With this, we finish our session for the day. And I'd like to request Professor Alok Agrawal, sir, to present memento to our chairpersons.
So, dear friends, with this, we are at the end of today's National Orthopedic Trauma Symposium as a part of CGI-Con. This is the first time, on the desire of all the people, we decided to hold a whole one-day symposium. Now, the people all here have to keep sitting here for the general body meeting, and the people who are hungry, they can go out, eat and come fast for the high tea. To summarize, we started with what is polytrauma. We went to a pelvic session, to a spine session. We went to the upper limb, lower limb, hip and pelvis, and we had our orations. I feel this has been a very useful day, and I'm thankful on behalf of CGI-Con to the National Academy of Medical Sciences, New India, for giving a financial grant for today's final program. Thank you. May I request the office bearers of CGIOA now? Zoom band kar do. May I request the people from the CGIOA to come on the dais? Dr. Hemant Chatterjee, sir. Dr. Prashant Dwivedi, members of CGIOA to come on the dais. And there is